introduce our speaker, Dr. Bhaskar Thakuria, sir, who will talk about the topic Syncope, a practical approach for a physician. We kindly invite sir to begin the talk.
A very good morning to one and all present over here. We have assembled after our exhaustive banquet and a full day session yesterday and day before yesterday. So definitely the first session will have very less number of attendees. Anyways, we'll have to start on time. So I'm very thankful to the organizing committee for choosing me to deliberate on a topic which is a very commonplace topic for we physicians, and we uh, encounter patients with syncope right from our days of post graduation, or maybe from our days after we delve into the professional life after doing MBBS, and it remains a commonplace occurrence or commonplace disease or presentation till late in our life. So we need to know about syncope, though we have discussed it time and again in many different conferences and classes, but I think it was a apt decision on the part of the organizing committee to include this syncope again. So we will be revisiting the topic of syncope today. I hope I'll be able to do justice to the topic. As per 2018 ESA guideline, syncope is defined as transient loss of consciousness due to cerebral hypoperfusion. And this transient loss of consciousness has got three main attributes. It is characterized by a rapid onset, a short duration, and there is spontaneous complete recovery. The group of disorders which is labeled as transient loss of consciousness is defined by a state of either real or apparent loss of consciousness, which is characterized by amnesia for a period. There is abnormal motor control or loss of motor control, to be precise, associated with loss of responsiveness and a short duration. Because of the kind of presentation that syncope has, it forms a commonplace differential diagnosis in many disorders that we encounter in daily practice. The two main group of TLOC as per the classification are traumatic and non-traumatic ones, and we definitely, the topic of our discussion is the non-traumatic transient loss of consciousness. We also do use another term quite often, which is called a pre-syncope or near syncope. This term we use for a constellation of signs and more specifically symptoms, which forms part of the prodrome of a syncope, classical syncope, but then this prodrome does not culminate into loss of consciousness. The syncope, therefore, the definition has got five important components. The most critical element is the loss of consciousness, which is always complete. There is loss of voluntary control, which is inherent in the loss of consciousness, and so also the recovery, which is spontaneous, complete, and usually prompt. The onset is relatively rapid, not maybe instantaneous, and it is usually preceded by prodromal symptoms, and the underlying mechanism, as I already said, is global cerebral hypoperfusion. The non-traumatic transient loss of consciousness again is subdivided into four groups. The first group is the topic of our discussion, that is syncope. There are the other commonplace causes and diseases which falls into second group of epileptic seizures, then psychogenic causes, and definitely the least common but definitely not the least important ones, which are being grouped under rare causes. The central point in the pathophysiology is low blood pressure causing decrease in global cerebral blood flow. It has to be global. It cannot be localized. And as we all know, systemic blood pressure is a product of cardiac output and total peripheral vascular resistance. Different etiologies that causes syncope can operate either by causing a decrease in cardiac output or by decreasing total peripheral vascular resistance, or it could be affecting both of the mechanisms in varied proportions. Then syncope again is regrouped, subclassified rather, into three major groups. Syncope that occurs because of reflex mediated syncope. This forms the major chunk of the disorders, around 60 to 65% in different group of study sets. And the major diagnosis under this, which we all have experience in during very different times of our life, is the vasovagal syncope. And then there are other causes as shown over here. The second group are the syncope that occurs because of orthostatic hypotension. And the third group, and the most important group, though it is less in percentage, is the cardiac syncope. With regard to pathophysiology, in a gist, this is being shown in the circular diagram over here. The reflex syncope either operates through a vasodepressor mechanism or a cardio-inhibitory mechanism because of inappropriate reflex operating in the patient due to during varied circumstances, which ultimately leads to low BP and low cerebral perfusion. Whereas the causes that are grouped under orthostatic hypotension occurs finally because of the autonomic nervous system failure. This autonomic nervous system failure can occur because of primary or secondary diseases of the autonomic nervous system, structural disorders. It can also occur because of drug, which forms a major group of these disorders. And thirdly, are as shown over here is a subgroup of inadequate venous return, which can finally causes low blood pressure and low cerebral perfusion. Whereas the third group, the cardiac syncope, occurs either because of a arrhythmic disorder or because of a structural cardiac disease. When we approach a patient of syncope, we need to take there are 4 steps in the diagnostic approach to a patient of syncope. The first step is differentiating syncope from other causes of loss of consciousness, as I have already shown. The second step is the initial evaluation of the patient. Third is the final and the second step evaluation for appropriate final diagnosis. And fourth is the referral practice, where unexplained syncope are further investigated, evaluated with specialized tests. With regard to differentiating syncope from non-syncopal conditions, 4 important questions need to be answered in each and every patient in the first step. And these questions can be answered only if a detailed history from the patient, if possible, and also very importantly from an eyewitness if it is taken. Taking a history, proper history, should be given the most importance to, because many a time there does not remain any clinical signs in the patients who presents with syncope. So history taking should be is time consuming to arrive at a successful diagnosis, but nevertheless it gives us a lot of information and it's very important for a successful diagnosis. The 4 questions that needs to be answered in each and every patient whenever we deal with syncope are as shown over here. Firstly, we need to know, was the loss of consciousness complete or not? Secondly, whether the loss of consciousness was transient with rapid onset and short duration. And thirdly, did the patient recover spontaneously, completely, and without sequelae? Should be our third aim to answer. And fourthly, did the patient lose postural tone? These are very, very, very important to be answered in each and every patient. And if the answer to all these questions is yes, then only we can relatively surely we can say that the patient in question could be syncope, and not because this his transient loss of consciousness is not because of some other confounding factors. But then if the answer to any of these 4 questions is not yes, but or else if we cannot relatively ascertain the answer to the circumstances of this question, then we will have to delve further into the confounding diagnosis. With regard to this, there are many conditions which can present as syncope, but actually they are not. So the causes are many, spreading from different types of seizures to non TLOC without fall, then cataplexy, intracranial hemorrhages, notably the subarachnoid and intracerebral hemorrhage, TIAs, metabolic disorders, and intoxication. So we'll have to be very diligent about answering all those 4 questions. Then, as I said, the first step is to differentiate seizure from other causes, and the most important of all is to differentiate seizures and syncope. And with regard to this, we have been revisiting this time and again during our clinical teachings of postgraduate, during our postgraduate learning period, then during our further professional period. And then I'll have to admit that many a time we falter because we do not give due importance to all the 4 questions that I have just now shown you people. And for ease of differentiating between these two important disorders, but two important but different disorders, I have enumerated the differences shown over here into 3 groups. The events that that happens before the transient loss of consciousness, event that happens during the episode, and event that happens after. If we give due importance to all these 3 group of important points, then we will be able to differentiate between seizure and syncope relatively surely. The next step, if after we have known that yes, this person is syncope, the next step in management of the patient is to know whether the patient has got such kind of disorders where the diagnosis carries a ominous diagnosis could be entertained in this patient. And here we should give importance to the red flag signs. The red flag signs are many, like chest pain, dyspnea, abdominal pain, fall, then certain focal neurological signs, and so on and so on. And then there are certain other important points to note also, which has been shown over here. And I'll not go into details of the ECG finding, which are also very important in diagnosis of the patient. Then we need to regroup further the syncope into non-cardiac and cardiac syncope. Those people we have ascertained as non-cardiac syncope, they are to be put into 2 second step investigation, important investigation for each of the patient. These are the carotid sinus massage and orthostatic challenge tests. If put together, they can pinpoint the diagnosis in almost 98% of the patients. The orthostatic challenge tests that can be undertaken in this group of patients are active challenge test, tilt test, Valsalva maneuver, deep breathing test, and ambulatory blood pressure monitoring. The method and the results interpretation is shown over here. Whereas the people who are having a cardiac syncope, they are to be put for specialized testing, which is beyond the scope of this lecture. These are to be done in a specialized center with facility for all these tests enumerated over here, like telemetry, then Holter monitoring, then EPS. All those comes in handy in final diagnosis. With regard to treatment, I'll not go into detail for paucity of time. Then what I'd like to go through is, in summary, at last, I would like to say that evaluation of and treatment of syncope is very challenging for sure, and a multidisciplinary approach comes in handy. The physician must carefully consider whether the detected abnormalities are compatible with clinical circumstances, and the goal in every case should be to determine the cause with sufficient confidence. Thank you for, and I'm very lucky to represent my institution in this in front of this gathering. Thank you.
Excellent presentation, Dr. Thakuria. And you have done justice to the subject because these many times in clinical practice, so we have come across all this sort of things, the syncope, but differential diagnosis along with our seizures and cardiac causes, these are also important. So clinically, we have to suspect and we have to go for the test. Thank you. Over to Dr. Robertson.
Thank you very much, sir, for your wonderful deliberation. And syncope is a very commonly encountered in our daily day-to-day practice. And we like the audience to ask 2 questions.
I rather like to have some comments rather than questions.
Do you consider pre-syncope as different as or as a as syncope?
Sir, pre-syncope is not exactly different. It is actually the same pathophysiological process that happens, but then the whole process gets aborted prematurely, because of which it's an incomplete one.
That's the point. We should not neglect pre-syncope.
Yes.
If you follow the patients for 1 year, even both in the pre-syncope group, there is a paper published in New England of Medicine. Those who were suffering from pre-syncope and those who were suffering from syncope, 1 year mortality in this group of patients is 18 point, almost 18%. Only point variation is there. So we should not neglect syncope.
Definitely.
And yeah, another thing I like to say is that because on only three types of syncopes are there. One is your that is reflex syncopes, that always have a prodrome.
Yes.
But so we have to ask for any prodrome in a patient's of syncope. If there is prodrome is there, if there is one thing, there is loss of blood pressure as well as loss of pulse rate.
Yes.
Pulse rate will be decreasing.
Bradycardia.
The bradycardia will be there. So this is a reflex syncope.
Yes.
Whatever that, maybe a carotid hypersensitivity, maybe because of the carotid hypersensitivity, they all behave in a, because these are the only findings: fall of blood pressure, loss of consciousness, and spontaneous recovery with bradycardia. But in your orthostatic group, so you have to look for the BP. There is definite evidence of orthostatic. There is loss of systolic blood pressure after 5 minutes supine. If you on standing, you measure the blood pressure. There is always fall of blood pressure in the orthostatic syncope group. And at the same time, if there is volume depression, you will get tachycardia in that group of. That's the differentiation point. And the most important is the cardiac syncope, which can kill your patient. There are only two conditions, either because of obstruction or because of the arrhythmia.
Yes.
Those who have got obstructive, if the patient has got no prodrome, if the patient does not have any prodrome, always think of cardiac.
Yes, sir.
And the second thing, about the cardiac syncope is that if the syncope occurring after exercise,
yes,
you have to. So minimum investigation in each and every patient, and this ECG, because that will not cost you much. So though it is group is less, and there are only 4 conditions which can kill your patient even in the arrhythmia group also. Not to speak of the, because everybody will find murmurs and exercise induced syncope in a patient's of cardiac syncope. So in ECG, at least you look for the Brugada syndromes, because there is always a schedule type or cove type of. If you look at the V1, V2, you will see either ST elevation in a V1 and V2, that the cove or schedule pattern. That is that Brugada is a autosomal dominant, mainly affecting the family. If a patient has got a family history of syncope, we should not neglect that group of patients. And the SOCM, there, if you like dagger like Q wave in any leads, mainly in the lateral leads, that is suggestive of SOCM, and arrhythmogenic right ventricular valve, because of the fibrofatty region. We have to look for all these things. And though we talk of syncope in other only ventricular tachycardia, otherwise ventricular fibrillation, and patient will ultimately collapse without So we have to rule out ventricular tachycardia. And the AV node, mainly the AV node, those who have got Mobis type 2 and the third degree heart block, and the SA node. If there is AV node disease, we always easy to diagnose because of the findings you will have in the ECG. But the SNE disease, sometimes there may be 6 sinuses. You have taken the ECG, you have not got any findings. Still, they have. You have to look for other investigation, halter, even some, if required, even the electrophysiological examination.
Yes.
Thank you so much, sir, for your wonderful insights. I think we'll wind up this first talk because we are lacking behind the time. So thank you so much, everyone.
Thank you for your highly valuable and clinically relevant session. We shall now proceed to our next session. I'm delighted to introduce our chairpersons for this session, Dr. Sadiqul Islam, Dr. Manisha Deka, and Dr. Parakumar Das. I request you to kindly grace the dais. I take great pleasure in introducing our speaker for this session, Dr. Bharat Bhushan Kukreja sir, who will talk about the topic clinical data insights on non-communicable diseases based on analysis of 1,000 patients from a clinical setup.
Good morning to all. So, Dr. Kukreja sir, who is known to all, a senior physician from Guwahati, he will be delivering the talk on clinical data insights on non-communicable disease based on analysis of 1,000 patients from a critical setting. So, may I ask sir to please start his talk?
Thank you, honorable chairpersons, distinguished faculty members, and friends. I begin with my sincere thanks to the Chairman Scientific Committee and the organizing secretary, Arup Chaudhary and Kyor, for giving me this, I think, a rare opportunity that these 3 days, all the 3 days, I have been made to share the platform. This was not a scheduled talk, but while we were having some relaxation, he said, come on, make your presentation. So here I am. What I'm going to do, this presentation is basically to share with you, to make you aware how much potential each one of you have. If I can do it, every one of you here can do it. What I have done is last 5 years data of non-communicable diseases, which I have seen in my clinic. I thought, let me analyze them. So this study is the clinical insights into the NCDs based on the 1,000 patients which I have seen in my clinic. Okay. So collecting and analyzing clinical data in real world practice provides critical insights into patient populations and the disease patterns. We can identify the disease prevalence, uncover the comorbidities. Many a time examining one patient for a problem, you realize there are so many other things. So if you look at your record, you know it, and then assess the control patterns. So what I want to tell you is that clinical data reveals real world insights into the non-communicable disease burden and control that informs the evidence-based clinical decision making. The objectives were to determine the prevalence of major non-communicable diseases. I took only 4: type 2 diabetes, hypertension, dyslipidemia, and hypothyroidism. Then look at the study comorbidity distribution, analyze the NCD prevalence by sex and age group, and assess the HbA1c control among the diabetic patients. So in the following cartoons, I will show you the results. Now here is the overall NCD prevalence. Type 2 diabetes dominates the NCD profile at 77.3%. Dyslipidemia is 48.5. Hypertension and hypothyroidism 21 and 20% respectively. So type 2 diabetes dominates the NCD profile, followed by dyslipidemia. This highlights the need for targeted intervention strategies. And this is the comorbidities. Look at this slide. The last two, 15 plus 10, 25% of the people have more than 2 NCDs existing at the time when they are in your clinic. 2/3 of them are those who have got either one or more than one. So majority have 1 to 2 non-communicable diseases. The frequent clustering of NCDs highlights the need for coordinated care models that addresses multiple conditions and simultaneously. The analysis has shown you what I am saying. Now, if you look at the gender distribution, male predominates at 70% and the female are 30%. And what are the key insights? Nearly 3:1 ratio between male and female, and important consideration for NCD analysis. If you look at the sex distribution, in male, higher type 2 diabetes rates, 80% versus 70% in women. Higher dyslipidemia in male, 51% versus 41%. In female, it shows higher prevalence of hypothyroidism. And in them, it is twice more than men. Now, here is the age group analysis. Type 2 diabetes prevalence increases steadily with age, reaching highest with age, with 60 plus age group. Hypertension, the red line, shows similar pattern to type 2 diabetes. Dyslipidemia peaks in the middle age. This is dyslipidemia between the age group 45 to 59, and hypothyroidism didn't show, or it shows fluctuations across the age groups. Now, HbA1c control, 65% of diabetic patients have very poorly controlled diabetes. It's only 11% of the patients who have controlled diabetics. So this alarmingly high proportion requires immediate intervention and improved management strategies. So this gives me an enough of warning that I need to have improved tools, improve application of doing better control. So what are the key insights? The key data insights: disease dominance, type 2 diabetes, 77%, dyslipidemia, almost 50%, dominate the NCD profile. Comorbidity clustering, majority have 1 to 2 non-communicable diseases. There are multiple comorbidities which highlight the need for integrated care. The sex difference: male have higher metabolic disorders, females have a higher incidence of hypothyroidism. And the clinical application is detecting care gaps, identifying untreated conditions and uncontrolled diseases to target interventions. Improving screening. Data-driven approach helps in optimizing screening protocols based on actual prevalence patterns. The attendant accompanying the patient is a very, very potent person to be screened. And that's a study which I'm doing now, where I have been able to pick up many people who have been accompanying their patients. And you can always make preventive strategies. So clinical data analysis transforms raw numbers into actionable insights for improved patient care. How do we utilize clinical data for healthcare improvement? Data collection is from electronic records. Many of you have electronic records. From registry creation, I have created this from my registry, and of course from periodic analysis. And what they mean to us: patient management, it identifies the gaps in care, improves screening, designs preventive strategies, health policy, and community interventions. So let me conclude and tell you the future directions. The true power of clinical data lies in its ability to transform insight into action. The clinical data analysis transforms raw information into actionable insights, driving evidence based healthcare decisions. The key conclusions while analyzing these 1,000 patients were that NCD patterns: type 2 diabetes dominates NCD profiles with high prevalence across the demographics. Integrated care, I could see the gap in care. The future directions are predictive analytics, quality improvement, and population health. So I need not go into what the meaning of these words are. It's all self-understanding. So this is what information I could gather by analyzing this 1,000 people. Let me confess my drawbacks. Since this was a afterthought, there are few data which could not be analyzed because I did not record them in my record sheet. So like tobacco use, sleep patterns, stress levels, dietary habits, alcohol use, and of course, in many of the patients forgot to write their height, weight, occupation. And so these are the uh, flaws in this collected data. But overall, I know that in the last 5 years, what I have done, what is the pattern of people who come to me, how do I prepare myself, and I can contribute this. And if all of us join together, we were talking about AI yesterday in the debate, and we all know that AI will give you the data you put in. So where the data will come from our clinics. So if we combine together, feed it into the central data bank, probably we will have a better understanding of our scenario in our country. So I must thank my patients and of course my data team. The collaborative research leads to improved patient outcomes. And with this, I profusely thank you and once again thank the scientific committee for giving me this opportunity to share with you data which is from my small clinic in Guwahati. Thank you for your kind attention. Thank you, chairpersons.
Thank you so much sir, for such an enlightening talk, emphasizing on data collection and use of AI, and of course, using it for the improvement of our, in which direction should we proceed? So, if there are any questions, we can take up one or two questions on that. So, then we wind up if there are no more questions. Thank you.
Thank you.
Thank you for your enriching and highly valuable talk. Up next, we have a panel discussion. It's my privilege to introduce our chairpersons for this session, Dr. Nitya Gogoi, Dr. Bhabani Bhuya, and Dr. Apurba Rabha. I request you to kindly preside over the session. And now may I invite our esteemed panel moderator for this session, Dr. Diganta Das sir, DM Rheumatology. And the panelists for this session are Dr. Chitralekha Borua, Dr. MP Das, Dr. Rebecca Marak, and Dr. Daisy Doley. We warmly welcome you to the stage.
Good morning to all. So we'll be discussing 4 cases, very interesting cases in rheumatology in this session. So before organizing the case actually, so I searched one thing in Google, what common people mean by the word rheumatological diseases, and it's showing all arthritis, nothing else other than arthritis in Google in rheumatology. So actually it is not like that. Rheumatological diseases can have involvement of all the system in our body and can land it up in different specialty as well as the internal medicine department. Among the those patients who are basically undiagnosed in department of medicine with multiple system involvement, if we look into them very carefully, they came out to be a rheumatological disease or sometimes endocrinological disease. So rheumatology is nothing but internal medicine plus. So let us start with the first case, 50-year-old lady presenting with headache for last 1 year. Headache, it is mild to start with, and for last 2 months it become very severe. She also has myalgia on and off for 6 months. And the patient is diabetic and hypertensive on medication for last 2 years. No history of fever, joint pain, loss of consciousness, any vomiting or seizure. So this is the CT scan you can see on the left hand side. And on examination, she had bilateral immature cataract, BP and sugar is under control. And Because of headaches, she received multiple NSAIDs, and there is very poor response of NSAIDs in the headache. So I like to ask ma'am, what will be the differential diagnosis considering her background history of diabetes and hypertension and the age?
So, middle-aged, 50, I wouldn't call her elderly, a middle-aged woman coming with properly controlled diabetes, hypertension, and headache. Okay. The first thing, of course, would always be looking into the intracranial involvement, which is conspicuous here as there is no stroke on the CT scan. But we have to always consider, I mean, before you look into the CT scan, we have to consider uncontrolled hypertension, which you said is controlled, uncontrolled diabetes, you said is controlled. And the other thing is, what are the drugs that have been used for the control of hypertension? If there were any drugs that could have resulted in dyselectrolytemia, that is something very much to keep in mind because that could be one of the causes of headache. But and the poor response to NSAIDs is a very important food for thought. But the one single clue that you said, myalgia,
Myalgia, yes.
is not to be ignored. Many people think that myalgia, and people generally say just aches and pains, ot bihai se, tot bihai se. Typically, people coming to our OPD would say, siring ke mari se, things like that, which we often ignore. But a young 50-year-old young woman with a refractory headache, not responding to NSAIDs, and history of myalgia, definitely a food for thought. Why? We want to look into any signs of inflammation. We have to pay proper attention to a rising ESR or a rising CRP. You know what I'm hinting at. We could be landing up with a large vessel vasculitis. So
Exactly.
that's very important. We want to also delineate whether it's a unilateral headache or a bilateral headache. If it's a unilateral headache, myalgia, and raised markers of inflammation, we are on a particular track to the diagnosis.
Okay. So when the patient landed up in GMC indoor, so we straight away palpate the temporal artery on both sides. Left side temporal artery is very tender and it's cord-like. So I like to ask Rebecca ma'am, what investigation next you will do?
Thank you, Dr. Digonto Das. So, as Madam had said, we would be thinking in the line of a large vessel vasculitis. Say, let's be more specific. We would definitely keep in consideration giant cell arthritis. So, investigation of choice, the gold standard is actually superficial temporal artery biopsy, but it may not be feasible always. So, depending on the center where you're working, we can go for a high resolution ultrasound where you can get a rim, a non compressible rim. If the ultrasound quality is not good, or it depends on the skill of the radiologist also, then we may even go for a CT or MR angiography. So I think that we can consider depending on what setup we are in. If possible, biopsy would be the investigation of choice.
Biopsy is actually gold standard. We don't have a team who report temporal artery biopsy or who do temporal artery biopsy. So what we have available in our hand is ultrasound. So we did the ultrasound of the temporal artery on both sides. What we can see here, there is thickening of bilateral superficial temporal artery, more on left side, and the thickness is obviously more than normal, but the flow is continuous. When we look into the transverse section, we can clearly see the halo sign. That means blood flow is there and surrounding blood vessel wall is very thickened. When we compress with the probe, the obstruction of blood flow obstruction is there, but we cannot compress the arterial wall. That is very much thickened. And along with the high ESR and CRP, we made a diagnosis of giant cell arteritis or temporal arteritis, considering these diagnostic criteria, like our patient is more than 50 year, new onset headache with temporal artery abnormality in the ultrasound and elevated ESR. Of course, we have not done the biopsy part. So this came out to be a case of GCA. Next, I like to know something about GCA from Daisy. Is it always temporal headache or something else in GCA?
Since you know that giant cell arteritis is a large vessel vasculitis, so there can be variable manifestations. So many of the features of giant cell arteritis, they overlaps with Takayasu arteritis, because Takayasu arteritis is also a large vessel vasculitis. So both the aorta and its branches can be affected in both the conditions. So in giant cell arteritis, so patient can have variable manifestations. So the most common, it can present with a headache, new onset and persistent headache, which is not responding to NSAIDs. And also there can be pain and tenderness over the temporal area, and severe scalp tenderness can be present. But giant cell arteritis, the headache is not always temporal. It can be diffuse headache also sometimes. And many times patient can present with visual symptoms, which can be sudden onset visual loss. And again, it can be temporary vision loss like emeresis fugax, or it can be irreversible vision loss sometimes, which is a medical
And
emergency.
most of the time, the temporal artery tenderness or headache is not there. Patient sometimes
Yes,
present like PMR.
sometimes temporal artery may not be affected
It
also.
is like polymyalgia rheumatica type of presentation.
Yes. So the involvement of this giant cell arteritis, many a times patient can present with stroke also sometimes. For the first time, mostly the vertebrobacillar stroke can be present. And again, constitutional symptoms again, there can be fever, night sweating also, weight loss. And also one of the most, second most common is there can be jaw claudication and even tongue claudication also. Patient can have pain while chewing. And of course, there can be, as I've already said, there can be aortitis. So in that situation, the manifestations will be like Takayasu. There can be arm claudication as well, and pulse
So
asymmetry,
broadly,
BP
we can
asymmetry.
classify it is visual and cranial manifestation and
Yes.
extracranial manifestation.
Yes.
And if the manifestation is a bit, I mean, not that strong or high risk, like stiffness only, that can be a PMR variety.
Yes, PMR like symptoms also can be present.
Next, I like to know from Barua ma'am, what is the underlying pathophysiology, and depending on the pathophysiology, what are the drug of choice for GC?
Okay, GCA is a large vessel and medium vessel vasculitis. So there is in pathology there is presence of dendritic cells in the blood vessels release chemokines, and it activates CD4 T cells and macrophages, and they release cytokines like interleukin 1, interleukin 6, and interferon gamma. And as it is a inflammatory disorders, drug of choice is immunosuppressive drugs, and my first choice will be glucocorticoids as it is a time tested drugs, and others are antibody against interleukin 6, that is tocilizumab, and abatacept, which prevents T cell activations. And the interleukin 1, that is anakinra, it is not recommended for giant cell arteritis disease. And if we consider ACR 2021 guidelines, when there is potential visual loss, so we have to prevent visual loss. So in that situation, we have to start promptly intravenous high dose glucocorticoids. That means pulse therapy of methylprednisolone along with tocilizumab. And if there is response, then we can taper the and it is a high methylprednisolone pulse therapy should be followed by high dose oral corticosteroids. And if we see the response by 4 weeks or 8 weeks, then we should taper the dose of glucocorticoids. And if there is no response, then we have to switch over to the other immunosuppressive drugs like methotrexate or abatacept. And in other cases, without visual symptoms, we can start high dose oral corticosteroids along with tocilizumab. And if response, then we can taper the dose of glucocorticoids. And if there is no response, we have to switch over to the other immunosuppressive drugs instead of tocilizumab, like abatacept or methotrexate or mycophenolate mofetil. So this case, there is no visual symptoms,
and history is for last 2 months, so we can go for high dose glucocorticoids with tocilizumab. And what treatment has been given in this patient?
Ma'am, actually, considering her age and diabetic and hypertensive status, we gave a mini pulse that is 250 milligram for 3 days. Then we are supposed to give IL-6 inhibitor, but the patient could not afford. So after that, along with steroid, we have added methotrexate for GCFR, and for sugar, we have given metformin. And for blood pressure, she was discharged with telmisartan and amlodipine combination. After 1 month follow-up, symptom-free, ESR CRP is within normal limit.
Congratulations, Diganta, for treating this, identifying this patient, because otherwise this patient is a multivessel disease, a small vessel diseases manifesting as a multiple cerebral infarct. And only clue of vascular disease, large vessel disease, is the myalgia. But because that other polymyalgia symptoms are not there. Not there. So you need a high index of suspicion in that group of patient, and you have palpated the artery, that leads you to that leads you to the diagnosis. And second thing, being a medicine specialist, when patient complains with myalgia, we would have to look for vitamin D deficiency in that group. We have to rule out osteomalacia in that group of disease, as well as other muscle. I would have done a CPK in this group of patient, and to look for muscle diseases, and even since the patient is diabetic, and there is imminent dangers of losing the vision, and instead of going through, because you have to, if you use steroid, you have to use steroid for a longer period of time, and steroid, as you all know, increases the blood glucose.
That's why
do you consider other alternative therapy in
actually
induction?
that's why we have started a very mini dose pulse dose and started only with 10 milligram, not 1 milligram per kg body weight, and along with that we have added methotrexate, so that within next 4 to 6 weeks you can withdraw steroid and maintain her on methotrexate.
And Ekta, she was also checked for vitamin D. She was also checked for thyroid profile. Hypothyroidism could also have myalgia. But fortunately, this woman had very visible and palpable temporal arteries. Her granddaughter happens to be a medical student in the 9th semester. She also saw it when she brought her.
Because of our training, you will be able to look for it.
That's wonderful. Yeah.
Thank you.
Okay, coming to the next case, 30-year-old boy presenting with cough and hemoptysis on and off for 2 months. There is a significant past history of recurrent ear infection and discharge from the left ear. HRCT mastoid done, it's showing otomastoiditis, and outside he was treated as otitis media. However, immediately we did one HRCT cyst. What we can see here is the multiple nodular lesions on both sides of the lung parenchyma, and some lesions there is internal cavitation going on. So considering his age, cough with hemoptysis, as well as discharge from the ear, what will be the differential diagnosis? I would like to know from Rebecca, ma'am.
Okay. So this case itself, I think, would say is typical. The presentation is typical because he has come with upper respiratory symptoms, which involves the nose and the ears, right? And then he's come with hemoptysis. So when we see, we can narrow it down to very few conditions which will have upper respiratory and lung involvement. And right, if we had not done CT scan, then we would have had other differential diagnosis. But with the CT scan with cavitation, I would narrow it down to only one. But like it is taught to us, never make the rare diagnosis as your first diagnosis. Yes, you will have to consider infective conditions, but initially we were called it vaginous.
But if we consider only cough with hemoptysis 2 months and this
then we'll
then
call
it
it
is
infective.
obviously TB.
Infective.
But
cough.
if we consider the significant past history of
Yes.
recurrent ear infection,
Ear infection, nose infection, and respiratory, then it goes to granulomatosis with
So
polyangiitis.
next, what I immediately did is just a speculum examination of the nose. We can see there is nasal spectrum crusting and thinning out of the septum. Actually, thinning out, I have checked with a torchlight. I can't provide you the picture. here we can definitely see the nasal septum and there is crusting. And this is the patient. Side view, there
little
is
saddle
depressed
nose is
nasal
there.
bridge, and
Right.
there is lower motor type of facial nerve palsy on left side. So considering everything, multi-organ involvement, ENT, that sales physician, neurology, and they did this tympanometry. What we can see here, conductive type of hearing loss and B-type curve on the tympanometry. And the other investigation we did, everything is normal apart except the PR3, which is more than 400. So it came out to be a case of GPA, earlier known as vaginous granulomatosis. So I like to know from Borua ma'am, when to suspect GPA?
Granulomatous polyangiitis is a disease of medium and small vessel vasculitis. And this in 90% of cases affects upper respiratory involvement like nose, ear, throat involvement is very common, along with severe constitutional symptoms like extreme fatigue, fever, night sweat, weight loss, and increased ESR and CRP. So if a patient presents with common cold like symptoms and not responding to conventional treatment, and it is sign and symptoms lingers for an extended period with severe pain, sinus pain, nasal discharge like nosebleed and mucopurulent discharge from the nose, then earache, ear discharge, along with the eye involvement, redness of the eye, episcleritis, scleritis. In that scenario, along with the history, we should suspect GPA. And in GPA, there is pathologically there is classic triad, that is vascular inflammation and inflammation, granulomatosis, and necrosis. So there is inflammation, and because of necrosis, there is purulent discharge or bleeding. So these three things goes together. And in granulomatous polyangiitis, 70 to 80% cases, there is kidney involvement. So if we get the clues of proteinuria, albuminuria, and essential hypertension, that means nephritic syndromes, then always we should suspect GPA. And lower respiratory tract involvement, as shown in this patient, nodular opacities, diffuse alveolar hemorrhage with history of hemoptysis, definitely one should suspect GPA and we should proceed for the investigations.
Thank you, ma'am. Thank you. So next, I'd like to know something about the diagnostic procedure from ma'am. How to diagnose when we are suspecting GPA? How to diagnose GPA actually?
GPA is, of course, diagnosis of an index of suspicion. The eyes will not see what the mind doesn't know. So you have to have that in mind. This is a person who's come to you with hemoptysis, nasal bleed, and you have demonstrated the granuloma, the tumor like mass, macroscopically. Now, we also want to know about if there is any renal involvement. And this is the chart which the American College of Rheumatology has charted out for us. And we need to have a score of more than 5 to label it as a definite GPA. But one thing that we need to remember as a gist from this slide, this chart that is there, is you have to have features as charted out there, mostly upper respiratory, with or without renal involvement. But the main +5 score you see on the lab count shows that a positive CANCA or PR3. If there is, to remember it easily, we have to remember that if you have these features that have been described involving the eyes, ENT, renal, and other organs of the body with or without joint pain, history of fever, and microscopically on the biopsy, you have demonstrated granulomas, you have PR3 positive, you have clinched the diagnosis of GPA. But if by chance you have a PANCA positive, then you have a -1 on that score. That's very important to
It's
know, because
for
we
in
generally
that
say,
case actually,
yeah,
if you consider the clinical, it's already fulfilling all the
all
criteria.
the
Score is
criteria.
more than 6 years,
Mm.
and PR3 is more than 400, so we don't
So
need more than that actually.
uncontroversially,
Yeah.
we have picked up the diagnosis of GPA. For us internal medicine people, this is one thing that we should remember, that we should think of the possibility, ask for the investigation, and just saying ANCA positive and ANCA negative, which very commonly we say, is not enough.
Not enough.
You have to say whether it's the P or the C ANCA, PR3 or impure. Granulomas present, no granulomas. Eosinophil count. There are certain cardinal features which you want to highlight when you clinch the diagnosis of GPA.
That eosinophil count is usually high in EGPA. And the MPA variety, there is more of renal involvement than the respiratory tract involvement. And in GPA, there is more of ENT and pulmonary involvement compared to the MPA. Renal involvement is less in GPA. I think this CERT has already been discussed yesterday in Dr. Aman Sharma's lectures. Everybody is well oriented at this CERT. So we have treated him with MPS pulse, along with we induce him with cyclophosphamide. That's what we did for the patient. I would like to know something more about ANCA-associated vasculitis treatment guideline from DAISY.
The treatment guideline of ANCA-associated vasculitis are mostly, it is divided into two phases. One is induction of remission, and if remission is achieved, we have to do the maintenance therapy. So for induction, according to Euler guidelines, so induction is basically, again, we have to say whether the patient has any organ or life-threatening manifestations and or non-organ threatening. If it is an organ threatening disease, mostly we have to start, like if there is a RPGN like picture or is a pulmonary hemorrhage, so we have to treat it like an emergency. So we have to start with methylprednisolone pulse and followed by rituximab and or cyclophosphamide. So that is for the induction. And if it is a non-organ threatening disease, like maybe simple non-organ threatening manifestations, then in those situations either
Only
rituximab,
upper respiratory involvement,
yes,
nasal crusting,
only ENT
just
limited
a
disease,
little bit of
yes,
cartilage involvement without any bone involvement. That's what you mean to say.
yes,
Non-organ
threatening diseases.
non-organ threatening.
So in those situations, we can give rituximab, either rituximab or methotrexate or azathioprine as induction. So after the remission is achieved, so then we have to keep the patient on maintenance therapy. So for maintenance therapy, so rituximab we can give for at least 2 to 4 years. It is recommended. 6 monthly maintenance regimens, and or another option is azathioprine or methotrexate.
Methotrexate.
Yes.
That's what. Actually, when we are talking about a simple GPA, that means non-life threatening GPA, we have one case, ma'am, it's ma'am case actually, Ampidas ma'am case. She's our follow-up. She only had upper respiratory tract involvement and sclera involvement. You can see her. She is well in remission with only methotrexate 15 milligram per week. And she is interestingly PR3, MPO both negative. There is no lung involvement, there is no renal involvement.
In the induction phase, and you have started with the cyclophosphamide.
Yes, sir.
With the high dose cyclophosphamide or
Sir,
the low dose
Actually,
cyclophosphamide.
what we are giving is we are though it is US regime is said to be better, but considering the patient follow-up and compliance, we usually go with monthly doses, high doses of cyclophosphamide. So coming to the next,
Before going to the third case, the house as a medicine specialist, because they are all oriented to look for GCS. So in our case, we have to rule out pulmonary tuberculosis. We have to rule out cystic bronchiectasis in this patient, as well as aspergillosis. We have to rule out before starting all these therapies.
Actually, the classification criteria is only applicable if we ruled out the vasculitis mimicker first. If we have to exclude those first, then we can apply the weight-based diagnostic criteria for GPA. Number 3 case, 18-year-old boy presenting with gradually progressive swelling over the nose, nasal bridge, and the upper lip. for 1.5 year. It's painless, non-itchy, no fever, no weight loss, no other swelling anywhere in his body, and gradually he is developing difficulty in breathing and dysphagia. So in 1.5 years, I want to show you, this is his first picture he sent me. He's having swelling over the upper lip and is sick. Then he went to Coach Bihar. They did what I don't know. They have taken some biopsy with those huge cut marks. They have given something, probably steroid. Swelling decreases. Again, after that, that patient went to Tata Memorial Hospital for evaluation of malignancy. Came back to BBCI. After that, I got the patient from BBCI. After they have excluded those malignancy, when he came to me, he had again the swelling involving both the upper lip, cheek, nasal bridge, and the nose. You can see here. So we gradually we search all the investigations, especially the imaging. What we can see here, there is a heterogeneously enhancing mass lesion in the nasal cavity, extending anteriorly up to the subcutaneous spaces and posteriorly up to the nasopharynx, hard palate, soft palate, and posterior third of the tongue. And interestingly, there is no bony erosion, bony involvement, or any indentation over the major arteries. We also reviewed the other investigation, PET, whole body, everything is normal apart from the mass, which is heterogeneously enhancing with moderate rate of metabolic activity, and there is bulky tonsil, and there is lymphadenopathy, but without any increased metabolic activity. Bone marrow aspiration is normal, other blood and CBC, renal function, liver function, even RA urine is normal. ANA report and ANCA report were available, both negative. So I want to know something about the differential diagnosis from Borua ma'am, considering the patient presentation of 1.5 year with a mass inside the nasopharynx.
There is mass in the nasopharynx, and he has highlighted that there is no bony erosions. So that's why initially I'll think of some benign conditions like papilloma, that is very common is inverted papilloma. Then we can consider other schwannoma, hemangioma, and dermoid, and some gliomas. But still, it is a large growth. So, and heterogeneous in density. So we have to consider some malignancy. And amongst nasopharyngeal malignancy, squamous cell carcinoma is common, then adenocarcinoma. And we have to think of some malignant melanoma and olfactory neuroblastoma. Then we have to think of lymphoma, Hodgkin, non-Hodgkin's, and large cell plasmacytoma. So we have to bring the differential diagnosis. And first I'll consider the benign conditions.
Yes,
And
ma'am, thank you. Actually, he had undergone multiple biopsy from that site. Biopsy 1, which he did in Coachbihar, it is not available with us. And after that, biopsy 2, it shows some capillary hemangioma. Biopsy 3, neurofibroma. And BBCI, last report is necrotizing cutaneous vasculitis. We have that report with us. I'd like to know, actually, they have done all the IHC marker for malignancy to rule out the malignancy. But while going through the IHC and the morphology of the lesions, there is something else in the background of though we are looking for malignancy. Actually, it is not malignancy. Daisy, what is your view?
If we look at the microscopic description in the biopsy, so we can see that there is multifocal infiltrates of histiocytes, eosinophils, plasma cells, and lymphocytes. So we have a mixed inflammatory infiltrate. And one important point they have mentioned is necrotizing vasculitis with perivascular coagulative necrosis. So this point is a strong point which favors vasculitis, cutaneous vasculitis, and also there is mixed infiltrates of inflammatory cells. So from this we can say that some inflammation is going on in the in this patient. And if we look at the immunohistochemistry, like we can see that again there is CD2, CD3, CD4, CD8, and even B cells, and again CD68 positive histiocytes. Again, we can here see that there is mixed T cells, B cells, and all the cells are present. And if we look at the malignant markers like CD56, which is a NK T cell marker, so all these are negative. So there is no evidence of any lymphohematological malignancy in this biopsy. So from a rheumatologist point of view, I can say that there is some vasculitis which is going on in this patient, but what is the type of vasculitis that we have to look into further details.
Actually, yeah, this if we look into the morphology, the gross morphology, it is unlikely to be malignant one because there is no involvement of the bone, no involvement of the vessels. It's just touching the adjacent edge outside anteriorly up to the lip and posteriorly up to the nasopharynx. And thing is that another thing is it is persistent. It's increasing. In between, he did biopsy in Coach Bihar. They gave something, probably, I assume, steroid. He responded to steroid. After that, it again started increasing. So, obviously, this is not malignancy, but it is inflammatory type, considering all IHC marker. But which type of inflammatory mass it is, we are not sure. So, we had that, we are not considering the another biopsy. We just procured the previous biopsy slides and we did IgG4 staining. Here we can see on the right hand side, and this is HNH staining, and this is the IgG4 staining. What we can see, it is full of IgG4. So when we revise our diagnosis, everything he fits. So this, obviously we have not done this one, serum level, which is not available here. So this came out to be a case of IgG4 related disease presenting as nasopharyngeal mass for last 1.5 years. Next, I like to know something about Rebecca ma'am. What are the organ involvement in IgG4 related
I
disease?
just like to comment on the biopsy again. Though the staining has shown that there is lots of IgG4 staining, but the biopsy that has been described here is against an IgG4 actually.
Actually, the previous biopsy report, they have diagnosed as necrotizing vasculitis,
Yes,
which is against IgG4.
IgG4, because in IgG4 usually we don't get a vasculitis, and even if you get it rarely, but it is not necrotizing. It is actually non-necrotizing.
Non-necrotizing
Yes,
vasculitis.
so that is against
But again,
IgG4.
yeah, they have done all the ICH marker related to their panel to exclude the oncology part. But what I did is I look for, if you consider the gross morphology, what else it can be? Can it be GPA? Unlikely.
But
that is an inflammatory mass. Commonly, what we got during our training session is IgG4.
there's a typical what you call a histopathological finding in IgG4
Yeah.
related diseases.
That we
Lymphoplasmacytic
did later actually.
infiltrates and
Means that GPA still is a possibility here because the patient had necrotizing vasculitis. Though granuloma is not there, but it's a necrotizing vasculitis which we get in
Okay.
GPA.
These are the slide. Can we see any necrotizing vasculitis here? The vessels are not there at all.
but then the three
They're reported as necrotizing vasculitis, but these are the slides. Vessels are not there.
Yes.
Okay, Rebecca ma'am, please.
Thank you, Dr. Das. So, IgG4 related disease is a new term or disease, but the condition is very old. It was not diagnosed, it was
Yeah,
misdiagnosed.
like API, like
Yes.
all.
So now it is on the run because we are aware of it. The thing is, IgG4 related disease has been known with different names. It's known as IgG4 autoimmune disease
Yeah.
also. It can involve any organ. It is defined by its multi organ involvement. But yes, there are very selected organs which are predominantly involved or are involved more commonly than the others. So we have the salivary glands, the lacrimal glands, the orbital tissues, then pancreas, retroperitoneal structures, kidneys. These are the organs which are generally involved. But like I said, it may present
It
with
can
a mass
present anywhere in the body, like a tumor, and it always mimic a
can mimic infection, malignancy, and
malignancy.
it can present as a solitary tumor. Then you
Solitary.
are at a loss.
So subsequently, he was treated with 500 milligram of rituximab, and we have given prednisolone 1 milligram per kg body weight in a tapering dose. And next, whether we are correct or not, because IgG4 disease is a rare disease to be considered, and there is no treatment guideline. What we have is treatment outline. So I like to know from ma'am, what is the treatment outline for IgG4 diseases if we consider this European cohort?
Yes, of course, considering the rarity of the condition, we have about 2, 3 cases on our follow up. We also have another patient of mine
Yeah,
who,
who
both of us,
presented as pituitary mass.
yeah, as a
Neurosurgery
pituitary
has been
mass.
done. Later on came out to be IgG4.
I mean, that patient has gone from doctor to doctor, pillar to post. It's finally landed up with me. Anyway, whatever. Point is, there is no definite treatment guideline that has been laid down for IgG4. But it said that what we follow is, if it is in a place where there aren't too many symptoms, you could just wait and watch. If it's in a place where you've picked up an IgG4 causing no symptoms as such, it's that you can wait and watch. But if it is in places like that one which we are already following up, like a pituitary mass, biliary stricture, retroperitoneal fibrosis, renal involvement, eye
And the present
involvement.
case scenario also, he is
Yes.
developing dysphagia and respiratory
Yes,
problem.
so
We
he
have to take
definitely
it as
has,
yeah.
symptoms that are causing obstruction. So in those kind of situation, it is treatment at a war footing early. Usually we start with steroid pulse followed up with rituximab. We want to reduce the steroid from a higher dose down to a lower dose and continue at a lowest possible dose for about 6 months and then stop. But up to 50% of these patients could
They will
relapse.
relapse.
Relapse in IgG4 is pretty common. If it's 50%, meaning, of every 2 patients would relapse. So what are the other steroid sparing immunotherapy,
We have to
immunomodulators
target the
that
B cell.
we can
We have
use?
to target the B cell. For that, we have anti-CD20, that is rituximab.
Yeah, so rituximab, and then to maintain remission, we could put the patient on azathioprine,
Or
MMF,
methotrexate.
and or methotrexate. And every 2 patients are not the same. We could need to pulse with steroid and rituximab at any point down the line on follow-up.
But if we consider our first patient, that pituitary mass,
Yes,
she
yes,
received
yes, yes.
MMFs, she even received
Yes,
tofacitinib.
when she came
But
to us,
she didn't respond that
she
time.
didn't respond.
After that, she responded to rituximab.
Rituximab. So she was already on MMF and she was on the highest possible dose because she had come to me from a referred rheumatology center actually.
Okay, this is what
Excuse me, can I make a point, Dr. Das? One sentence caught me. You said the patient responded to steroids. So I think one of the features of IgG4 is that this good response
good
to
response
steroid.
to
Very, and
steroid.
that is
Yeah,
that
good
helps with the
response to steroid.
diagnosis.
That
So I
that
want
actually
to
cleans
ask
the diagnosis.
Madam and you also, like ma'am, you had said that if it is in a place which is not very threatening to the patient, then we may withhold or we may delay the treatment. So won't it be justified to put the patient on steroids, giving the fact that it responds very well?
If we let me talk about our first case, Sunita Todi from Tinsukia. Actually, I should not have disclosed her name, but she was on tofacitinib, on MMF, and 20 milligram of steroid. She is responding. Already one eye is gone, and one eye vision is hampering.
One eye she's
And
completely blind.
whenever she decreased the steroid dose below 20, she used to have more problem. Now, you won't believe, she got 2 doses of rituximab and Visolan is only 5. And her right eye vision is completely improved. Left eye is still blind because of injury. Now it is also blind. Right eye improved.
Patients, should we go for
Yeah,
steroids
it
for all
depends
patients?
actually. If we can,
Irrespective
if
of
we can
the site
stop,
where it is
it is
involved,
good.
if we can
If we
stop.
cannot, then at least
But
5 to
my
7.5 we
understanding
can
is that
continue.
steroid has to be given for a pretty long
Yeah.
duration, 6 months minimum, right?
So this is what we receive, and this is after 1 dose of rituximab. You can see the response. So we have only 5 minutes. Let me be quick. 39-year-old lady, unmarried, fever for 6 months, low grade, and joint pain 6 months. History of some ovarian tumor, appendectomy was done in 2017, undocumented. Mens is irregular for 2 to 3 months, less flow with cycle duration and more than usual. AN is positive by ELISA. You can see her face. There are some lesions over her nose, tip of the nose. Rebecca ma'am, is it SLA?
This is, I think, a typical discoid lupus erythematosus lesion with a central clearing and a rim of crusting and erythema.
Okay.
So it is.
This is actually herpes labialis, not discoid. Thank you. So on
I
systemic.
see Aman Sharma sir in the crowd. That makes me a little conscious when we're talking about vasculitis. Welcome, sir.
The lesions
Sir.
in the nose
Yeah.
does mimic DNA.
We have later
right?
confirmed it from the dermatologist colleague that it is herpes labialis. So gastrointestinal system, only splenomegaly, other systems are normal, and there is no sign of it is probably because she is on steroid till now. What we can see from the hemogram is that hemoglobin is always low. The total count is and platelet count is always low. Even after receiving multiple methylprednisolone pulse, that count is not improving. And other rheumatological workup we have done is ANA by IFA. It is 1:320. DSDN is indeterminate. That is not negative, not positive. ICT, DCT both positive. 24-hour urinary protein is 480 milligram. So I like to know from ma'am what are the possibilities considering her age, presentation, and the autoimmune panel.
Yes, Digonta, this patient had really posed as a problem for us. Looking at her ANA 1:320, DSDN, of course, indeterminate, and the clinical picture, I would say this is definitely lupus with nephropathy. She has autoimmune hemolytic anemia, but the lupus is not in a flare. It is lupus, not in a flare, with autoimmune hemolytic anemia. After receiving multiple doses of steroids, she's not responding. Lupus, not in flare. So we have the other things in mind as you are already projecting. Of that, autoimmune liver disease, I am not bringing it into the picture as of now. HLH, because of time, HLH or the macrophage activation syndrome is common in younger children where you'll have the macrophages engulfing on the peripheral smear. You'll see the macrophages engulfing the cells. You will have a pancytopenia, which goes here in favor.
Can it be TB?
Yes, tuberculosis is something which all internists would think about, but with DCT, ICT positive, and with what you call ANA 1:320, DSDNA indeterminate, I wouldn't put TB as number one. I would call this a lupus with autoimmune hemolytic anemia. Now, with what you call nephropathy, but there is a second pathology for sure because the autoimmune hemolytic anemia and the pancytopenia is not responding
Let us narrow down
to steroids.
finding. Thank you, ma'am. Let us narrow down the finding. It's prolonged pyrexia of 6 months duration, pancytopenia not responding to steroid, rash is there that is not typical of SLE, splenomegaly, if we consider SLE, it is unlikely, very uncommon. Joint pain, though history is there, we are not getting, probably it's a steroid effect. So other infective workup we did, viral marker, fever profile, all negative, fibroscan is normal, EGA endoscopy, esophageal candidiasis with erosive gastritis, 2D echo, mild PAH, bone marrow is normal. This is her chest X-ray. Now I would like to know from Barua ma'am, what can it be?
Yeah, chest X-ray, it depicts space-occupying lesion in anterior mediastinum. So when we see a space-occupying lesion in anterior mediastinum, we should always think of three T's. One is three T's. One is thymoma, remnant thymos tissue is present there. So thymoma, thymic cyst. Another is cerebral lymphoma, large cell plasmacytoma. Another is thyroid tissues like retrosternal thyroid gland or malignant thyroid carcinoma. And another is teratoma. Besides germ cell tumor, teratoma is more commoner than seminoma as a anterior mediastinal tumor.
So we did one HRCT. It's a well-defined heterogeneously enhancing soft tissue mass density in the anterior mediastinum. There is bone erosion. You can see the costal cartilage are eroded already. They have suggested a neoplastic etiology. We did biopsy, true cut biopsy, and IHC report are here. From IHC report, P63 and PAN-CK both are strongly positive, so it came out to be thymoma. So is there any relation of thymoma and SLE? We know the relation between thymoma and myasthenia gravis. Is there any relation between thymoma and SLE? Daisy.
Yes, SLE and thymoma, there is association, but it is very, very rare overall. As we know that thymoma is a tumor of the thymic epithelial cells, and though we know that the function of the thymus is to eliminate the autoreactive
Yeah.
T cells in our body, so when the thymoma is there, so this negative, there is a defective negative T selection, so these autoreactive T cells, they escape, and they, what they do is that they stimulate the B cells, and that is why there's lots of antibodies like double-stranded DNAs and all, so it
And
leads to
that's why we are
autoimmunity.
getting all those iffy positivity of DNS, DNA, ANA.
So the
Probably it's all
manifestations
because
of SLE are mostly because of the activated B cells. So it is well recognized, but it's a very rare association. And also one of the symptoms that has been described in this case is a refractory cytopenias,
cytopenia,
which is
yes.
a very common in SLE when it is associated with thymoma. So and the treatment is, of course, we have to do a thymectomy.
Actually, we planned a thymectomy. After that, she collapsed. We could not
Yes,
survive
even
the
after thymectomy, there can be sometimes worsening of SLE
Yeah.
because of immune reconstitution. So it can unmask the autoimmunity sometimes, or it can worsen if there is a already pre-existing SLE.
Thank you, Daisy, and thank you all panelists, and thank you all chairperson. I like to conclude. Rheumatology, it's not only the joint pain; it can involve all the system. It is, as I have discussed, all other system like patient going to ENT, patient going to neurology, pulmonologist, all of them came out to be rheumatological cases. Thank you.
Thank you, Speaker Dr. Diganto. And thank you, panelists. With this,
one case, it is back. When there is thymoma, it is rare with SLE, but it is also showed that there are some cases rarely present with autoimmune hemolytic anemia with thymoma.
Well, I haven't fortunately come across such a difficult situation. So it's such a rare thing that I can't really answer with a lot of conviction. But if you've already given steroids and patient is not responding, then perhaps it may not respond. That's all that we can know. I mean, that's what I would wish to say. I can't say from my experience. There's something which I've never seen. The other thing that I would say that in the differential that you discussed regarding HLA and all, one infection which should always be considered a CMV. I mean, CMV can mimic SLE, CMV can mimic flare, can unmask SLE. So these are the other things that I would wish to say.
thank you, speakers, and again to the panelists. With this, we are going to conclude this session. Thank you.
Thank you.
Thank you for your highly valuable discussion. Up next, we have a presidential address for which I would like to call our chairpersons to the stage. Dr. N.N. Deka, Dr. Atul Chandra Saikia, Dr. Dvijen Das, and Dr. Dhiraj Das. I request you to kindly grace the dais. And now may I invite our esteemed president of API, Assam chapter, Professor Anup Kumar Das. We warmly welcome you to the stage.
Good morning, everybody. We come to an important session that is presidential elections. It is a new entry to our APICONs, started first in Nalbari by Sanjeev Kakoti. After that, this one is the third one that will be presented by our respected chairman, Onup Das. I request Professor Onup Das to go for his presentation.
Thank you, chairpersons, and good morning to the learned audience. Being a chairperson of an association and giving so-called presidential address or something, I don't know what is the meaning. It is just a welcome address or a farewell address or something else. I don't know. But anyway, I don't have any slides to show you because I'm not here to teach you anything or give a lecture like I do in my college. What I'm going to share with you a few points that I faced and I thought of while being a student and in my journey as a doctor of a clinical medicine. Okay, when I went into the first year, the reason was that I wanted to become a doctor. A doctor means a medical professional, and that doctor may be a clinical doctor, clinical medicine, or clinical subjects, paraclinical subjects, or preclinical subject. And I had an interest in treating patients at that time. I don't know whether I wanted to treat as a medicine specialist or a surgical specialist or a gynecologist or a ENT specialist, anything. Went into the third, in first year, second year, I learned about physiology, anatomy. Went into the third year, posted in the wards, different wards, clinical wards, and I had to attend, we attended clinical rounds as well as clinics. And some of my teachers are still here who taught me medicine. Birinchada is there. In the evening, we had clinics with third year, fourth year, fifth year. Then appeared in the examination, became an intern. Being an intern had to be posted in wards and had some interaction with patients. Went to the outdoor. It was a big day for us. Examining patients, being taught how to examine inspection, palpation, percussion, auscultation. Then write down the history, send the investigation. We did the urine investigation, stool investigations, blood, and in the laboratory, which were at that time present in the ward itself. Nowadays, it's not present in the ward. Then next day, the VP used to come, register used to come and asked, what is this? What is bed number 1? What is bed number 2? And we had to give diagnosis. What are the medications we are giving? We had to show the history sheet and the drug sheet and all. Sometimes we were right, sometimes mostly we were wrong, and mostly we were rectified. So why? We did not have experience. Everybody said, no, you just passed your theories and now you will have to learn. So how to learn? What are the learning triads of medicine to become an Indian medical graduate? The so-called IMG. So the learning triad is, of course, theory. Without learning theory, what is brain, what is heart, what is the circulatory time, what is ejection fraction, what is liver function test, what is the GFR, glomerular filtration rate. These were taught, and we had to know this because these were the normal. When this normal physiology, anatomy were deviated, then became abnormal, and those were the people who came to the doctor. So that was the first thing we had to get into our mind. So we have to understand that this person coming to us with pain or vomiting or fever or thing had an abnormal physiology and possibly abnormal anatomy. So that was the first thing I learned. Then about the learning triad, that is the first part, anatomy, physiology. The second was history. Being in clinical medicine, I'm looking at it from medical perspective, from clinical medicinal perspective. then history taking, and physical examination. These are the three learning triads. It has been known 3,000 years from now, before Christ, those big Indian surgeons and clinicians, Sushruta, they also mentioned, these are mentioned, that you observe the patient, you examine the patient, and you follow up the patient, and then you note down what happened to this. And so that in the next patient, you can predict what may be the problem and how you are supposed to, what is the best method of treating them or giving them some care, and what were the prognosis, what happened to them. So these were known about 3,000 years back. Then came the scientific formatting of these all procedures of this learning triad. The writings, anatomy, physiology, Gray's anatomy, and all everything, and the history taking, and the physical examination. These were not done haphazardly. These were to be done in a scientific formatting which has not changed in the last 130 years, because these scientific formatting of this history taking and physical examination were probably finalized by 1910. Okay. Now, the problems which I face. Now, whenever a patient comes, I go to the outdoor, or to the emergency room or in the ward. Then there is a definite diagnosis which I have to make. And between the diagnosis and myself, the doctor, there is the patient. So the doctor, the patient, and the diagnosis, so that I can give some treatment. Now, when I take the history, it is being reported widely and it has been validated over and over again. 53% of the diagnosis can be made from history taking only, by history only. The greatest example is cardiology. 95% of the diseases can be diagnosed with history and the stethoscope. You don't need ECG, you don't need echo, you don't need all these big list of biomarkers and all whatnot, angiography, nothing. 95%. This has been the case 100 years back, and this is the case 100 years from then, even now. So that is the biggest problem that we face, that we don't take history properly, because nearly 53% in resource poor setting, we need to be very, very thorough in taking history. And physical examination is another important aspect. And if we combine physical examination and proper history taking, proper physical examination, detailed scientific physical examination, the diagnosis jumps to 70%. I'm not saying this. People are saying this who have done very genuine work in this aspect. So probably this is important, but that is not all. We may miss, or we may not be able to do justice by diagnosing by history taking and physical examination. That happens, and that is expected, reasonable. In 30-40% cases, we need to do diagnosis, investigate, and to arrive at a diagnosis. But the main importance of history taking and physical examination is that it is cheap. It does not cost anything. It does not cost. You don't need to invest anything on this. You can do that. But still, you need to go for investigation. The biggest advantage, I think, is by taking proper history and physical examination, you can narrow down the number of, or the type of investigations that you can do or you are supposed to do. Without taking proper history and physical examination, the number of investigations will increase. Because if we don't examine a patient with, say, chest pain, then we will do peer view chest, CT scan, ECG, echo, and whatnot. But if I take a proper history, if you take a proper history and examine the patient, then you can divide it between three common conditions: the musculoskeletal, cardiac, respiratory. And then if you narrow down your investigation, number of investigations. So this is the very important aspect of proper history and physical examination. No, that does not mean that we don't need investigations. We do need investigations because there are certain conditions where you need to do emergency investigations. The very good example is a cerebrovascular examination. Now, if a person comes with acute hemiplegia, we know that the hemiplegia, the opposite hemisphere is affected. That is a very reasonable anatomical diagnosis that something has happened in the right hemisphere which has caused hemiplegia. Such diagnosis is 100% true. Okay. Now, this hemiplegia can be due to ischemia or due to hemorrhage. There lies the problem. Which one? Because the treatment of both are entirely different. So, by proper history and physical examination, we will know probably this is hemorrhage or probably this is ischemic, not definitely. The right hemisphere is affected definitely. We know that anatomically, definite. But probable is either hemorrhage or ischemia. Then comes the possibles. What are the other possibilities which can cause it apart from hemorrhage and ischemia? It may be a tumor, it may be an abscess. Those are the other possibilities. So there comes this differential diagnosis. For these two things, where we are in doubt whether treatment is entirely different for the different differentials, then we might have to take help of CT scan. So then comes this adjuvant or what you call investigations, adjuvant investigations. So nowadays, the investigations have become much more sophisticated, and so has our understanding of diseases, and so has the number of treatment and the different types of treatment which were not present when we were students out then. We never thought of, we never had any idea of biologics. We never had an idea of such strong immunosuppressants, immunomodulators. We did not have CD counts. We only had lymphocytes. We only had neutrophils. So much has changed. Stem cells therapy, we were unbelievable. Diabetes, differential, different types of diabetes. We only had two types, insulin dependent, insulin independent, nothing else. However, are we wiser? Are we more armed than before in curing people? I don't think so. Because cure is something else. Your care is something else, and relief is something else. There are three things: cure, relief, and care. Nowadays, the longevity has increased so much, they're up to 70 years, 73 years, while it was 62 years average Indian longevity. Now it's 73 years. So number of elderly populations increasing, and with this the number of polymorbidity is increasing. Polymorbidity is leading to polypharmacy. Polypharmacy is leading to prescription of 10, 12, 13. I have also seen 19 medicines in one prescriptions. So many medications in an elderly with reduced organ functions, normal functions. So obviously we are treating polymorbidity and causing more morbidity. So why we are giving so many medications? Because we think of cure. Cure is not possible in all, and we have to think of giving relief rather than cure. And if we cannot give relief also, then we have to give care to the patients rather than going for cure. Going aggressively for a cure is not possible and should not be done. So this decision is known as clinical decision making. Machines cannot give you clinical decisions. Endoscopy cannot give you a clinical decision what to do with that ulcer or what to do with that tumor that you are seeing inside the stomach. You are giving cure or you are giving relief. That is, you have to decide. Machines will not do it. Artificial intelligence is not going to do it. Okay. There has been a study in Middle East, very big study, and it was multi-center study. I forgot where it was asked for in the patients were asked, what do you expect when the students and the doctors they come in clinical rounds by your bedside and examine you, talks to you, and 83% said they wanted them to talk to the patients. The patients wanted the students or the internists to talk to them, and some of them said not 80%, but about 70% said they never felt any abnormality or any discomfort by being examined by those junior doctors, but rather they wanted the senior doctors, senior consultants to examine them more than the junior doctors, but they allowed and they appreciated that when they talked to them and when they interacted with the patients. So it means the bedside medicine is still relevant rather than giving a battery of investigations to for a patient. Now, this bedside medicine is decreasing nowadays. There are many conditions, many reasons. The most important reason was found to be here and also in Scotland. In a study, it was found, the conclusion was that time constraint. Nowadays, the doctors are not given enough time to do bedside medicine, clinical medicine. Why? Because they are more they were uh, they were forced to do a lot of paperworks, number one. Then this computer entry for the disease, for the updates, for the follow-up, for writing discharges, and these paperworks, both in the consultant level as well as the houseman level. So time constraint is the most important barrier nowadays for reduction in clinical medicine, bedside teaching, etc. and etc. That is very important. However, we cannot deny the importance of artificial intelligence and very advanced investigative gadgets. Nowadays, these gadgets are you can allow the patient to wear something and to transmit the findings rather than waiting and examining the patients. And these, suppose a halter monitoring can give you more information than your bedside examination. Everyone will agree. Then you can also transmit the patient's data to specialists for opinion and other investigations for treating the patient. And also, the other artificial intelligence can also help you in formatting the algorithms and go about how to treat that particular patient. And genomics, which has got tremendous improvement in the investigation wise as well as in diagnosis in the last 2-3 decades, it's also helping us too much. But the bottom line is bedside clinical medicine has got one thing which cannot be replaced by any pharmaceutical agents or any investigative gadgets or any artificial intelligence is the human touch. It has been proved beyond doubt that many patients wanted to be um, touched, wanted to be touched, wanted to be listened to by the doctor, and that gave them a tremendous amount of satisfaction. Almost all patients, they said they appreciated it. So this human touch, just sitting by the patient and talking to the patient and giving some reassuring words or giving them some smile, just smile at the patient and talk to the patient sympathetically and making them feel important and not leaving the bedside with just a random touch of stethoscope. These things will definitely have some effect on the holistic treatment of the patient. So this holistic nature cannot be replaced by any machines anywhere in the world, and everyone has accepted it. And therefore, this human touch is the most important part of a doctor. If I may be allowed to say, uh, our professor of dermatology in Assam Medical College was Professor T.C. Saikia sir. Then we had internship, and for 15 days we were posted in the dermatological ward. And he said on the first day of my internship, I mean posting in dermatology, he said যে কিয় আহিছা মানে মেডিকেল কলেজত MBBS পাছ এতিয়া ইণ্টাৰ্ণি why have you come sir doctor হ'ব খুজিছো. So he said, remember one thing, to become a man is very easy, a doctor, but to become a human is a little bit difficult. So that separates you from being a good doctor and a bad doctor, and not so good doctor. Not bad. That is the difference between good doctor and not so good doctor. So be human. So sometimes we lose our temper with patients. So patients load is there. We snap at the patient sometimes. Some person who is shouting in pain in the ward, and the houseman is busy with another serious case. And sometimes we fail to give this reassurance, or what do you call it, this human touch to our treatment for the patients. So I know it's difficult. That I have faced. But coming back to the emergency section, in emergency room, whenever we are posted, and whenever I was posted, whenever patients came in a serious matter, I mean serious condition. So at that time, being young, we wanted to diagnose what is happening to that patient. We wanted to give treatment for that particular diagnosis. We did not think that at that time the diagnosis was not important, but resuscitation was more important. Giving resuscitation means giving him the necessary support by which he was not in danger of immediate catastrophe. So that was the motto which was propagated by most of the educationists. They don't try to give curative treatment in the emergency room. So it brings us to those three things: relief, care, and cure. Cure we will do in the ward later on, but first give relief. Acute abdomen, there was a seminar, panel discussion yesterday, acute abdomen. So when a patient comes with acute abdomen and possibly vomiting, no, we are not interested in whether this is intestinal obstruction or this is perforation or which is. Oh, we just want to give him relief and delay the catastrophe, if any, by putting in a Riles tube. This is the first thing that we have to do. Put in a Riles tube, put in an IV fluid, and then you do the physical examination, and the only necessary investigations. If we do not know the causes of acute abdomen, if we do not see the patients, then we won't have experience. And after having proper experience of 1 year of internship, 1 year of housemanship, if we do not know, even then, after 2 years of training, even then, if we do not know what are the causes, then what we will do? We will give a large number of investigations, not a focused targeted investigations, but large number of investigations, and this is a sign of a panic of the doctor. The doctor becomes panicky and gives a large number of investigations. This is called walking in thin ice syndrome. Walking on thin ice syndrome. So to develop that focused experience, you need training, and you need to be by the patients, as many patients as possible, so that you gain an experience. And sometimes later on, when you are uh, uh, senior enough, like Ramamedhi sir, you have that intuition. Sometimes without touching also, Medhi sir might say, this looks like this. Okay, because I have seen so many earlier, so many patients, and exactly they came like this. And more often than not, that is the final, appears to be and comes out to be the final diagnosis. So, intuition, experience, these are different things. These are important, and for that you need to be a little bit intelligent. Intelligence cannot be defined. There is no definition for medical intelligence. There is no definition for medical experience. These are all subjective, but these are important. Another mistake we do, I did, and I still do, is to give more importance to some findings which are not probably relevant. In an elderly person who is having pneumonia, he is admitted, and possibly he has got a little bit of sclerosed bicuspid aortic valve, and there is a small aortic stenosis murmur. Instead of giving more importance to the actual pneumonia, I am maybe excited because I found out a small aortic stenotic murmur. Oh, dangerous. So there may be something cardiology. Hemkolita is to be, he is to be consulted, and there may be something very dangerous. Harmless bicuspid aortic stenosis, no, nothing is to be done. Treat the pneumonia, only then it will be important. It will save the elderly man, isn't it? The last, I'll be finishing my so-called presidential talk, because these are the problems I face, and I have learned the hard way. Then another example I'll give. One of our senior professors was admitted about 6 months back, severe cough. He was in a gynecological department. He had cough. Everybody has cough nowadays. Every month we get cough post COVID. Everybody has. Then that cough was not relieved by cough syrup. First he took azithromycin, yes, and he did not get relief, and he started having a little bit of dyspnea also, and severe hacking cough of 24/7. He was admitted, and as usual, we sent all the respiratory things for culture and sensitivity. The report came that there was very heavy growth of Klebsiella pneumoniae, sensitive to so much, so many drugs, this and that. The growth was very heavy of Klebsiella pneumoniae. Okay, fine. Treated with the intravenous sensitive antibiotic. Then after 2 days, he called me, Dada, I'm going to Guwahati Medical College. Why? I'm not getting any relief. So the cough is not reduced, and I'm still having this. I said, okay, just wait. I sent the blood and the respiratory samples to the ICMR. We have ICMR nearby. And I asked the scientists to do a panel. I said, don't do the respiratory panel, do the viral panel. Okay. So it came out to be a, uh, a virus, COVID 43 or something like that. Okay. I just gave corticosteroids, and after 2 days, he was okay. So that is one thing that has to be kept in mind while ordering and interpreting investigations. The golden rule I tell my children, my juniors, that if you are giving something, patient is improving, and your report is something else, something else, some other drugs is to be given for antibiotics, suppose, but the patient is improving, don't change the antibiotic, because this is a very common mistake. This they do. The culture report is this, so I will give this medicine. But in fact, the patient is improving with the previous medicine, empirical treatment. So that should not be changed. Number one, and number two, uh, I believe in the old dictum, because I belong to the old school, that the diseases which come have the common causes. The commonest cause is the common. We should not think of the rare diseases first, and we should always think of the common diseases. And it's only, these are only my experiences. I'm not giving you a lecture, or I'm not giving you some advice or something like that. All of you are very learned, and over these last 2 days, the quality of lectures that I have heard, I have learned many things. 3 4 things I have learned, and it's been a pleasure in the last 2 years being on the helm of affairs in API Assam, and this my our term has expired, and thank you so much. Thank you so much.
Thank you for your very nice deliberation. Actually, we have learned too many things from your lecture, and everybody of juniors also probably has taken a lesson from this lecture. And I think there will be no question allowed for the oration. We'll just close the session. We'll move to the further proceedings.
Moving on to our next session. It gives me great pleasure to introduce our chairpersons for this session, Dr. Prashanta Dihinya, Dr. Priyam Goswami, and Dr. Daisy Rasbongsi. I kindly request you to grace the dais. I'm also delighted to introduce our speaker, Dr. Amritangshu Borkakoti sir, who will talk about the topic management of cirrhotic ascites.
Hello, Dr. Abitangsu, a hepatologist, DM in hepatologist. He's a very brilliant student. From the first day I know him. He's a student of Assam Medical College, now doing in Name Care Hospital, doing hepatology mainly, and even gastroenterology also. So I request Dr. Amitangsu to start your topic.
Thank you, Chairperson. Good morning, everyone, my respected teachers. I must thank APR Nogramans, Dr. Goswami sir, Dr. Swartkev sir, and specifically Dr. Arup Surji. It was decided last night, 1 a.m., that I have to deliver a talk. So anyway, this kind of patients are quite common in our clinical practice. So it's deep jaundice, ascites, you can see, and deep umbilical hernia. So this kind of patients repeatedly comes to our chamber with cirrhosis and ascites. Now, once a patient of cirrhosis develops ascites, which means there is significant damage to the liver, there is significant portal hypertension. And that's why if a patient develops ascites, the short-term and long-term mortality is very high. So this, which is called decompensated cirrhosis, when a patient develops decompensation in the form of ascites, the mortality rate increases. Now, if you can recompensate with treatment and make him ascites-free, the survival is better. So meet Mr. YY, who is a 47-year male with occasional alcohol and diabetes. First time presence with gradual distension of abdomen. So what will you do first? So first is the grading of ascites, whether it is mild, just detected on ultrasound, grade 2 or moderate ascites, or tense or grade 3 ascites. Grading. Then, as Dr. Anubdas sir has said, and I was taught in AMC, whatever you do in your life, you must be a clinician. So first is clinical history and proper examinations. You must look for the signs of liver failure. You must look for the signs of heart failure, nephrotic syndrome, tuberculosis, and malignancy in a patient with ascites. Now, whenever the first patient comes to our chamber, you must evaluate his liver function and renal and circulatory functions. Etiological test for liver cirrhosis, hepatitis B, C, diabetes, the normal liver function test, PT-INR, CBC to look for thrombocytopenia, and you must do an cross-sectional imaging with triphasic CT or MRI to look for HCC or portal vein thrombosis or simultaneous other non-liver pathologies. In a cirrhotic patient, you must do an endoscopy to rule out esophageal varices. Look for the renal dysfunction and circulatory failure markers. Urinary sodium potassium is very important in patients with cirrhosis and ascites. And then you work up for ascitic fluid analysis. So you do ascitic fluid tapping in a patient with grade 2 and grade 3 ascites or new onset of grade 2 or grade 3 ascites or a patient who is doing well on your management, then suddenly worsening of ascites, patient developing encephalopathy or renal dysfunction, you must do a diagnostic tapping. Now, it was previously very fearful procedure. Not there is no routine need to transfuse with FFPs or platelets, even if the PT-INR is very high or platelet count is low. Except in a case of clinically evident DIC, you can do it is a very safe procedure. And you look for the total count and differential count, protein, sugar, and ADA. You must calculate the SAG score, what is the serum albumin and ascitic fluid albumin gradient. Now, rather than classifying patients as high protein or high transudative, exudative ascites, make a habit to classify them as high sag ascites versus low sag ascites. High sag ascites means the ascitic fluid albumin gradient is more than 1.1, which means there is portal hypertension. High sag, low protein ascites means portal hypertension. The low sag ascites are the other causes like nephrotic syndrome, tuberculosis, or peritoneal carcinomatosis. Now, broad lines of management is grade 1 ascites, just dietary restriction of sodium is important. It resolves. Grade 2 and grade 3 ascites require specific treatment with diuretics, tapping of the ascitic fluid, and so on. So, most common we use lesilectin, that is Lasix and furosemide and spironolactone combination, and this combined schedule versus the sequential approach, you start with Lasix and then start gradually add spironolactone. Now, when we combine this schedule, the ascitic mobilization is better. The control of ascites is better when you combine a furosemide with spironolactone. Other diuretics like torsemide is available, which is more potent than furosemide. If the patient is not responding to furosemide, you might have to switch to torsemide. Spironolactone sometimes causes painful gynecomastia, and you may have to switch to amiloride, even though it is less potent. Now, please remember that lesilectin 40 is equivalent to ditor plus 5 mg. So, ditor or torsemide is more potent. You need to give a low dose to prevent renal dysfunction. Once you started on a patient on diuretics, you monitor the weight loss, which is very important. If there is peripheral edema, you must lose 1 kilo per day, or if there is only ascites, no edema, 500 grams per day is sufficient. Do not be in a hurry to escalate the dose. You must go slowly. Every 3 to 4 days, you escalate the dose of an diuretics. Once the ascites is completely resolved, you should reduce the dose. You just should not stop immediately, because the ascites might reappear again. And if there is inadequate response, you calculate the urinary sodium. If the patient is excreting sodium and he is not losing weight, that means he is consuming more salt. If the patient is not excreting enough sodium with diuretics, that means he is diuretic resistant. So urinary sodium is essential in case of non-response to diuretics. When you discontinue diuretics, if there is side effects like serum sodium is less than 125, in cirrhotic patients, the sodium is anyhow it is low, 125, 130. So if it is less than 125 only, you stop. Or if there is severe muscle cramps, sometimes it develops with furosemide, renal dysfunction or hepatic encephalopathy, you discontinue diuretics. Potassium high, low, you stop spironolactone. In case of severe muscle cramps, you can add albumin or baclofen also. Now you have started the patient with diuretics. You controlled his ascites. After a few months, he again comes with severe pain, abdomen, fever, and distension. What is this called? This is called spontaneous bacterial peritonitis, which means there is infection of the ascitic fluid without any definite source of intra-abdominal focus. If the ascitic fluid total count is more than 250 neutrophil count, it is called SBP. You might get a culture, or you might not get a culture, but if it is more than 250, you start an antibiotic. So the basic core principles in management of SBP is you tap early, even if there is slightest suspicion. Identify the clinical setting, whether it is community acquired or nosocomial. Associated organ failure, like any other infection, you look for signs of circulatory dysfunction, renal dysfunction, or hepatic encephalopathy. If it is a community acquired third generation cephalosporins like cefotaxime is beneficial. But if it is a nosocomial or in hospital acquired infection, you straight away start with a carbapenem, imipenem, or meropenem. If there is no response within 48 hours, you add tigecycline. Look for fungal infections also in patients of cirrhosis and ascites who are repeatedly on and off the hospitals for dripping and all, who are on prolonged antibiotics, diabetics, CKDs. Fungal infections are also quite common in ascitic fluid. Now, once a patient develops SBP, you put him on indefinite duration of antibiotics. Most commonly used is norfloxacin or ciprofloxacin till ascites resolves or till he gets a transplant. This is called secondary prophylaxis after development of an episode of infection to prevent reinfection. There is a concept of primary prophylaxis, which means before the development of infection, some patient with advanced cirrhosis who have a borderline renal function, lower sodium, or urea BUN is high, you must have give primary prophylaxis with ciprofloxacin or norfloxacin to prevent SBP. Whenever a patient develops acute varicose hemorrhage, a short course of antibiotic is required to prevent infection. Now you have treated his SBP with antibiotics, you send him home with diuretics and norfloxacin or ciprofloxacin as a part of secondary prophylaxis. Again, he comes few months back, again requiring repeated tapping. Sir, pani ulai goisilo hai, ako pani jama hoise, which is quite common. So this is called refractory ascites. When a patient develops ascites in spite of a good dose of diuretic or he is not responding to the dose of diuretics. So there are two classes. One is diuretic resistant. You are giving the maximum dose of diuretics, spironolactone and loop diuretic combination, but it is not resolving. One is Second is diuretic intractable. Intractable means you cannot give the adequate dose because of the side effects like muscle cramps, AKI, encephalopathy, and all. So the core diagnostic criteria is a good dose of diuretic, recurrence of ascites because of repeated multiple factors. Now, once a patient develops refractory ascites, his mortality increases further. This means there is no, the renin-angiotensin system. The whole hemodynamics is worse. So you must first counsel them for liver transplant. India is becoming the hub of liver transplant. Nowadays, people are affording, the learning curve has improved. So transplant, you must counsel whenever a patient comes with recurrent episodes of ascites. Now, not everyone can afford transplant, so what will you do? Second is, most of the patients are on beta blockers for varicose prophylaxis. Now, you must have seen that cirrhotic patients have a very borderline BP, 90 by 60, 100 by 60. If you continue with beta blockers, the renin-angiotensin system and that everything again reactivates, and the ascites accumulation is more. So you reduce the dose of beta blockers. Carvedilol, most of the patients on Cardiovas or Carvedilol, you stop Carvedilol. If at all you have to give beta blocker, you give propranolol. You do an endoscopy. If there's large varices, you do banding, but you reduce the dose of beta blockers, or better to stop it. You can reintroduce if the circulatory dysfunction improves. So beta blockers must be stopped. If not at all, you can reduce the dose. Large volume paracentesis is the treatment of choice for grade 3 or trans ascites. By definition, it means removing more than 5 liters of fluid in a single go. Now, 5 liters, why this cutoff is 5 liters? Because if you remove more than 5 liters of fluid, there's significant amount of fluid is removed, and our body goes into a state of relative hypotension, and the renin-angiotensin system is reactivated again. The ascites accumulation is even rapid. So you give albumin to prevent what is called PICD, post-paracentesis circulatory dysfunctions. So if you remove more than 5 liters of fluid, you must give albumin. But if you remove 2, 3, 4 liters, they might not require albumin, except in certain situations like ICU setting, or if patient is of acute on chronic liver failure or shock, where you just need to give some comfort to the patient. You remove 2, 3 liters fluid, but you need to give albumin also. But otherwise, up to 5 liters, it is safe. Now, if we remove the fluid, that doesn't solve the problem. It doesn't improve the hemodynamics. It just gives the relief. So what you can do for refractory ascites, it's called TIPS. What is TIPS? It is an radiologically placed stent between the portal vein and the hepatic veins. So it reverses the whole hemodynamics. It reverses portal hypertension, and the ascites control is significantly better. Now, it is available in our clinic setups. So TIPS is an option who have refractory ascites. Previously, now see, whole burden of portal pressure is transmitted to the heart. So your heart should be normal. Cardiovascular uh, workup is important. You're diverting the portal blood into the systemic circulation. So hepatic encephalopathy is a common complication of TIPS. Now that's why previously the mortality rate were higher with TIPS, or it was at par with standard medical management. Nowadays, they use a smaller diameter stents just to reduce the portal pressure, and the side effects are also lower. That's why, with recent trials of TIPS, the mortality rate is better, survival rate is better. There is a concept of long-term albumin infusion in patients with cirrhosis. The concept is to elevate his serum albumin level more than 3.5, and if you can maintain that, sustain that, the ascites control is better. There are limited trials, one is positive, one is negative, but some European guidelines have added that refractory ascites patients can be benefited with long-term infusion of albumin once in a week up to 6 months to 1 year, and it improves ascites control as well as improves survival. But as routine practice, it is not recommended for 1 or 2 episodes of ascites. It is just recommended for refractory ascites where the patient is not suitable for transplant or TIPS. You can continue with albumin infusions. Midodrine is available, which is a good alpha-1 agonist. It improves systemic intraabdominal vasoconstriction and improves the hemodynamics in the patients with refractory ascites. It prevents PICD. You can use midodrine after tapping if albumin is not available. It improves ascitic fluid mobilization. Plus, in hepatorenal or patients with ascites who have renal dysfunction, midodrine helps in control of ascites. Now, there are trials combining midodrine with albumin versus standard medical management, and the control of ascites and everything is better. Please do not forget a good nutritional prescription in patients of cirrhosis ascites because they require a good number of protein and calories to prevent malnutrition. So just what are the do's and don'ts in patients with cirrhosis and ascites? Salt-restricted diet, start with diuretic. If not responding, do a spot urine sodium potassium. You assess the response and titrate. You look for infections, portal vein thrombosis, even liver cancer, ACC in patients with cirrhosis and ascites. Paracentesis more than 5 liters, only with albumin. If the patient is not responding or not tolerating the diuretics, we look for the options of serial LVPs, those who cannot. You look for whether he's a candidate for TIPS or it must counsel it for liver transplant. What are the don'ts? Don't over restrict salt. It is not palatable. It leads to malnutrition. Ekebare nimok nakhabo. This is not advisable. Beta blockers, it should be stopped or reduced to a minimum dose. You should not increase the dose of diuretics very frequently, over diuresis or under diuresis, or just doing 2-3 liters of tapping today and again 2-3 liters tomorrow. It increases the risk of infection. So frequent tapping is not required in a small volume. And sometimes some patients were counseled for TIPS in the earlier stage when we can control it only just diuretics or albumin. So it should not consider TIPS as a first line of treatment of ascites. So in our health setup, our patients are different because of economics. Our patients have a low BMI. The tolerance to diuretics is also lower. They develop AKR, muscle cramps. It's a very low dose of diuretics. Concomitant tuberculosis is also quite common in patients with cirrhosis and ascites. So we must exclude tuberculosis in a patient of cirrhosis with ascites. So stepwise management, confirm the diagnosis, this is cirrhosis, then start a diuretic. He is not responding, he remove the fluid, look for infections, portal vein thrombosis or liver cancer. Tapping always with albumin if you are tapping more than 5 liters of fluid. Recurrent ascites because of multiple factors, he is not responding or he is resistant to diuretics. You look for the options, whether serial just doing tapping in a frequent interval is sufficient, or TIPS or liver transplant. Also, the concept of adding midodrine with albumin in the long term is also beneficial. But per se, midodrine and albumin combination almost 20 to 30,000 per month. So this must be taken into account. So our target is to improve the quality of life of a patient with cirrhosis and ascites. So you must do the permutation combination to what modality is beneficial to the patient. Thank you.
Thank you, Dr. Amritanshu. That was an excellent talk. And this is a very commonly encountered clinical problem. And you have very well elaborated on the management, starting with low dose diuretics to the management of refractory ascites. We may now have a few questions from the audience.
See, in our setup, patient who does not go for TIPS or liver transplant, they are coming for repeated ascites. The cost of albumin is 7,000 per bottle.
Yes, sir.
So, what is the alternative saline we can use in except albumin if we remove 5 liters of fluid?
Yes, sir. So people have used FFAs, plasmas. People have used that. I forgot that fluid.
Hemaxil.
Also. Yes. So if at all you have to give something, give albumin. But if not possible, then hemaxil also. But up to 5 liters, it is safe.
Can you substitute with white of egg, 2 eggs or 3 eggs, except albumin IV?
What, sir?
বগা কণীৰ বগাটো খাই substitute হ'বনে?
Yes, yes. Nutrition is an important, but for tapping, if you do tapping, you're removing gross amount of fluid. Then only I'm talking about the PICD or the circulatory dysfunction. In the long run, these things dietary motivation definitely improves. If you can improve the albumin level up to 3 or 3.5 with diet only, it's a very good thing.
Those patients who cannot buy albumin IV, there is a albumin powder in the market. Can it substitute?
No, it's for nutrition. That is albumin infusion for tapping. That's totally different. It is
What,
for volume replacement. Other is for nutritional replacement.
my last question is what is the longevity after tips?
Yes, tips, as I have said, sir, longevity improves with a shorter diameter of tips, and if you select the patient carefully, he doesn't have hepatic encephalopathy, he has a good cardiac function, then the longevity definitely improves, because if you control ascites, patient's longevity improves.
Sir said that about the albumin, because most of the patients they are not affording the albumin. And because of now Ayushman, they are getting some patients. Because most of the patients we are advising the egg white. So how many eggs you have to give that and how it helps actually?
So albumin intake actually helps in improving nutrition. There is no number. You can give 5, 6, 10, 20, whatever he can consume. But if you add salt, nimok lagai lagai khale, there is no benefit. He is taking more sodium. So has to be 4, 5 egg whites without adding salt is helpful actually. So there is no criteria kiman khabo lage, but jiman khabo pare himane bhal.
Besides egg whites, any other protein any other protein supplement orally?
Yes, yes. So those who have hepatic encephalopathy or those who have nutritional deficiency, any kind of protein, vegetable source, animal source, any protein helps actually.
Thank you. Thank you. Conclude the session.
Thank you, Dr. Amitangsu, for your enlightening talk. And now we conclude the session here.
Thank you.
Thank you so
everyone.
much.
Thank you for that enriching and well articulated talk. Up next, we have a panel discussion, for which I would like to call our chairpersons to the stage, Dr. Anjan Saikia, Dr. Panchanan Khaklari, and Dr. Asif Iqbal. I request you to kindly grace the dais. I welcome our chairpersons to the stage, Dr. Anjan Saikia, Dr. Panchanan Khaklari, and Dr. Asif Iqbal. Yes, sir. And now may I invite our esteemed moderator, Dr. Bikas Narayan Chaudhary, sir, Professor, Department of Gastroenterology, GMCH. I would also like to invite our respected panelists for this session, Dr. Kamal Chhetri, sir, Dr. Utpal Jyoti Deka, sir, Dr. Rajiv Bora, sir, and Dr. Shahidul Islam, sir. We warmly welcome you to the stage.
Good morning. On behalf of myself and from my all panelists, before starting the panel discussion, I offer my sincere thanks and gratitude to the organizing committee, giving us the opportunity to do this panel discussion on one of the important clinical problem frequently we face, and something which is no definite single treatment also. So we will like to elaborate some things regarding the pain management, which is a predominant symptoms of the chronic pancreatitis. Almost 90% of the chronic pancreatitis suffer from pain, and for which they usually come to the medical help. So I will start this panel discussion with a prototype of patients. My patient is a 56 years male He is a chronic ethanol abuser, more than 10 years, approximately 80 grams per day, having pain abdomen since last 3 months, moderate to severe, constant in epigastric area, sometimes occasionally back radiations. On clinical examination, hemodynamically stable, abdomen examination only found to be the tenderness in the epigastric area. So this is the laboratory test. Hemoglobin is 9, almost normal. Amylase lipase is normal. Remind it, in chronic pancreatitis, always amylase lipase will be normal because there is no parenchyma. And LFT is normal. That my resident did one X-ray abdomen as a protocol of work as a acute abdomens, found to have calcifications in the pancreatic area. CT scan was done. There is a large stone in the distal or head of the pancreas with proximal dilatations of the main pancreatic duct. So clinical diagnosis is a chronic calcific pancreatitis. So what is chronic pancreatitis? It is basically a progressive inflammatory fibrosing disorder damaging the duct as well as the parenchyma. Typically acquired, but sometimes it may be your genetic, because of genetic abnormality also develop pain. So chronic pancreatitis. Pain is the cardinal and most debilitating symptom affecting 80 to 90% of the chronic pancreatitis and profoundly affecting the quality of life. Pathophysiology of the pain is complex, multifactorial, encompassing the peripheral mechanism, both and central mechanism. Because of complexity of the pathophysiology of the pain, it is very difficult to treat. There is no single targeting agent which can provide the relief of the pain. So this is the natural history. Initially, some patient may develop as a acute type of pain, appears to be the acute pancreatitis, subsequently have recurrent, and subsequently develop the chronicity. And some patient present as a directly as a chronic pancreatitis. So classifications of the chronic pancreatitis basically 3 types. One is obstructing type, one is calcific type, and one is steroid responsive autoimmune type. So these are the pathophysiology of the chronic pancreatitis leading to the pain and enzyme insufficiency and sometimes endocrine insufficiency also. Basically because of fibrosis, loss of acini, islets, PD stone, calcifications, and parenchymal ductal strictures and stone obstruction. These are the different causes of pains, central sensitization. There is a 2 types of plumbing defect and wiring defect. These things happens in the chronic pancreatitis. I will not go to the details of these mechanisms. So the pain assessment can be done with the bedside by different methods. So management strategy, as the pathophysiology, the pain of the chronic pancreatitis is multifactorial. So effective management requires comprehensive, individualized approach. It should address the peripheral and central mechanism. Current treatment paradigm is step-up strategy. So these are the treatment modalities. The first, my questions to Dr. Sahidul. What are the lifestyle changes and dietary changes you will advise to manage the pain in chronic pancreatitis?
Thank you, sir. So first, as we know that we definitely don't know the mechanism exactly why it is happening. So, and we know the factors that lead to this chronic development of this chronic pancreatitis. So first foremost, for this person, the most important is alcohol cessation. Stop drinking alcohol. Though it has been found that cessation of alcohol does not stop the progression of pancreatitis, but it has been found in studies that it definitely relieves pain and definitely decreases mortality. Second is if the person is a smoker, smoking, stopping, that has to be very, very stringent. There are numerous studies which says that smoking is associated with severe pain, increases, it aggravates the disease as well as it's associated with progression of the disease. So smoking cessation is another important point if the person is a chronic smoker. And there are some other things like this addition of antioxidants, but it is again controversial. There have been 2 studies, one in India, one in UK. In Indian study, they found that people who are not alcoholic and who are young had some benefit with this antioxidants like methionine, and vitamin C, vitamin E, all those things. But in another study in UK, they found that elderly with alcoholic elderly who suffered from chronic pancreatitis, they didn't have any effect on the pain with this dietary means like this antioxidants. And the other thing we can do is that fat. We have to. There was it is natural that fat aggravates the thing of pancreatic enzyme release, so it aggravates the pain. So we are taught and we have been going restricting fat for this pain management. But recent guidelines say that fat total stoppage of fat is not recommended because it leads to nutritional deficiency and other things. So it is individualized approach. I think that is okay.
So Dr. Sohidul will explain to want to say if the patient is a alcoholic or ethanol abuser, first advice and counseling should be stop alcohol because the continuous alcohol consumption increases the progression of the disease. Next is smoking. Smoking also, lots of studies shows smoking increases the fibrosis, inflammations, and leading to the more progression of the disease. So if we can stop smoking and alcohol, if it's an alcohol abuser or smoker, that will halt the disease progressions and sometimes the relief of pain also. And diet. It is dictum that in pancreatitis patients, always you should advise to take small volume and frequent food, avoid fried food, and don't destroy the diet containing antioxidant. That means don't overcook the vegetables. At least little bit of undercooked vegetables you should take. These are the basic advice for in the diet and lifestyle management. So next is Dr. Utpal Jyoti Deka. How will you manage pain in this type of patients, especially in the painkiller, both opioid and non-opioid?
Thank you. So, especially in case of chronic pancreatitis situation, as the disease is chronic and it is a long term, so we should use the as much as possible initially low potent or non-opioid analgesic. So we usually prefer the who recommended the pain relief ladder, that is sequential introduction of many this is for analgesic with for low potency effect, then with subsequently high potency effect, and then titrated till the pain is relieved. But that is applicable in most of the time in mild to moderate pain if I see patient presents it. But in this patient, if it's severe pain, patient presentation may in even chronic pancreatitis also severe pain. In that situation, initially first some high potent analgesic may be required. That is called top-down approach.
Yes.
So sometimes when so that is the approach for the pain relief.
So just like other chronic pain, we used to follow the WHO pain analgesic ladder. Started with a lowest potent NSAIDs, like even paracetamol also, if it's a mild pain. And if the severity of the pain is increases, we can increase the potent analgesics. If not control, we can use the low opioid effect like tramadol and combination of painkiller. So that our aim is to get relief of pain from the pancreatitis. So next is Dr. Rajiv Bora. Is there any role of analgesic adjunctive in the management of pain in the chronic pancreatitis? Because I already mentioned in the pathophysiology, there are two types of problem. What is plumbing? That means abnormality duct, either in the obstructions or strictures or stone, or one is the wiring. That means nociceptive. There is a nerve in the surrounding the pancreas. So that may be because of repeated inflammations. The nerve number may be increased and there may be nerve may be hypertrophied, and this next second order neuron is the dorsal horn that may overreact, and ultimately it may go to the cerebral cortex. There may be over perceptions of the pain. So is there any role of adjunctive of analgesic, Dr. Rajiv?
Sir, right, sir. Thank you, sir, for the question, and thank you, Nagaon API, for giving me the opportunity to sit here. So, as you have said that yes, there is a role of adjunctive means addition to painkillers, some other medications which might be helping in the long run to decrease the pain. One, it is written in the slide, that is the gabapentinoids, the voltage-gated calcium channel blockers, because we know that in a patient having chronic inflammation, the nerves surrounding the pancreas are also stimulated, their threshold goes down. So we have to block those nerves. So for that, gabapentin will be a very good additive, and it also has some sedative effect. So at least the patient might be able to sleep a bit better in those type of patients. So that is one part. I want to highlight one new molecule that is given now quite regularly. That's a synthetic opioid, tapentadol. So it is said to have two mechanisms of action. One is it basically blocks the morphine acts like a morphine agonist. So yes, it acts like a typical opioid analgesic. And the second is also it decreases the norepinephrine reuptake inhibitor. So yes, those type of medicines are definitely necessary in chronic pancreatitis pain management. Thank you, sir.
So before going to the next questions, I invite all the audience to participate because this is a common clinical problem we frequently encounter. If any doubt or any opinion or any comments, please give us. Next question is Dr. Kamal. Frequently used the pancreatic enzyme, any pancreatic disease, chronic pancreatitis, acute pancreatitis, which is frequently, rampantly used. So is there any role of pancreatic enzyme in the management of pain of the chronic pancreatitis?
If you look at the literature for pain management, it does not.
Does not, yes.
But if you ask me, do you use? I do use, right? And I see most of the prescriptions of gastroenterologists, they
commonly
use
used.
it like Udiliv of liver disease, of whatever penlipase of part is for.
Just like chronic liver disease, SAMI.
SAMI.
Everybody uses SAMI.
UDCA or SAMI,
SAMI.
whatever.
But there is no evidence-based result of the beneficial effect of SAMI and UDCA.
So like any fatty liver UDCA. So any pancreatitis part, right? So that is what is the common practice. But if you look at literature, there is no statistically significant evidence in the literature which will reduce the pain of chronic pancreatitis if you use part.
Yes.
But might reduce the some of the symptoms of chronic pancreatitis in the form of bloating, distension, discomfort, all those times, because some of them also related to maldigestion. So deficiency of pancreatic enzyme happens in the chronic pancreatitis, but some of them are related to maldigestion, not the plumbing or wiring that what Dr. Vikas said may not be related to that kind of pathophysiology. So we use, but the scientific evidence is very limited.
Yes. So scientific evidence for supplying the prescribing the enzymes in management of pain is less significant result. Only few situations like in early chronic pancreatitis and giving your the non-enteric coated tablet have some benefit in the study. So Dr. Rajiv, again, next question to you.
Right, sir.
Because the pancreatitis itself is an oxidative stress. There are lots of oxidative free radicals in the pancreas. Is there any role of antioxidant in the management of pain in chronic pancreatitis? Because these radicals stimulate the nerves.
Right, sir. Right, sir. So they are said to be a role. Means it's a controversial term because one study has said, as Seidel said, that it has no action, and another study has said that it has some role. But we know that like stellate cells that are present in liver, there is also stellate cells which are present in the pancreas also. The thing is that stellate cells, when they are stimulated, like in chronic infection, always releases free oxygen radicals. So yes, to curb that, probably the antioxidants will be helpful. And the thing is that these antioxidants, if you go for vitamin C, like ascorbic or something, these are not very costly things. So a strip of Lim-C will cost hardly 25 rupees for 10 tablets. We can continue that.
So study shows combination of antioxidant have some benefit in the management of pain. But single antioxidant does not have any benefit in the management of pain.
Right.
The hypothesis is that there is a free radical injury producing the stimulate the stellate cell increases the fibrosis. So we have to give the supplement of antioxidant so that free radical injury will be less.
Right, sir.
So again, Kamal, I am coming to you. So what is your opinion regarding the endoscopy, therapeutic endoscopy? Because we are usually not doing very commonly, frequently, but most of our patients going to the outside, then everything is done. ERCP, ESWL. But after returning back to the again, whenever he landed to the Assam, again he will have pain. He will come to us. So we have done everything. Again, recurrence of pain and stone is there. So what is your opinion?
So regarding this thing, role of endoscopic management in pain of relieving pain of chronic pancreatitis, there are certain situations where there is a role.
Particularly, there are two types of situation where endoscopy can help. One is this management of the stricture, and another is management of stone, right? If the stricture, which is single and which is located in the head and the neck part of the pancreas, which can be reached by doing ERCP, by whatever instrument that you use, balloon and all, then you can dilate, place a stent. It will get some relief, and the pain because of stricture, if it is because of ductal hypertension, then some of the pain will be relieved. This is number one situation where you will use. Number two situation is the management of stone. Again, very complex stones situated all over the pancreatic duct and parenchymal stone cannot be treated with endoscopy alone. So only small stones around 5 millimeter in
Less than
size
5 millimeters.
and situated in the head and the proximal part of the body can be tackled with endotherapy or ERCP alone. If the stones are bigger than 5, you should go for additional armamentarium, like you said, ESWL, and say nowadays we have that laser.
Yes.
Pancreatoscopy and
Pancreatoscopy and laser lithotripsy.
can be used for management of 5 to 10 millimeter or even bigger stones situated in the body and part of the body of this thing. But parenchymal stones cannot be taken care of. Another situation where endoscopy might help is management of pseudocyst.
Pseudocyst is very good.
If there is a pseudocyst which is related to chronic pancreatitis, US guided or even without US guided, sometimes we can drain. This is one. And another situation where it is very useful is pancreatic ascites.
Ascites.
If there is a pancreatic duct leak, doing ERCP and placing stent relieves the situation, and patient gets a very good quality of life. And other than in chronic pancreatitis itself, if the patient develops benign biliary stricture,
yes,
this is one situation
one
where
important indication.
endoscopic treatment has definite role. So these are the areas where endoscopy might help.
So according to you, there are only few indications for going for the ERCP in the setting of chronic pancreatitis. So first is in the primarily pancreatic disease in the stone in the head or stricture in the head regions. There may be a beneficial effect doing a ERCP, pancreatic sphincterotomy, stenting, and stone removal either in the direct basketing or ballooning or in the extra shock wave lithotripsy. So others are the associated symptoms, condition like pseudocyst, giving compression, giving pressure, reducing, producing pain, or sometimes pancreatic leak, having pancreatic ascites, pancreatic pleural effusion. In that situation, that is your sphincterotomy and stenting will help. So next I am going to these are the things endoscopic therapy done. So pain. So again, Rajiv, is there any role of ESWL for the management of pain?
Right. Setisa has obviously said that there are some specific, very limited roles of ERCP, and this also goes to ESWL. Yeah. As Setisa has said that there is some very specific roles of ERCP. So likewise, also ESWL has also some very specific roles. So ESWL cannot be done if a patient is having like a pseudocyst, or if the WN wall of necrosis, or if the patient is having pancreatic leak. Pancreatic leakage, definitely the putting a stent through across the leak will definitely give a very good result for the patient. In ESWL, if the stones are, as you have said, more than 5 millimeter, it's distal to the head or neck region of the pancreas, it definitely has a role. In comparison, also, if you go for ERCP, generally, when you are trying to pull out the stones in ERCP, as those are basically calcium stones, the chances of a puncture of the balloons are too common. So, and these balloons are also very costly. So, probably I would say the ESWL will be a better option for this patient if we think about the cost factor also.
So basically, one point here is the important point is here
availability.
Availability.
Yes,
Number one is availability, and number one point should be remember always. We should remember it. Stone is not causing pain. There is no relation of presence of stone or pain. Stone is not a cause of pain, so we should not target the stone until and unless there is obstructions in the head regions or strictures. That means giving rise to the increased intraductal pressures and pressure ischemia of the surrounding parenchyma. Otherwise, there is no role. If you remove stone, patient will have pain. If there is a stone, patient will have pain. That stone is not a cause of pain. We should remember that point. Then extracorporeal shockwave lithotripsy, it's one problem is that availability of the, though it is done by the urologist for renal stone, but it is not commonly used in our area for the pancreatic stone. And study shows even in after extracorporeal shock lithotripsy also, only there is a short-term relief of pain, not necessarily because of stone is removed. I think there are some factor is that it may produce the nerve injury surrounding the pancreas, giving relief to the pain for shorter durations. So, Dr. Utpal, give us a brief note, the role of EUS in the management of pain in the chronic pancreatitis.
Yes, definitely there is a role of US guided plexus block in
Celiac plexus.
management of chronic pancreatitis pain. So it can be either a block or neurolysis. Neurolysis, especially in chronic pancreatitis, if it is complicated with carcinoma. So if pain is excruciating in a suddenly stable patient, you always in chronic pancreatitis suspect there may be development of carcinoma because it's a pre-malignant conditions, which is carcinogenic. So in celiac plexus block, the precision of the plexus is very well visualized with the US guide of US rather than CT. So there is chance of injury to the side like hypotension, development of hypotension, diarrhea, retroperitoneal abscess. All these are less with US guided celiac plexus block. But it only relieve the pain temporarily. That is transient. The median pain relief duration is in different studies shows 3 months to 36 months. That is, in some studies it shows that pain relief may be sustained up to 3 months, here in some up to years only. But subsequential celiac plexus blocks also can be applied, so that if the patient is not relieved to initial block 1 or 2, so then again it may be tried. But if the first patient is not responding to first block, then it is unlikely will be responding to the subsequent block. So then, what is the neurolysis? It is and again in block we use the bupivacaine around 0.25%, 10 to 20 ml. And with steroid, some says that without steroid also same effect. And in neurolysis, it is the agent used is ethanol along with bupivacaine.
So thank you. The US in endoscopic ultrasound, we can detect the celiac uptake, celiac coming from the aorta. So surrounding the celiac artery, there is a plexus which is a hyperechoic. It appears to be the hyperechoic. So we can target directly. There is a less chance of injury in both vascular in the surrounding structure. And this is used by the pain and palliative management group also by doing either CT guided or ultrasound guided. But it is more precise with doing endoscopic ultrasound. We can use that. But the study shows also the results are very temporary relief of pain. And neurolysis is basically used in the carcinoma head of pancreas. So next again, Shahidul. So what are the indication of surgery? We are not discuss the surgery details. So what are the indication of surgery for pain management in chronic pancreatitis?
So, Sir has already said that if the stone is more than 5 millimeter and there is continuous pain and it is not being relieved with medical management, then we can go for lateral pancreatitis. And sometimes we have to even go for total resection of the pancreas if the pain is totally intractable. And there is a suspicion of neoplasm also, that is another indication of that.
So basically indications are bile duct strictures which is not responding to your ERCP treatment, biliary strictures, which is frequently commonly used the serial stenting, 3 stent for 1 year. Then examine again the stricture is resolved or not. And pancreatic stricture, distal strictures, young patients, we should provide the surgery. Of course, patient must have dilated duct. Then duodenal strictures because of chronic pancreatitis, fistulas, different fistula, and chronic then pain which is not managed at all by doing all types of treatments. Then suspected development of malignancy in the head which may require the Whipple surgery. So these are the different surgery, PASTU, modified PASTU, phrase, and these are the duodenum preserving pancreatic head resections. Then Whipple's beggar same duodenal preserving near complete pancreatic head resections, distal or total pancreatectomy. Nowadays, recently one article comes in the gastroenterology, total pancreatectomy with the islet cell transplantations. So these also used for the management of pain in the chronic pancreatitis. So I want to conclude this discussion. Painful chronic pancreatitis requires thorough investigation to rule out what is the cause. Is there any associated factor giving rise to the pain? Then, as Utpal mentions, we use the step ladder, WHO step ladder for management of pain by starting with the NSAID, may give to your opioids. Then, if it is not responded, we can go for the endotherapy, as Kamal mentions. If there is a treatable cause, we can do the endotherapy. We can go for the ERCP. We can drain the tissue to cyst. Then there is a role of some little bit a role of antioxidant also. And ultimately, if it is not responded, the surgery is the definite treatment. Again, there is a head-to-head comparative study. Surgery versus endoscopic therapy also shows the long-lasting response is found in the surgery group, then the endoscopic therapy. But at the end of 5 years, almost same result is coming. So with this, I conclude it is a multidisciplinary management is the key. No one option work in everyone. Very likely multiple option is necessary. It's frequently young then strongly consider surgical referral prior to the performing this neurolysis or EUS pancreatic gastrotomy. Opioids are effective but need to be case close monitoring. So I advise some questions from the audience. Any questions?
Thank you, sir, for your excellent.
Actually, sir, there is no such type of things. The gakhir mangso khabo nwaribo, because if we stop this, because this is one of the protein source, especially in children. Most of the time, we found that chronic pancreatitis occurs in children also. During pain-free period, you should introduce one by one. One by one. There is no such dictum that you cannot take milk and you cannot take meat for the whole life. There is no such things. In the pain-free period, he can have a normal diet. But during pain, he should avoid the fatty food.
That means মানুহ কম যে যেতিয়া পেইন নাথাকে তেতিয়া খাব।
Yes. Not like that. আপনি একেদিনে সব খাব, গাখীৰো খাব, মাংসও খাব, মাছো খাব, not like that. You introduce one by one and wait and see.
Next question. All 50% of gastroenterologists of chronic pancreatitis write creon. As per MCAS Setri's opinion, there is no role of enzyme. Whether you advise us, because we are learners, more or less, whether we should write creon or not.
No. It's not like that. We are also writing. That's why this Kamal that cleared the things. Everybody is writing the pancreatic enzymes in the management of chronic pancreatitis, not necessarily pain. First thing is that the patient is having enzyme insufficiency in the chronic pancreatitis. Pain is one component. If the patient is having enzyme insufficiency, if there is an enzyme insufficiency, you have to supplement the enzymes so that his absorption and digestion will be okay and his growth and body weight will be maintained. Because one of the common problem with the chronic pancreatitis is sarcopenia, where the prognosis is very bad. So
that means
enzymes for management of pain, especially in respect of management of pain, then early pancreatitis, having pain, then your non-enteric coated, creon is an enteric coated, non-enteric coated pancreatic enzyme, little bit of helpful in study also shows.
So we can write creon.
You can write.
My
Nobody can stop writing the enzymes in chronic pancreatitis.
My last question is, you have said tramadol and morphine are there. Can you use diclofenac in chronic pancreatitis pain cases? Diclofenac, any role?
The continuous use of that potent, because it's a chronic condition, so pain will last for almost his only life in some situation.
Whether we can write diclofenac or not.
We cannot use continuously, but a bolus as a bolus, suppose on demand sometimes you can use, because continuous use we cannot use.
We do not write continuous. We are not writing diclofenac continuous. One shot or two shot can you write it? That is not mentioned in Decker's slide.
No, NSAID. You can use NSAID.
That is included in
non-steroidal anti-inflammatory. One shot is no problem, but don't use frequently because it may causes ulcer. Because most of the chronic pancreatitis used to take analgesic from the over-the-counter.
So thank you, sir, for beautiful presentation. Now, one issue is many times we do get patients coming with stent, and they're coming with cholangitis currently. Many times the patient will end up into sepsis. One part, how to tackle that. The next part you have said the clonidine may be one of the modalities of the pain management. How clonidine is effective in the treatment of pain?
Clonidine.
Huh?
Clonidine.
Clonidine in management of pain.
Yeah,
in
you
the
have
chronic
shown in
pain.
the flow that.
Oh no. That was the like all other chronic pain. All other the WHO that is the to manage the all other chronic pain. You can use step by step, one by one.
The
So that
clonidine we consider as an antihypertensive, centrally acting. But in your flow, I have seen that the clonidine is one of the modalities of treatment of pain.
we are not using clonidine. This is a
Yeah, that's what. One is centrally inhibition, that can be one. Sympathetic inhibition. Okay, I'm not pretty sure about that.
And regarding management of cholangitis, you are asking one question is cholangitis. So management of cholangitis, first thing is you have to see whether he is hemodynamically stable or unstable. If it is a hemodynamically stable patient, give antibiotics, give IV fluid, observe the patients, let get stabilized. Okay, most of the patient with antibiotic IV fluid responded. So if there is no that hemodynamically unstable, not responding to your treatment, he may require drainage. Drainage may be either endoscopic or percutaneous. If the endoscopy and ERCP facility is available with you, you can do that ERCP, you can drain the biliary systems, you can go. But if there is not available, you can go to PTBD by taking help from your radiologist.
One of my patient was in recurrent cholangitis. So what should we advise in those?
Recurrent?
Recurrent cholangitis. After recovery?
Yes. Chronic pancreatitis, there is a term called recurrent acute pancreatitis, which may ultimately end up with the chronic. Even chronic pancreatitis also frequently comes for the pain. The pain is the problem. That's why I am mentioning that it's a very difficult situations in clinical scenario to manage the pain. Pain is the predominant symptoms which decreases his quality of life. That's why all this tried, starting from the NSAID, opioid, giving.
No, my question is little different. The patient was on stand, and after stand, the patient developed recurrent cholangitis. So should we advise to remove the stand?
Yes, definitely. You remove the stand.
One thing,
Thank you, sir.
one
Thing,
just one
yes,
question.
just I want to tell one thing. As you have said, if there is a stand, first thing we have to check whether it's a pancreatic stent or a CBD stent, because sometimes in patient with having chronic pancreatitis also. Okay, now obviously you can hear. The thing is that we have to first check whether it's a pancreatic stent or a CBD stent. The thing is that in the patients having pancreatic stent, the chances of blockage are very high because those stents are generally up to 5 French. We all know that 3 French is 1 millimeter, so it's too small. If we think it's a blockage there, we probably have to replace it. And if it is a CBD stent and a stricture there, we can put more stents there. Say one is a 7 DPT stent means double pigtail stent. We try to give another stent side by side so that the strictures dilates. But in pancreatic, that probably putting 2 stents will be a very, very risky position here. So probably not to be done. But yes, if the patient is having pancreatitis, because I said, we have to stabilize the patient if possible. Yes. If no, we have to go for a very high risk constant ERCP and try to replace the stent or put another stent there. If because they agrees.
So one.
Because patient is having cholangitis. So it's probably CVD stent, and it can be plastic stent can be kept only for 3 months, and it is to be replaced and stent addition to be done subsequently.
Just one question, and how frequently or how often we confirm pancreatic exocrine insufficiency, like in chronic pancreatitis. This is pain management, of course, because the the question has come up, the supplementation of pancreatic enzymes. How frequently we get to see pancreatic PEI, exocrine insufficiency? In that case, if it is 90%, probably all chronic pancreatitis patient will need supplement.
No, not like that. Pancreatic insufficiency, you can even not required for the fecal elastase also. By history, you can rule out whether the patient is having pancreatic insufficiency or not. Ask for history of steatoria. Then ask his weight. Is he losing weight? So if there is a steatoria, weight loss, no need to go for the pancreatic enzyme insufficiency assay. Give supplement. If you have doubt that this patient might have pancreatic enzyme insufficiency, then you test. Otherwise, from history you can detect. Because it's costly. If you do the PK elastase test, again it is you spend money. Already he is on lots of medication.
Just for the benefit of us, because what is the percentage of chronic pancreatitis cases? It's a life story, no? Like chronic pancreatitis lasting for many years. So
Lifelong.
when do you expect, when do you expect the
It's a
insufficient to
lifelong
occur?
disease.
That's why. When do you expect the insufficient to occur? Maybe after 2 years, 5 years. Then probably
It's very rare. Before
Usually
5 years.
late,
Is it rare
late,
or
late in the disease process, but unless and until 90% of the pancreatic
Gland.
function goes off, you will not get the clinical manifestation.
Okay.
So most of the time it is subclinical. Though so in that subclinical few cases, there may be some benefit of supplementing part.
Thank you.
Patient require only the 10% of his daily secretions of pancreatic lipase. So till remaining 10%, he will not have any symptoms of pancreatic enzyme insufficiency. So after that, he will have steatorrhea. Then you can ask by taking history, you can diagnose pancreatic enzyme insufficiency.
So most commonly we fail in one case is that alcohol consumption, smoking, tobacco, these are the areas where we fail. And the control of blood sugar if the patient also has diabetes. If tight control of diabetes is done and the patient is strictly abstaining from smoking and tobacco and alcohol, most of them will respond to whatever treatment you give. But patient usually do not follow this. The lifestyle modification is very difficult, more difficult than the medications actually.
In literature, it says that 10% of the pancreatitis, chronic pancreatitis causes diabetes. That is type 3 diabetes mellitus, and which is also late manifestations. So exact pathophysiology is not known, though it is thought to be the because of atrophy islet cell gun, not like that. So all hormones, not only the insulin, that is glucagon is also less. And this type of patient, the management is difficult. Because if you give insulin, patient will have hypoglycemia. So only one treatment, metformin, has some role because it's reduce development of cancer also, pancreatic cancer. On 5 to 10% patients of the chronic pancreatitis develop diabetes mellitus. And this is also late presentation.
With what symptoms, sir?
What symptoms, sir?
Bloating. Any medication will work.
So, fatty pancreas, actually, there is no such significance. But recently, one article comes regarding the fatty pancreas. So, fatty pancreas at the age of elderly patient have enzyme insufficiency, and sometimes the fatty pancreas in the long term may develop to pancreatic carcinoma. This is the two things found in the longitudinal study.
And there may be it increases the risk of post-ERCP pancreatitis.
Pancreatitis. Another
If the
is
patient is having
post-ERCP pancreatitis.
fatty pancreas in ultrasound, and if you do ERCP, there is increased chance of post-ERCP pancreatitis. That should be counseled.
So it is reported in more and more ultrasounds, but we don't know what is the correlation with the symptom. What symptom it will produce, we don't know, sir.
No, in diabetic patients, especially type 2 diabetes patients.
Control diabetes.
So
that should be diabetes should be addressed as merit of diabetes only, not the merits of fatty pancreas.
But both can produce
Thank you.
gastroparesis. That is when it becomes a bit difficult to find out actually whether there is something wrong actually with the pancreas or not.
So
Anyway, this is just a
tightly
commentary,
controlled
yeah.
sugar, I think that
Yeah.
should help.
So, if there is no question, I thank all the panelists. Thank you, the chairpersons. Thank you, the audience, for giving us the encouragement for asking questions. Thank you. Thank you very much.
Okay, we are closing the session as we had a very nice discussion on the very common talk. That is, there was a lot of participation from the audience. So thank you all.
Huh?
Thank you for that highly valuable and clinically relevant talk. Moving on, we have another panel discussion for which I would like to call upon the stage the chairpersons, Dr. Sadiqul Islam, Dr. Uma Shankar Kutum, Dr. Gwyneth A. Waugh, and Dr. Mriganka Deka. I request you to kindly grace the dais. And now may I invite our esteemed moderator, Dr. Kishore K. Talukdar Sir, Senior Consultant, Tulip Hospital, Guwahati. I would also like to invite our respected panelists for this session, Dr. Brajendra Hakar, Dr. Chandana Sharma, Dr. Suresh Sharma, and Dr. Rakesh Periwal. We warmly welcome you to the stage.
Yeah. Okay. So a very good afternoon to my respected chairpersons, respected panelists, my senior teachers, and esteemed audience present in the hall. At the outset, I would like to thank Nagaon API branch for giving me this opportunity to moderate a panel discussion on a very important topic related to critical care infections. So today's session dives into real-world ICU challenges, balancing evidence with clinical pragmatism. My sincere thanks to our chairpersons and expert panelists who will bring their valuable experience in critical care medicine, and their insights will make this discussion truly meaningful, and will and our learned audience also, your participation is equally important. So through this case-based discussion, let's simplify complexity, decode resistance, and shape practical strategies for the bedside. So this is my disclaimer, not presenting any exotic cases, mind-boggling diagnostics, or Drishyam model climax, following routine clinical workup only. Questions will be first posed to our learned audience, followed by our expert panelists. The questions will be simple, but we need to remember that in clinical medicine, sometimes it is gray, it may not be always black and white, and it will be a data-driven exercise. I'd like to start with this quote by Thomas Dewar: minds are like parachutes, they only function when open. So needless to say that ICU is really a precarious balancing act of so many factors, patient-related, environmental, treatment-related, and that's really an oversimplification actually. Infection is both the cause and the effect of poor outcomes, and often, no matter what the patient had primarily, the final cause of death is always an infection. So let's go through some basics we don't give importance nowadays. So MICs and clinical breakpoints. So this is a question for the audience. A, B, C, D antibiotic. Which one is the more efficacious one? Anyone? Okay. How many of your, okay, sir, you wanted to say? Anyone? Anyone for A? Correctly said, sir. So now one more question. How many of you are asking your microbiologist to give the MIC and breakpoints? I know MICs are available, but regarding breakpoints, now that is equally important. Now why? The thing is that breakpoint by MIC ratio, which the higher the ratio, the more efficacious is the antibiotic. So what will help? It will help in the antimicrobial stewardship. Now, the level of antimicrobial resistance are increasing so much that nowadays we need to hunt the last susceptible drug, like the picture shown in the uh, uh, slide. Clearly, bugs are doing PhD in resistance while we are still turning the pages. So, little bit audience warm up again. Simply, only the antibiotic, no discussion, nothing. 67-year female, massive MCA infarct, intubated for airway protection, was on meropenem, tracheostomy tube done, no fever, increased TT secretions grew Candida albicans and Acinetobacter baumannii, chest X-ray normal. What antibiotic will you give? Pardon, sir? Okay. One more scenario. 80-year-old female, bedbound, catheterized for 10 days, no fever, urine culture, Candida albicans. What antifungal? Anyone? Okay, 43-year-old male, fever, co-amoxiclav for 3 days, admission due to community-acquired pneumonia, blood CS, strep pneumonia, sputum GS, GPC, GNB East, culture sputum showing MDR E. coli. So, anyone treating strep pneumonia? And anyone treating MDR E. coli? Yes, correctly said by someone that we will treat the blood CS strep pneumonia because the isolation is from a sterile sample. Then again, culture from a patient coming from the community, MDR E. coli, we will think it to be a colonization. So little bit regarding colonization versus invasion. Detecting a microbe doesn't automatically mean infection. Some are innocent bystanders also. The trick is separating harmless colonizers from true invasive pathogens. That distinction prevents unnecessary antibiotics in the ICU. And these are some of the differences which may help you. Colonization are always seen in non-sterile sites, repeated isolation at the same site, signs of infection absent, mainly associated with indwelling catheters, drains, then absence of signs of sepsis, chronic wounds, then isolation of multiple organisms, then invasion can be in both non-sterile as well as sterile sites, usually single organism, usually grow in culture, signs of infections are present. And importantly, Staph aureus in blood, Candida from blood are pathogenic. Most CSF isolations are pathogenic. Mainly the sterile sites, always we think it to be true invasion. So, without wasting much time, coming to our first case, 23-year-old female, resident of semi-urban area, dependent of hospital staff, recently married, came from honeymoon, Shimla, Manali, 1 week back. Now coming with a history of high-grade fever with chills and rigor, each episode lasting for 30 to 40 minutes and for 5 days. Since 5 days, she is having this fever. No other localization from history, no significant past history. In the emergency, heart rate of 150 beats per minute, respiratory rate increased 40 beats, and she was maintaining SpO2 of 90% with 10 liter of oxygen. Rest of the systemic examination is normal. This is the X-ray showing bilateral fluffy opacities. My working diagnosis was severe acute respiratory infection, probably severe CAP in a young female. So, anyone? Any other thoughts? Possible causes, empiric treatment, investigations?
Thank you, Kishore. From the clinical background, it seems like she has a UTI from the clinical history. And on admission, her parameters are all goes towards a probable sepsis because she has signs of organ involvement. She has a requirement of oxygen, her SpO2 is not maintaining, and her chest X-ray shows a bilateral pattern which is suggestive of an ARDS. So I would go for a complicated UTI with sepsis and ARDS.
UTI, ma'am.
A complicated UTI with bloodstream infection going to ARDS, organ involvement.
Okay. And yes, sir. Anyone can add.
Go back. Can you go back the slide, please?
This one, sir.
So one more. So this up to the 5th came from honeymoon 1 week back.
Yes.
So up to that point, probably many a time we'll think that okay, honeymoon cystitis. Okay. So if you don't see in the next, then comes the extremely important question whether it is uncomplicated. What is uncomplicated UTI and what is complicated UTI? So cystitis as such is uncomplicated in a young woman. Once we say complicated, what are the things it's complicated? If the patient develops fever lasting for this much duration, and if someone is having pain, persistent fever, that itself becomes complicated. Even if she is a recently married young woman, and then it becomes big again. If you see this dependent of hospital staff, probably she was exposed to some of the might have been exposed to some of the bugs which may be resistant. So I'll also go for complicated UTI because if you go now because she developed fever lasting for 4 or 5 days and then respiratory distress, then you have an X-ray which which is showing actually ARDS picture. So bilateral fluffy ACT would have been much given as a very clear cut things, but this is it'll go off as ARDS also. So that will be more plausible. 23 years viral pneumonia or suppose atypical pneumonia with the initial time, initial symptoms were different.
So your working diagnosis is urosepsis with ARDS. Okay. So the audience agree. She didn't complain of any urinary symptoms till now. Yes, why not? Very nicely added, sir. Okay, let's see. Let's proceed. So these are my possible causes. We admitted the patient in ICU and NIV was given. He was started empirically on ceftriaxone and doxy, thinking it to be a tropical infection. Then steroids. We'll come to that. Then these were sent. Basic lab scheme, hemoglobin of 7.1, TLC normal, SGOTPT slightly raised, albumin low 2.8, CRP 45, PCT was normal. No hemoparasites in PBS, malaria, dengue, scrub typhus, even viral PCR was negative. My question to the panel, opinion on steroids. Now, you were thinking on that line. So I gave steroids. So was I wrong or any other output?
What was the blood pressure?
Blood pressure was normal, till now normal.
So probable sepsis without hypotension, unless we do not start steroids unless there is hypotension. So probably we should not have started steroids. And moreover, now that you come to the laboratory findings, she doesn't have a very high PCT. So it could be, yeah, the PCT is normal. So again, maybe it's not sepsis at all. It could be a tropical disease. Have you done leptospira?
Negative.
Okay. And her hemoglobin is also 7.1.
Yes.
Okay.
I actually started steroids thinking it to be severe cap. So this was a phase 3 multi-center double-blind randomized control where hydrocortisone in severe community-acquired pneumonia was studied, and it was said that it had some mortality benefit.
What is the, now how do you define severe community-acquired pneumonia? We don't have an ABG in this patient, right?
We had the ABG.
Huh.
So there it showed some means type 1 respiratory, it was showing type 1 respiratory failure.
What
but
was the PF ratio and the CRP? Because we need these two to
CRP was 45 and PF ratio was 100.
Okay, so from the PF ratio, it is a severe community-acquired pneumonia. There is evidence suggesting that we should start steroid in severe community-acquired pneumonia,
Yes.
and those where there is evidence of ARDS.
So 2 treatment regimens were there, 8 days treatment and 14 days. And we usually follow 8 days, that is 200 mg per day for 4 days, followed by half the dose for 2 days, then again half the dose for next 2 days. So anyways,
There was another study which was published in Lancet that was after the COVID era, which showed that a dose of 20 milligram dexamethasone for 10 days, followed by 10 milligram of dexamethasone for 5 days,
Okay.
was found to be more effective in severe community-acquired pneumonia. 5 days, yeah. 5 days, 5 days.
Okay.
20 followed by 5. So that is the one which is now more widely followed.
Okay, okay. So day 2, no major changes in clinical status, still on an IV, but ABG improved. Mild hypoxia, mild increase in lactate, X-ray same. So any escalation of antibiotics today, adding any other coverage since we are only on ceftriaxone and doxycycline?
What was the nasopharyngeal swab?
Negative.
Okay, so H1N1
Viral
viral
PCR
markers were
negative.
negative.
We'll proceed. Okay. Day 3, patient is marginally better We didn't change the antibiotics till now. NIV settings, PEEP and FI2 decreased. Urine output is good. Can tolerate few hours of NIV as well. Fever episodes also less frequent. Blood cultures flagged GNB. So GNB bacteremia presenting with SARI or severe CAP. So any possible organisms, change in antibiotics, any other thoughts?
You have given carbapenem to begin with, right?
No, we gave ceftriaxone doxy thinking it to be some tropical, but patient didn't deteriorate it.
But
BP was maintained, so we didn't upgraded it. Yeah, it was a dicey situation, but what it is. No.
Because her total count was with JNB severe infection, total count is within 7,000 something. PCT is within normal range, which is a little bit unusual.
What it is
So,
now.
if yeah, what I feel either it's a probably started with a viral infection or a tropical infection, which is not non-bacterial or maybe mostly viral.
Yeah, dual pathology can be there, sir.
And she may develop the secondary infection in the later half, second half. Already 4-5 days spent in the initial phase. So in the second week, probably she may have another second infection because of immunocompromised. Because TC on admission was normal, PCT was.
So anything with the honeymoon
my
thing,
point,
going to Manali,
yes.
Can anything from be there? Patient on a vacation.
No, that's right. Tropical infection may be one like scalp typhus or leptospira or this, but what the counts are not telling with the findings. So my first thing would have been I would have repeated the PCT again and total count. Probably initial TC is normal.
Yes, why
on
not,
day
sir?
2 or day 3, it is very important to have.
Yeah, we can see the trend, sir.
TC or maybe PCT.
Correctly pointed out, but we.
The steroid, I think TC should not be followed.
Even after steroid, I expect TC to be high. Once you have given steroid, the TC will be high. We ignore that high TC after giving steroid. So my point is that is beyond that. If you have anything.
Okay.
Sir?
If other vital parameters are stable, and patient is improving, TC is arising, we'll ignore that finding.
But it may not happen always, no, sir. Sometimes it may not.
It could be salmonella because you have GNB in the blood and neutropenia. I mean, possible salmonella infection could be there.
Very excellent, DD. Point to be taken out, ma'am. So we will go to day 4. Patient is better, largely off NIV. Fever is.
Can this improvement because of the steroid only?
Why not, sir? Anything is possible. Patient was still on steroids. So anyone want to add? Because next will be the final answer to the. Fever reduced to 1 to 2 spikes, but still it is there.
Fever.
Day 4, 1 to 2 spikes per day it has come down.
So it will be risky to continue steroid if it is a GNB in first week.
Without,
it will be complicated. You have started and we are now getting land up with a GNB, probably enteric fever. So first week of use of steroid in enteric fever.
But we don't know, sir. It was enteric or
we know
our
GNB is flag in blood.
No, GNB in blood. We still were not thinking about that. I don't know. Was it enteric fever? We were thinking it to be some gram-negative pneumonia only. But still, it was responding to ceftriaxone, doxy, patient improving. So thinking
or steroid.
Maybe. Yes, sir. Yes, sir. Yes, sir. Okay. Ma'am was correctly said it, Salmonella typhi, and it was pen sensitive. So it was a complicated enteric fever presenting as severe CAP. Change in the management, as we know, doxycycline, we stopped it. We added azithromycin, ceftriaxone continued, steroids stopped, discharged after 7 days of admission. And this was the X-ray after 7 days from discharge, completely okay. Okay, without wasting much time. Now in critical care infections, ICU mainly gram-negative bugs is the commonest, are more common in ICU infections compared to gram-positive. So we will discuss it more. So among these four, famous four, so some, not the trivia exactly, how to read the culture reports. So this is a culture report, Klebsiella pneumoniae, pan-susceptible, very ideal situation ICU. Then now the cephalosporins are resistant. So it is ESBL, still susceptible to BLBLIs, not so ideal, but under control. Now, BLBLIs are also resistant. So this is known as ELSBL plus, that is ESBL plus BLBLI resistance, but still carbapenem are in our hands, starting becoming scary. And at last, we have carbapenem resistance. So these are the things that we usually get in the ICU. So coming to this, we actually should know the carbapenem resistance mechanisms because it is the crux of starting any empirical antibiotic while we were thinking what we are expecting from the cultures. So as you have seen, E. coli, Klebsiella pneumoniae, Enterobacterales, and the other two are the non-lactose fermenters. So E. coli, Klebsiella pneumoniae is basically associated with NDM, OXA48, KPC, and others. Then Pseudomonas resistance is mainly due to porins, efflux, NDM. Acinetobacter is for non-48 oxas like 23, 24, and 51, 58. Now, this is, I think everyone have seen this this picture actually. So how the carbapenem resistance basically occurs. So as you can see, as this is the beta-lactam drug. So this beta-lactam drug basically enters into the, reaches the cell wall, and through this PBP, that is penicillin binding protein, they binds to this protein, and then through the porin channels, they enters and does their work. So these are some of the, now, what are the resistant mechanisms here? First of all, if the PBP protein is modified or altered, then this is one of the resistant mechanism. If the porin channels are modified, due to this also the carbapenem, the carbapenems are getting means resistance occurs. Then next, the efflux pumps. Now, what are the efflux pumps? They actually act exactly opposite to the direction of the porin channel. So they kick out the drug from the cell. Then again, we have the beta-lactamase enzyme. This is the enzymatic inactivation due to which we will be talking about in the next slide. So these are the four main mechanisms for carbapenem resistance. So we'll quickly, beta-lactamases, class A, class D, class C, class B enzyme. These are the according to the Ambler classification. In short, for class A, D, and C, we have ceftazidime avibactam. Not completely. For class B, we have aztreonam. And some of the people may ask, how will we detect this? We need BioFire or Malditov, but it is not like that. This simple test of 600 to 800 rupees of lateral flow assay. If a blood culture is positive, do this test, you will get your resistant mechanisms for carbapenem resistance. You will get at least 5: NDM, KPC, OXA48, VIM, and IMP. So move over to our second case. 50-year-old male with type 2 DM uncontrolled was admitted in the ICU for H1N1 pneumonia. He was intubated for 4 days, following which got extubated. He had a central line and Foley's, and on day 4, on the day when he was extubated, he developed new onset fever, hypotension, and was put on inotropes. 2 sets of blood culture sent. X-ray was done, no new patches or haziness. Urine culture, no growth till now. Possibilities, any other investigations you would like to do? Or I should go directly to the blood culture?
Yeah, he's been extubated and chest X-ray is normal. So probably it is not the pneumonia which is causing the infection. So we'd be wanting the blood cultures. Looks like a bloodstream related infection, CRBSI.
So this is the blood culture, blood from central line flagged Klebsiella, and it was MDR, carbapenem resistant. So extended drug susceptibility was done. Tigecycline was sensitive with a good MIC. Minocycline surprisingly more resistant. Ceftazidime-avibactam sensitive, fosfomycin resistant. And colistin, as usual, it was intermediate. So it is carbapenem resistant Klebsiella bacteremia due to Klebsi. So why this syndrome is important? That is the Klebsi, and what to use in this case.
Yeah, it's very important because it is one of the most important causes of mortality and cost in the ICU. More than 65, catheter-related infections causes very high mortality. Then, it's one of the most common cause of hospital-acquired infection. So it is very important, and if we need to follow the catheter bundle very carefully to avoid Klebsi. Again, Klebsi and CRBSI, there is a difference in the nomenclature. Klebsi is usually it is used for surveillance. It is any infection where 48 hours after you put in a central line, you get a new onset fever and no other source of infection is identified. So that is Klebsi. And more specific would be a catheter-related bloodstream infection for which we need the microbiological data. So for us, CRBSI is a nomenclature which is more important. And for this particular case, since it is a it's a Klebsi which is resistant to almost multi-drug resistant, extended drug resistance, the most appropriate drug would be a ceftazidime-avibactam. And yes, probably we would use also Estrionum also might be required. We don't know the genomic here typing. We only have
Estrionum was resistant.
Was resistant. Okay, then no, ceftazidime-avibactam would be the drug of choice.
Okay, anyone would like to add to the ceftazidime-avibactam? Anyone would like to add tigecycline in this case? Okay.
Just to
Line has been.
For this one, it is a Klebsiella. We may not remove the line, but for MRSA and Candida, we have to remove the line. For gram-negative GNB, we may keep the line and treat it.
If it is not a precious line, sir, we may remove it.
Yeah.
But for Klebsiella, we can keep it. But if it is a Candida or gram-positive and it is not a means important line, then remove it. But if it is a precious line, maybe we have to keep it and we have to give lock therapy for that, for MRSA or this fungal infection. Now, why I was saying that this syndrome is important? So because if it is a bacteremia, because some people may give tigecycline in this case, but tigecycline doesn't works in primary bacteremia. It basically works better in secondary bacteremia like GI infection causing bloodstream infection, then it will work. But why it doesn't work? Because the high volume distribution and it gets extensively distributed in the tissues. They doesn't remain in the blood for a very long time. So if it is a primary BSI, we'll avoid it that. So here tigecycline cannot be used. Best option is ceftazidime-avibactam, as ma'am rightly said. Now, this is a different scenario. Okay.
Just want to, because before we move into two things, I want to add what Dr. Chandana has already said. The central line, keeping a central line for longer time is actually, we should remove it as early as possible if it is not being used. So non-useful lines are not needed because the VAM, actually vascular access management, they have an international guideline. They have a statistics every year. 2024 guidelines, the publication they have said, if we keep the central line for 7 days, almost 22 to 24% you'll have infection. If you keep it 2 weeks, 67%. 67%. That means blindly say if line is there for 2 weeks, fever is having, a patient is having fever, this is CLBS or CRBS. So that should be.
And compared to a peripheral line, a central line causes 64 times more bloodstream infection than a peripheral cannula. So as early as possible, we would like to change it into a peripheral line.
Point, if you go back to line, why not colistin here? Suppose colistin MSC is also good. Suppose why
So
not
it is
colistin?
Klebsiella, it is
That's right. One has to see it should be reserved for Acinetobacter.
Yes.
So if we get Acinetobacter, colistin would have been a better.
So we will come to that, sir. We'll come to that. Yeah, why not, sir? So this is it is a different scenario, just to
Problem is when
basically.
you have two lines, one is a hemodialysis catheter and other is central line. There is a major problem. What to choose? So this is not uncommon. And HD lines are generally, we consider them precious because access are few. And if you already have a thrombosis somewhere with infection, it's likely. That is a major problem in decision on line. But as a general rule, whatever the book says, if there is an alternative available, I'll remove the line.
Rightly
That's
said,
it.
sir. So this is a different scenario. Same patient with Klebsiella, but here ceftazidime avibactam is resistant, and aztreonam is resistant. Then tigecycline is also resistant. Colistin is intermediate. What now? Or I'll give you one more thing. Same patient, but this time CR E. coli, same drug susceptibilities. So what?
Here we have to use colistin.
Both the cases?
E. coli in CR E. coli pneumonia.
Why directly colistin, ma'am? Before that, can no
one thing
colistin is
no one point.
Colistin oblique polymyxin.
One thing, colistin most of the time, if you go by automated machines, that will be shown as intermediate. So that is taken as sensitive. So if this report is automated machine, and they will never say as sensitive, they will say intermediate.
For colistin sensitivity, you need to do a broth dilution because we don't have the
You will not
facility.
give ceftazidime avibactam aztreonam combination.
But it is resistant. Both are resistant.
Yeah, if both NDM and oxa may be there, so that's why they are resistant. For the previous slide I showed, for NDM it is aztreonam, for the others it is ceftazidime avibactam. So in this case, I know it is not available here, but the microbiologists also don't want to do it. But this is an important test for synergy testing. So after, I think now avibactam aztreonam combination has already started in some of the centers. If that comes to our place, we have the strips, then we may not do this synergy testing also. Now, if we don't have the synergy testing, out of the two cases, Manes, the thing is, sir, ceftazidime avibactam and aztreonam, the probable resistant mechanism is aztreonam works for NDM and ceftazidime avibactam works for OXA48. And vice versa, they will be, this NDM will kick out the ceftazidime avibactam and the other OXA48 will kick out the aztreonam. So that's why both may be the resistant. If this is the resistant mechanism, okay, this is just a hypothetical answer to that. Now, the thing is that in both the cases, now if we don't have the synergy testing, so in both the cases, will you start the colistin or you will give anyone?
Colistin monotherapy, no. And the 60-90 rule is also good. So even if it is showing resistant, 60% of the chances are it will still work.
For whom, sir?
Whichever organism.
Klebsiella.
And when you
You're
are
partly
having a
correct.
ceftazidime avibactam resistance, we would like to use a combination with aztreonam.
In this scenario, if it is Klebsiella with close your eyes, give it. It will work. Because as you can see, there was around 100 to 96.4% susceptibility. This is an Indian means Indian study. Then secondly, for E. coli, only 70% is susceptible. So in that case, if you don't have the synergy, then you should go for polymyxin-based therapy. But for Klebsiella, you can give it. If you don't have the synergy testing also.
Polymyxin-based monotherapy?
No. Ceftazidime avibactam and aztreonam.
Polymyxin for UTI?
Polymyxin we will give if we don't have the synergy testing for E. coli only. Even it is said that IV phosphomycin monotherapy for E. coli, very good results are coming out. That's why I always say don't use oral phosphomycin just haphazardly. Okay. So we'll quickly move over to Our next case, 60 years old male, nephrectomy for RCC, past history of TB, has fibrotic changes in lung in pre-op CT, post-op day 4, shifted back to ICU for fever, shortness of breath and hypoxia, gets intubated in view of hypoxia and increased work in breathing. So his surgical antibiotic prophylaxis was piperacillin tazobactam for 48 hours. This was the pre-op X-ray, and this is the post-op X-ray on day 4. So thoughts and empiric choice of antibiotics now.
What was the reason behind giving piperacillin tazobactam as a surgical prophylaxis?
That was given by urologist, ma'am.
Okay. Because usually surgical prophylaxis, they use ceftriaxone, right? Piprazo, we try to preserve. So that is one thing which, it's not.
Maybe he wanted to give a anaerobic coverage also, that's why. Maybe.
Okay. So we have already exhausted with one beta-lactam, BLBLI. We first of all would like
So
to,
you will will you continue, means you will restart the piperacillin tazobactam or you will go to some other. Now the thing is that he is post-op day 4 in ICU with some.
Yes, and he has
X-ray.
hypoxia with increased work of breathing. First, we'd like to confirm whether it is the infective or a non-infective cause. Because it's a post-operative case, we also need to rule out other causes of lung patches.
Chalo,
It
ma'am,
could be
it
a
is
pulmonary
infective.
embolism, pulmonary infarction. It could be an
I'll
aspiration.
tell you it is infection. Now, ma'am.
It will depend on.
Anyone from the audience can also join. Ma'am.
Yes, it will depend on the hospital antibiotic
What is your
sensitivity
answer, ma'am?
pattern. Carbapenem.
In your hospital, what you?
Carbapenem. Carbapenem.
Carbapenem. So monotherapy?
Yes, monotherapy, carbapenem.
So are you not thinking of? Okay, ठीक है. Anyways, so he was empirically started on meropenem and polymyxin B, not by me. Blood culture and ET secretions have grown Acinetobacter baumannii. And this is the susceptibility report. Now the any choice of therapy? Colistin, tigecycline, ceftriaxone, sulbactam, EDTA. So anyone from the audience, what you will start in this, if this is in your hospital or you get a referral, what will you start? Sir, ceftriaxone, sulbactam, EDTA? Okay. Ma'am?
What from our experience, we have seen ceftriaxone sulbactam EDTA does show sensitivity from the lab,
Yes.
but in the patients we are not getting very good results. So a patient who has
You are the
deteriorated.
first person who is saying that you are not getting good results, and I'm happy about that.
Yeah, so our choice in a patient who is post-operative in the ICU, probably he would be on a ventilator therapy, would be colistin and tigecycline.
So
or
how many of you will
Acinetobacter.
start ceftriaxone, sulbactam, EDTA in this patient? Okay. So let's see. Now, these are the redundant formulations that are available in the market. Please kindly, if we are saying about antimicrobial stewardship, not only for CMEs and conferences, then please don't use this. Now, why? I'll give an example about ceftriaxone, sulbactam, EDTA. Now, the proposed mechanism was very good. We were worried about the MBL, that is the metallo-beta-lactamases. So what does EDTA does? It is an ion chelator. Our major concern, that was an NDM, which is a MBL, which has a zinc ion inside. This EDTA will chelate that, so destabilizing the enzyme. Now, what the injection contains, ceftriaxone 1 gram, sulbactam 500 milligram, and EDTA 37.5 milligram only. Whereas in lead toxicity, we use 9 gram of EDTA for a human body. So, and the disc, why it is sensitive? Ceftriaxone is 30 microgram, sulbactam is 15 microgram, in EDTA is 100 microgram, 3 times of ceftriaxone. So if this logic is applied, then I think in the IV formulation, the EDTA should be 3 grams, but it is only 37.5 milligram. That's why the disc works and the IV formulation doesn't work. Now, secondly, PKPD is unprincipled. Why I say that? Now, we have really forgotten why PKPD about the drugs. We should really go back to our pharmacology classes and read the PKPD of the drugs before using that. Ceftriaxone sulbactam has a poor PKPD principle. Ceftriaxone is half-life 8 hours, sulbactam only 1 hour. Sulbactam will be passed out in the urine before ceftriaxone works. 70% hepatic elimination for ceftriaxone, sulbactam renal. Volume of distribution is one is half, one is double of the other. Protein binding is one is highly protein bound, other one is very low protein bound. So the combination doesn't match. That's why FDA has also not approved ceftriaxone sulbactam. Only DGCA is approving it. The only BLI that is approved, that is cefoperazone sulbactam, piperacillin tazobactam, cefepime and metatazobactam has come out now, and ceftazidime avibactam. The other BLIs that you have seen, meropenem, sulbactam, tazobactam. When we are using meropenem, why we need the sulbactam and tazobactam? Because it is the epic of antibiotics. So redundant combination available, beware. And this is, we are not doing antimicrobial stewardship only in CMEs and conferences. Kindly please do it in your hospitals also. Before using a drug, kindly check. Only the microbiologist is giving that it is disc. Disc are giving by the pharma companies, and it is getting sensitive, and we are using it. So this is a request to everyone. So back to our case. CRAP treatment. Latest recommendation, monotherapy, mild infection, combination therapy for moderate to severe infection. What are available for Acinetobacter baumannii we have? In India, it is around 90% resistance for Acinetobacter baumannii. Carbapenem resistance is around 90%. And I think we are responsible for this. So in those cases, high dose sulbactam, we can use sulbactam in combination even if it is resistant. Tetracycline, minocycline preferred over the others. Polymyxins, but not alone in combination therapy. High dose carbapenems, extended infusions, not alone. Then nebulized antibiotics, not recommended. And lastly, ceftazidime avibactam aztreonam doesn't work with Acinetobacter baumannii. So kindly, if it comes out to be sensitive, don't give it. I don't know how it comes. So this was from the antimicrobial resistance research work from ICMR. As you can see, we have only two molecules, colistin and minocycline, that is around 97, 80 to 90% susceptible, still susceptible to Acinetobacter baumannii. So patient was treated with poly B and mino, good clinical improvement. Total duration of therapy was 10 days, and this was the post-op day 10 X-ray. So next case, 58-year-old male, diabetes, pelvic mass involving the right ureter, surgery done. But no. Ceftriaxone. This is carbapenem resistant Acinetobacter baumannii, na?
And the dose of sulbactam, and is it available?
Yeah, plain sulbactam, I am using it.
The doses?
Dose is high dose sulbactam. That is around 9 to 12 grams per day. 9 to 12 grams. So it comes in 1 gram or 2 gram vials. You have to give it accordingly, because daily dose of normal means normal dosage is only 2 gram per day. Yeah, they give the E-strips, sir, for the new molecules. No, sir, the thing is that in the disc, the amount of the EDTA is 3 times ceftriaxone, but in the IV formulation, it is 100 times lesser than ceftriaxone. So that's why the disc, because the proposed mechanism was very good, but the disc was also made very nicely. But IV formulation, it couldn't be made like that, maybe. So so post-op day 10, he started having fever with chills, given multiple antibiotics over the course of 1 week, but fever persisted. So post-op day 10, febrile, hemodynamically stable, no major clinical localization, TLC of 15,000. Creatinine was a little bit high, 1.5, rest was negative. CT, chest and abdomen was normal. Urine routine 10 to 12 pus cells. Blood and urine grew Pseudomonas aeruginosa. And this is the susceptibility report. Only colistin is intermediately sensitive. So how will you treat? Start colistin in modified doses, some other drug combo like ceftazidime avibactam, aztreonam, ceftazidime avibactam, aztreonam plus fosfomycin, some other plan.
Start colistin. and probably remove the DJ stent, which might be the source of Pseudomonas.
Why not, ma'am, ceftazidime, avectam, and aztreonam?
Pseudomonas.
It is not that Pseudomonas, it is completely resistant. Yeah, resistance mechanism of Pseudomonas, as we have already said, it is porins, effluxes, which is the main commonest, and endium may also be there. So your aztreonam is resistant. Ceftazidime avibactam is also resistant.
Suppose if we follow the principle, if you have a list of 3 drugs and you have resistant 2 drugs and one is sensitive, in the best of clinical situation, what will you use? In this situation, probably patient is having very serious infection, a life-threatening infection. You have a choice of 3 drugs, and other two drugs are resistant, showing as resistant. You are playing your card. Maybe you may not be correct in vivo. Patient may not respond to that, but you have another molecule because you don't have any other choice from the list. Colistin, which is still sensitive, and then probably in clinical practice, I'll definitely go for colistin.
So means monotherapy.
No, you combine with definitely we go for anti-pseudomonal and another one.
Which
maybe
one, sir?
meropenem, if you even a higher dose of meropenem as a extended infusion, maybe 4 hours infusion over, and plus higher dose, 2 gram 8 early maybe.
Means meropenem and colistin. Meropenem means over extended infusions.
Extended release. Because if you have this report and a life-threatening infection, and definitely if I think the digestant is the cause, the biofilm will be there. Whatever antibiotic you are going to use, this is not going to work. So patient will be having repeated infection. So next question is, if patient is still growing a lot of pustules in the urine and still positive ulcers, probably you are going to remove the digestant, and you'll have to ask the urologist whether it can be removed or not.
Procal is high.
For starting antibiotics,
Procal
we
is high.
don't need Procal, only for de-escalation of antibiotics.
Penetrate the biofilm.
So all are resistant, sir.
All are resistant.
All are resistant, sir.
Penetrate the biofilm.
So if it is resistant, it will not penetrate. We have to remove the source.
We have to remove it.
Yes.
Yes. Okay. In this case, Kazavi as aztreonam was resistant, but the thing is that if Kazavi as aztreonam synergy was, if synergy testing is possible, and if it is positive, you can give Kazavi aztreonam in this case, sir. No need for colistin. But if you don't have to see it, then yes, polymyxin therapy, maybe with phosphomycin, or it is resistant. But still, in combination therapy, we can use phosphomycin, or as you said, we can give a extended infusion of IV carbapenems also. So we discussed with the urologist, DJ stent was removed, colistin in modified doses was given, became afebrile after 3 days, KFT normalized. Quickly moving over to the next case, 56-year-old male, rheumatic heart disease with severe aortic stenosis, fever for 3 days, local physician gave ceftriaxone fever, subsided, fever reappeared after 3 days, associated with chills, advised blood CS, but echo was normal. Blood CS grew Enterococcus fecalis, linezolid added to the ceftriaxone 10 to 14 days therapy because linezolid was sensitive. Fever subsided, but again reappeared after 5 days. Patient was admitted in ICU with hemodynamic instability. So benzyl penicillin was sensitive here. Yeah, last one. Benzyl penicillin was sensitive. Only there was high level gentamicin resistance was there. Aminoglycoside resistance was there. Rest were sensitive. Daptomycin was intermediately sensitive.
So they have been reserved for vancomycin resistant status. So if the bug is sensitive to vancomycin, while linezolid was picked up.
It was given by the Would you like to repeat the echo in this patient?
Yes, yes, definitely. And if the transthoracic echo is normal, we have to go for a transesophageal echo because he already has a valvular heart disease. And so he falls into the criteria of infective endocarditis if we go by the Duke's criteria.
Rightly said, ma'am. But luckily, we repeated normal echo only, means not T, and vegetation was seen in the aortic valve, and this 2 weeks after the previous echo. So blood culture, he was given ceftriaxone for a few days, then linezolid was added, but still, and both linezolid was sensitive. We don't know about ceftriaxone. Again, fever came, hemodynamic instability, now vegetations in the aortic valve. So keeping into mind this culture report, what will you give?
Vancomycin should be the drug of choice because it's not VRE, no? Vancomycin is sensitive. So till now it is not VRE.
Now, okay. Anyone like to add anything? Or everybody will go with vancomycin? Because we normally discuss about gram negatives, we hardly discuss about gram positive. That was my idea to give this. Enterococcus endocarditis, that is fecalis. So in this case,
if you follow infective endocarditis, native valve, and then if you go to enterococcus again, so whether this is oxacillin sensitive, number one. If it is resistant, then you come to vancomycin sensitive or resistant. Your choice will be that way. If we
So here, sir, what you will give? This is your patient. Now you have been given the referral. So cardiologist have called you. So what therapy you will start?
penicillin, yeah, that's will work. Benzoyl penicillin sensitive. So ceftriaxone with vancomycin, if you combine with a correct dose and duration.
Okay. So ideally in a enterococcus fecalis endocarditis, dual therapy is must. Okay. So vancomycin, rightly said, but vancomycin needs to be given with gentamicin. But here there is high level and aminoglycoside resistance. So next thing
Can we
comes
add rifampicin?
ampicillin plus ceftriaxone. Because it is vancomycin sensitive case, here that combination will act. But we don't have the ampicillin thing here, whether it is sensitive or resistant. So in the available scenario, next best combination that comes, that is daptomycin and linezolid. And there are many studies, yes, daptomycin, high dose daptomycin with linezolid, because here it is intermediately sensitive, but MIC of 4 is okay. We can give because high level means high dose daptomycin, it is bactericidal in endocarditis, and together with linezolid, there will be enhanced bactericidal activity, though it is bacteriostatic.
There's guideline where linezolid is to be preserved for a vancomycin resistant case, VRE.
But here, sir, we can't give the vancomycin, sir.
Why?
We need to save the patient. We don't have any other therapy available.
Vancomycin is sensitive here.
If it is high level aminoglycoside resistance, then we can't give vancomycin for enterococcus fecalis endocarditis. That is the problem, sir.
And we
Even
don't have the
ticoplanin
MICs.
also you can
And
use
we don't have
because
the MIC also. If Vanco
Yes.
MIC is
very
two-
good, sir.
Yeah.
Vanco MICs are very good here. One.
Okay, one.
So here ticoplanin can also be used because vancomycin sensitivity is already there. Never use ticoplanin if vancomycin is resistance. So this is viral influenza A. Yes, yes, sir. So 25 years of female, 33rd week of pregnancy, then high-grade fever, nasal discharge 2 days duration, nasopharyngeal swab PCR positive for influenza A. Now, first of all, everybody will like to do an X-ray in this case because patient coming with respiratory difficulty. So can we do chest X-ray or CT scan in a third trimester pregnant woman, or opinion on the first and second trimester radiography imaging? Yes, no, or anything else? Yes. So I also went to the literature. So the toxic dose for a fetus is more than 50 milligray. In PET scan, it is 10 to 50 milligray exposure only. So CT scan, we can do it. We can do X-ray also, provided you need to take your radiologist with you and a proper counseling needs to be done, then only you go ahead. Otherwise, don't go once radiologist is saying something and you are saying something. So this is the data. I don't know whether you will be using it or not, but counseling by both radiologist and physician helps. Now, what about oseltamivir in this case? We will use it. I'll go a little bit fast. I'll skip something. So we will start oseltamivir at the earliest. So no point playing around. We have a lot of evidence supporting it, except a randomized trial which showed no benefit, but rest of them showed early oseltamivir benefited. Now, this is very important. Viral pneumonia, empiric antibiotic. In this case, will you give it or not? Yes, no, maybe.
Yes. That's what the IDSS says. You give.
Anyone know? Okay. So this was a recent uh, evidence that was presented by American Thoracic Society in recently May 2025. So here you can see if a patient is an OPD patient, don't give antibiotics. If a patient is with comorbidities and patient is admitted, go for antibiotics. So absolutely controversial for at least our antimicrobial stewardship perspective, but this is how it is. The document goes like this. So these are the bacterial co-infections in influenza. So now, adding steroids in influenza pneumonia, yes, no, maybe?
No.
Very rightly said. I will go fast. As I said, not recommended. So case continues, fever spike reduced over the next 2 days, changed from invasive ventilation to high flow nasal cannula. But after 2 days, she developed new onset respiratory distress. This is the X-ray. Maximum temperature recorded was 99 degree Fahrenheit and she was on NIV. What are the possibilities? Quickly, ma'am.
Secondary bacteria.
Okay, these were our possibilities, but we repeated the clinical examination and a mid-diastolic murmur was in the apex. Echo was done, severe mitral stenosis. So all that glitters is not gold, all that presented in infection panel may not be an infection. We went again for a clinical examination, which I discussed. So patient was added diuretics, good symptomatic improvement, shifted to ward, 5 days of ICU stay, planned for discharge after 3 days with cardiology follow-up. But again, new onset fever with cough, worsening breathlessness, leukocyte 14,000, procal 3.3, rising procal, which was normal. CRP 208. This is the new chest X-ray. So reason for current, these are just, I have given you the options. This may not be correct. So reason for current worsening, what will be your line of investigation? 3.3. Okay. Sputum culture was sent, KOH mount was done, fungal culture sent, patient started one meropenem and vancomycin. Sputum culture showing MRSA in an influenza pneumonia and with X-ray. So patient vancomycin was continued, meropenem was stopped, became afebrile, dyspnea improved. However, by 7-day fever reoccurred, cough increased and she was back on oxygen mask. So fever again. Any other test you want to do? Okay, we have sent everything, blood culture, repeat sputum culture. Now we will go for CT thorax also because patient already now, patient delivery ho gaya. These are the CT imagings. Bilateral infiltrates. Sputum KOH showed septal fungal hyphae, serum galactomannan was 3.3. So an impression of influenza associated pulmonary aspergillosis was made. Now vancomycin was stopped after 10 days. What will be the best choice of antifungal in this case? Yes, as I told in the beginning, nothing is black and white, mostly it's gray. Studies have shown all the antifungals, these three, are non-inferior to each other, but robust data is with voriconazole. Unless and until patient has long QTC, prolonged QTC, then maybe we may go with isavuconazole, because it is the only antifungal which shortens the QTC. During the first 10 days of treatment with voriconazole, she had a good improvement, cough subsided, pulse rate 100 beats per minute, again fever spikes, mild worsening of breathlessness. TLC came down, CRP came down, platelet 1.3 lakhs, but fever spikes again there. So what is your next best line of investigation? will you be doing voriconazole drug levels or blood cultures? Ideally, we should do it, but I'm telling you it was okay, normal. Now, so no other localization. We repeated an echocardiogram, mobile vegetation, 1.1 centimeter size on mitral valve. Blood cultures came back negative. So an echo showing endocarditis, but blood cultures are negative. Influenza pneumonia, MRSA pneumonia together. So what now? What next? So is it culture negative endocarditis or anything else or aspergillus endocarditis? Anything about skip phenomenon? What is skip phenomenon in Staph aureus? Now, if a patient has MRSA infection, then there may be one day blood culture may be positive, the next day blood culture may be negative, again next day it can be positive. So this is known as skip phenomenon, which is mostly seen with MRSA. So patient was initiated on vancomycin, treated for 6 weeks, became afebrile, repeat echo did not show any vegetations, did not pursue investigations like NGS. So final diagnosis was this. So most probably it was MRSA endocarditis since it responded to vancomycin.
Just one.
So I like to end with a saying by Alexander Fleming.
Just one point here in this
sir.
case, because the pregnancy and influenza, it's extremely important. Many a time we delay the treatment. So they say that if the studies are there in 2010 or so, JAMA publication, if you treat it before 2 days and after 4 days, the difference is very high, 63% versus 9%. They land up in ICU. So this patient, if we could have started anti-influenza Tamiflu maybe on the day 1 or day 2.
We started at the earliest, sir.
Yeah.
Or Saltamavir was started.
Duration, the chance of landing up in ICU is very, very low. And even two days is a cutoff. We'll have to start before 2 days. The chance of landing up in ICU will be less.
So Alexander Fleming said in 1945 only, if infected, use appropriate drug, maximum dose and minimum duration. Avoid underdosing. So this is my conclusion. So take hospital messages in the ICU. The margin for error is simple, small. Every case teaches us that the right mindset, timely action, evidence-based decisions turned critical backs into clinical victories. So expect ESBL, plan for carbapenemas, prepare for CRAB. Thank you for your patience.
I'd like to thank the moderator and the esteemed panelists out here for a very nice and elaborative discussion on a very pertinent topic. But because of paucity of time, I would like to close the session without giving any questions. क्लास हो गया हम लोग का infections का.
Thank you. Thank you for that enlightening session. We now move on to the final session of this program, for which I would like to call the chairpersons to the stage. Respected Dr. Mihir Kumar Goswami sir, Dr. Rajiv Borkakoti sir, and Dr. Swapnav Bodhaku sir, I request you to kindly chair the proceedings. And now may I invite our esteemed moderator, Dr. Kripesh Ranjan Sharma sir, consultant pulmonologist and HOD Apollo Hospitals, Guwahati. I would also like to invite our expert panelists for this session, Dr. Jogesh Sharma, Dr. Ashwini Bezborwa, Dr. Abdul Barik Ahmed, and Dr. Nirvan Vaishya. We warmly welcome you to take the stage.
So, without any further ado and delay, I would like to request Dr. Kripesh Sharma to start his deliberation about the allotted subject.
Thank you, sir.
They are very much there.
So, good
So, this is the final topic of the day and also of this particular mega event. So, definitely, this is not the last, this is maybe the last, but not the least. So, Dr. Kripesh Sharma, please.
Thank you, sir. So I would like to thank the API Nagaon branch for inviting us for this API APICON 2025. So we'll discuss with our panelists regarding certain case scenario of common dilemma in management of recurrent pleural effusion. So as we know, pleural effusion are something very easy to diagnose and treat, but when it get complicated or it get recurrent accumulation, then it's become very difficult. So it occur because of the several causes. It effusion because maybe because of the infective causes or neoplastic, inflammatory, autoimmune, traumatic, or even in certain chronic disease like CLD or other things. So recurrent pleural effusion can present as a significant challenge for physician and also for the patient because they have to attend the clinic. Their symptom are there. They have impaired quality of life, and then they need recurrent aspiration or different interventions and also cost. So we'll go through a few cases to understand how we can manage this recurrent pleural effusion. So uh, this is a case one. So we have a 54-year-old gentleman who is a non-smoker. He is a non-alcoholic, present with complaint of dry cough, left side has continuous chest pain that aggravate on coughing and deep breathing. And the patient also have a fever since for 7 days, and there is no complaint of breathlessness or hemoptysis or any other cardiac or respiratory problem. They had a history of multiple joint pain. The patient 1 year ago has a history of diagnosing right-sided tuberculosis for which he took complete course of anti-tubercular drug. So when a patient came, he had on examination, patient was febrile. Then they have a respiratory system examination, revealed diminished chest movement on the left side. They have a dull note on percussion, diminished breath sound and vocal resonance were also reduced from 5 to 7 spaces on the left side, and left infractular region and left infractural region. The rest of the systemic examination was normal. There is no significant finding. So the patient doctor has done a routine investigation, and they have found that the hemoglobin was 12. Total count was normal limit. Normal difference TC and ESR was there. Renal and liver function tests were normal. Plasma serum and electrolytes and glucose were also normal. Then X-ray was done, and which showed a left-sided lower zone opacities. So patient was investigated further based on this clinical finding and radiological finding. Then patient had sputum was tested. It was negative for acid-fast bacilli. Then pleural fluid analysis was done because there was a left-sided effusion. So they have shown WBC count in the pleural fluid of more than 4,000, which is predominantly lymphocytic. Then sugar was 60 milligram per deciliter, protein was 5.4, ADA level in pleural fluid was 41, malignant cell were negative, and pleural fluid culture was 10 for tuberculosis. It's awaited. So my question to the panelists is, what are the possible differential diagnosis in this clinical scenario?
First of all, I thanks all the audience because maximum in pulmonary tuberculosis is come when in 1882, Robert Koch discovered Mycobacterium tuberculosis. Only 13% was present in that meeting. And it is at the end of the session, so public is very less, but we want the quality and maximum is going for the lunch also. So in that case, there is a very interesting presentation is that you are telling about the joint pain, no?
Yes,
From
sir.
how many years the patient is having that joint pain?
So the history is not so clear, but he was having this joint pain for last 2 to 3 months.
But one thing is that that person is having a tubercular prohibition 1 year back, and he was treated with anti-tubercular treatment and completed, and patient was
Yes, this was
completed
on
treatment.
right side. Now patient has a left side effusion.
Right side. Now it is on the left side. Since the patient is having a multiple joint pain, patient's sugar is reduced, then CRP is slightly high, no? And TLC is normal. ADA is borderline 41. In that case, first things will come with the rheumatoid arthritis. As patient is having the multiple joint pain, we should not ignore it. Is there any deformity of this case? I mean, this is a real. Have you in your eye?
No, this initially this patient has slight swelling of the distal phalanges, but there is no significant other deformities present in this patient.
So it is after taking the anti-tubercular drugs or before?
This also happened. This was not present in the earlier 1 year back infection. This is occur only this time when patient has a second episode of effusion.
So what is about the uric acid level in that case? It is
Uric acid level was
normal.
tested. It was normal with normal.
So we should think in that line the rheumatoid arthritis, because when a person is having rheumatoid arthritis, to develop the pleural effusion is usually take the 8 to 10 years time actually, and the sugar is decreased. Why the sugar is decreased in rheumatoid arthritis or in case of parapneumonic effusions, empyema? The main aim is the sugar level is usually same with the blood sugar level in pleural fluid normally. It decreases when the sugar is utilized by the bacteria one, or if there is difficulty in penetration to the pleural space, if there is thickened pleura, or even in Amazon also sometimes this level is decreased. So my first diagnosis will be the rheumatoid arthritis in this case, because ADA's level is borderline high. But we are not doing the RH factor. We should do it since patient is having the
This till
joint
then
pains.
this patient was treated in some other center. So we'll come in details. There are lots of things are there. actually.
Yogesh,
Yes.
question. Why you're not thinking of other
Now I am telling now, second diagnosis is tuberculosis.
connective tissue disorder? You just only rheumatoid or throwing.
No, he is telling about the joint pain. Joint pain. Yes, others will also come. As a whole, the connective tissue disorder, especially the rheumatoid arthritis, because the small joints are mainly involved in that case. Second thing is the tuberculosis. Third is sometimes in case of parapneumonic effusions. Fourth time the patient age was?
Age was 56.
Malignancy also keeps in mind. I will stick in this four first. Later others will come.
Just before Osini, I want to intervene. Was he declared to be cured as per NTP guideline?
Yes, he was declared cured 1 year back, and at that time, follow-up X-ray was also normal.
Right.
So
in NCP, he completed dots.
Completed. Yes, 6 months of NTP.
NCP guideline also you cannot tell cured by say the X-ray. We can tell that treatment is completed, because to cure bacterial should be negative as per the definition. We have not seen the bacteria in this case.
Mihir, what is this? And this is a guideline for saying cure. Guideline to say cure.
Guidelines say if a patient is having the sputum positive, but it become negative at the end of treatment, then we will tell it as a treatment cured. But if we cannot do the test, then we should write the treatment completed as per the NCP guideline. But in clinically, when the X-ray is normal, we will write cured. But we don't use all this term. If we use this term for NCP point of level, then we should write completed, because we are not seeing the bacteria. First thing. Second thing, in any tubercular cases, we should inform to the, because if we don't inform it, we should inform to the authority. That is the important thing.
Notification.
It is a
notification of the
It is
patient
a
is very
notifiable
important.
disease.
It is and in fact, non-notification will lead to punishment also.
Yes, up to 6 months jail can be given, and a huge punishment for money. And if you inform, and another is a good thing is there. So I want to make some familiar to all of you. If you treat this person, you will get 500 rupees from the person in private chamber.
So financial benefit is there.
When you come in every time, 500, 700, what is your fees? You will get it every year till completed. And patient in also, when it will be notified, patient will get 500 rupees for every month for the nutritional purpose. That is the beauty of treatment of tuberculosis patient. But if you don't notify, you may go to jail also. Nowadays, that is the main thing.
Looking at AFP, it is negative after culture. If it was positive, you said it is not visible by microscopy or culture. 6 months they cure guli ko bole.
That should be on microscopy. Microscopy.
There are several points to declare a patient to be cured. As per your answer. Sir has mentioned about the microbiological point. There are other points also. You want to add something?
One thing
Yes.
I want to say, sir, about rheumatoid arthritis, as sir told, rheumatoid arthritis in male mostly can present with pleural effusion, but rheumatoid arthritis with female, in female case, rare, less percent of patient present with pleural effusion.
This patient has symptoms for 7 days only, is it?
Yes,
Intermittent fever, chest pain, and pleuritic chest pain and cough. So, could it be paranpneumonic effusion?
Exactly.
Because it's short duration only.
Exactly. This from this short duration of clinical picture, first differential diagnosis would have been a paranpneumonic effusion. Then next option would have been a lymphocytic, little bit borderline ADA would have been we have gone for this tuberculosis. Then the other rare possibilities we should kept in mind in a sequence way.
Sir, actually, what was the actual value of glucose will be very important.
Yes.
Because in rheumatoid arthritis effusions, the value will be almost close to zero compared to other paranpneumonic effusion or malignancy. So it will be low, but it will not be something around 0 to 20 level. So the actual value is important as well. The LDH value, the LDH more than 2 times the upper limit of normal. If that crosses, the chances of RA infusion, RA related effusion is much higher compared to, as sir has already asked, regarding other connective tissue disorders. Even SLE also can lead to pleural effusion, but the actual value of glucose that it was said as reduced. So that is what I was asking is was the actual value of glucose. So that is more important. That is what I asked.
Yeah, exactly. Your point is rightly said.
Here we can at least rule out some disease like SLE. Patient is male, 54 years, had history of tuberculosis, now short duration of uh, clinical findings with clinical findings pleural effusion, lymphocytic. Either it would be COX related or connective tissue disorder related, which might be rheumatoid arthritis. So we could have done whenever he came to us anti-CCP, and we could send pleural fluid for CBNAT. You have not mentioned whether you have sent or not. Only you have mentioned about the culture.
Yeah, CVNAT was done also. It was negative.
That is also important point. If we do the culture, it will take around 4 to 6 weeks times. But if we do the CBNAT test, we will get the results within one day. So this is important. But in case of pleural effusion, CBNAT is usual. In a few percentage of cases, it is positive. Otherwise, not. Second thing regarding the rheumatoid factor, as he is telling, Dr. Base. One thing is that we can do the rheumatoid factor even in the pleural fluid. When there is a joint pain, because I don't know what will be the further investigation in that case, because that investigation should be like that, whether we can do it in Tubri or even in the interior part of the Kokrajar also or anywhere, because the most of the clinicians are tackle this type of cases. So this is important. So we'll go for
Yeah,
further.
definitely. So in this case scenario, basically, uh, the other point that we want to discuss is that what is the significance of ADA in particularly in our country, and how should we interpret the ADA level in this particular clinical situation? So this panelists or from the audience, anybody would like to put some highlight on this point? Because this is where certain things are not very common, but ADA we can do everywhere, plus routine pleural fluid analysis. So that will help us to at least give us a idea that this should be a tubercular or non-tubercular, or we should do for other possible causes.
Actually, ADA, the exact cutoff mark for tuberculosis or any other, it is very difficult. Though very few literature or most of the literature says if it is more than 40 or if it is more than 70, it is most likely for tuberculosis. But in many other cases, like any other infection or HIV, even malignancy, you might have that high ADA.
Yeah, exactly. So ADA, several causes can rise ADA actually.
Actually, in case of pleural, not only in tubercular, if it is the 70 and above, it is more or less it is tuberculosis. But even in the 40 also, we should see all the things, all the parameter, then we will go. Another important thing is that in parapneumonic effusions also, or in empyema also, ADA may be positive. So these are the in malignancy also. But one thing is that that patient is having low ADA, low LDH. Always keep in mind that if in old age persons, that may be a case of malignancy and prognosis is comparatively poor. This
Yeah.
is from experience actually.
Exactly.
We
So
did a lot of study on
basically
this.
there are some
Previous, just one point regarding ADA, it has got a drawback here in the situation, in context of the situation here in India, because ADA is usually fractionated, ADA 1 and 2. So
this particular facility of fractionation of ADA is not available till now, as of now, in
Exactly.
India,
Sir,
to my knowledge.
yeah,
Up to-
ADA2 is more significant for
significant.
tuberculosis,
Yes,
but we
yes.
don't have a facility to
Yes, that's
do
what I
the
want to say.
difference between AD1 and 2.
But in Assam, it is not available. ADA2 is specific, but in some centers, ADA2 is now done. We should send the fluid in outside actually.
So exactly. So basically, the significance of ADA come based on the prevalence basically. So there are trial analysis, particularly in a TB low burden country or a high burden country. So this is a meta-analysis from a low TB burden country where they have said कि ADA level above 70 is significant. Between 40 to 70, it's a little bit dicey things where it most of the time in low TB burden country it came out to be a non-tubercle or neoplastic. But if another review from India where they have shown that ADA level even above 40 is significant, particularly in Indian context, where most if other clinical parameters are fitting it or other parameters are okay and we have a ADA 40, then the possibility of tuberculosis is quite high. So we have to look into basically this high TB burden or low TB burden country where our significance of ADA accordingly keep on changing. So other cause of ADA, these are common causes where apart from the tuberculosis, we may get high AD in HIV infection, in lung cancer, in mesotheliomas, in lymphomas, in rheumatoid arthritis diseases, then bacterial proliferation, particularly empyemas, or even in hemorrhagic effusion. So we have to keep in mind just this clinical picture. Also we have to, apart from the routine pleural fluid analysis, we have to also should have make a habit of looking into the color of the pleural fluid. That will also give us some idea that this is a what kind of which is a straw yellow color or it is a pus kind of things or it is a hemorrhagic. That also we can correlate with the ADA level and other parameters. The optimum pleural fluid cutoff of AD is still not that clear. But again, in Indian senior, at least 40 or above, and above 70 is more significant. But between 40 to 70, we should keep a borderline thing where we have to give importance to other parameters also. And below 40, chance of tuberculosis is less. But it doesn't mean that less than 40 is, it doesn't rule out tuberculosis. So in this patient, what should be the initial treatment plan according to the panelists? I request to
Excuse
give
me.
their opinion.
Have you done PCR in this case?
PCR gene expert has been done. It is negative.
Okay.
So first in this case, since patient is having the low sugar, TC is also 4,300 something, no? But lymphocyte is predominant. That is the important thing. So since in India, 40% people are having the tubercular infection, not the disease, but tubercular proliferation is more common. At the same time, we should think first with the antibiotic, give antibiotic, see for a few days, at least after 1 to 2 weeks. If it is not respond, second we go to for HTT, anti-tubercular treatment first. But I will keep in mind since the patient is having the joint pain, I will keep it always in my mind. This one. The pleural fluid should send for rheumatoid factor. At the same time, we should do the further testing. But I will say the further testing. Because we will think about the interior part, where physicians are working, what they will do.
Sir, in as sir has described regarding an interior part, so if I am in my center in Guwahati Medical College, sir, we can go ahead with a thoracoscopy in this patient because there is a large size of effusion. We can see the pleura. If there is any nodularity, how the pleura is, then we can take directly biopsy from the pleura.
So before going to thoracoscopy, even in periphery at present in Assam, at least we can send anti-CCP for blood, and as we have taken the fluid, we can send for rheumatoid factor. That can be done in periphery also. You can send for anti-CCP anywhere.
Sir,
Yeah. So this patient was treated by antitubercular drug in a peripheral center, but his symptom are persistent, and repeat X-ray after 1 month showed increased amount of pleural effusion. Then the patient came to us. So we did repeat certain things. We did the complete renal profile and other routine investigation. They're almost normal limit, but there was a CRP was on higher side, ESR was on higher side. Then we decided to go for looking into the CT thorax. So they have shown CT thorax showed this your moderate amount of left-sided pleural effusion. So at this point, we need to work up further on this patient. What are the possible, because patient is still symptomatic and effusion has increased. So what are the possible intervention or investigation we should do further to make diagnosis more clearly?
Are you doing the repeated aspiration of this?
Yeah, so we have different options that we can go for a repeated thoracocentesis because, or we can go for a pleural biopsy, blind biopsy. We can go for a thoracoscopy also, or we can modify the medicine if and wait and watch how the patient, or since the patient is symptomatic and initial pleural fluid was little bit maybe tuberculosis, so we can add steroid in this patient because adding steroid also sometimes gives symptomatic relief. So what is the opinion of the panel?
Now, first thing is that repeated thoracosynthesis is very, very important because we are thinking mainly the physicians, what they can do. Regarding the blind pleural biopsy, there is tons of complications. Better to do the thoracoscopy, but thoracoscopy is done only in few centers. In Guwahati Medical College, probably in Apollo, no, not in other centers till now. So before that, whatever possible is with us, why we don't utilize this? Though a RH factor in the pleural fluid aspirations, and already Dr. Bez is telling about NCCCP and or other tests like ANA, this may be negative, but NCCCP will be highly sensitive, it will be positive, and RH factor in the pleural fluid is usually become positive. Second thing regarding the increased level, we are giving antitubercular drug for 1 month, no?
Yes.
Usually 1 month it should be reduced. But sometimes we see the people are referring this type of cases from the periphery to us that is it case a drug resistance tubercular pleural effusion. It is a very, in that case, thoracoscopy is important. No, there is no other option, but rheumatoid factor in pleural fluid and CCP in blood should be done in this case before going to the thoracoscopy. If we get the result, it will be simple. Yes.
Yes, sir.
You have this CT scan, okay? And the chief complaints from initial point was fever,
And coughing.
cough.
Cough.
So
Chest pain.
from history, is there any symptom or sign of lung parenchymal involvement?
No, his sputum.
Or you think from the history it was only extra parenchymal?
Yes, from the history, it's mostly both parenchymal and extrapleural because chest pain was also there. So it's a pleuritic sort of chest pain. So both were there.
Both were there.
But cough amount was very minimal.
Very dry sort of.
Almost most of the time dry cough.
Okay, because he is 54-year old and this effusion has not improved.
Yes.
So what about, I'd like to the respected panelist, what will be the importance of draining the fluid again, thoracentesis, and followed by immediately by an imaging CT scan?
Yes, sir. After taking out the fluid, we can go for imaging to rule out any mass lesion.
Left side.
Left side. The previous time, first time fluid was in the right side. But
yeah, exactly, sir. Your point is right. If the amount of effusion is significant, large amount, then we always first drain the fluid, then we do a imaging. But in this case, it is just mild to moderate effusion. So in that case, we can directly go for a CT thorax.
So we although can get a rheumatoid arthritis effusion and we can get a NTCC positive, and even in the pleural fluid we can have RA positive, but still we cannot rule out a dual pathology. So it can have the RA factor plus tubercular pleural effusion. So answer will always be thoracoscopy. So if we can go inside and get the biopsy, not I understand that there is constraints in the areas. So if there are no constraints, I think we should go ahead.
Exactly.
Again, I am again telling one thing. If the patient is coming from the Kokrajhar, if we can treat this patient in Kokrajhar, that is important. Because if it is comes to the Guwahati Medical College, then we will do the thoracoscopy. And in Apollo, because in many centers there is no provision of thoracoscopy. And I don't know in private chamber what will be the cost of thoracoscopy.
In our center, it costs around 40,000.
The one patient who diagnoses a case of tubercular pleural effusions, if we send in investigation lakhs of rupees, that is happening in one case. For that reason, I am giving the stress there. One of our senior teacher is telling the diagnosis is a case of pleural effusion, around 1 lakh is spent, and ultimately treatment is giving a simple drugs. I will tell later. Probably this case is also going in that way.
Yeah, exactly. So,
Uh, I think thoracoscopy is okay. We will go for thoracoscopy, but repeat thoracentesis is also, I think,
actually, before we have this patient has only one thoracosynthesis was done. So, as per the guideline, also you have to go at least 2 to 3 times thoracosynthesis is required before going through a thoracoscopy, because many a time we single thoracosynthesis may not give a definite diagnosis. Then second or third thoracosynthesis may be a better option rather than directly going for a this your thoracoscopy examination. This patient, since patient has a little bit of underlying collapse, so we did a bronchoscopy which was normal, and repeat pleural fluid analysis was done. So again, it has shown a exudative pleural effusion. Where now this time pleural fluid PS has dropped to 7.1. Sugar is now again dropped to 22. Again, it is still lymphocytic predominant. We did the ADA, it was 59, and LDH was 506 level. So from this report, what is the conclusion from this? Because it looks patient fever is still persisting and sugar is still falling down. Patient is still sick.
Sir, here.
So here we can should we modify our treatment plan, or we should now go for a thoracoscopy? That is the question basically.
So here we can at least assume that patient is having his pleural effusion with high LDH and sugar is decreasing, though lymphocytosis, then you have again in dilemma. If you want to add along with that ATT, whatever he was getting, you can add steroid. If it is connective tissue disorder related, he will improve. Otherwise, to confirm, we have to go for pleural biopsy.
So that treatment line will be two in that case. One thing is that if it is come in a tertiary care hospital like GMC, even in AMC also thoracoscopy is not done, not in any medical college except GMC and in the Apollo hospital. So in periphery level, when the case will come, we will give the just steroid, RH factor and NCCP must be done, and we will see in this case. Because if it is come to a tertiary hospital in Guwahati Medical College then we will go for thoracoscopy, otherwise no. Because in that case, ADA level is slightly increased, no? And the glucose level is decreased very much in this time. And LDH level is also increased, no? So these 2 point is goes in favor of actually a connective tissue disorder.
So
that is important point.
Exactly. So we decided to go for a thoracoscopy. So we did a thoracoscopic pleural biopsy performed, and the histopathological examination revealed a PET-C moderately dense chronic inflammatory exudate with fibrinoid necrotic material. The predominant cell on the biopsy were histocytes, lymphocytes, plasma cells, and few macrophages in the background of granular debris. No evidence of any malignant or granuloma. So this was the biopsy slide showing a fibrinoid necrosis. Then, since a patient already had a history of joint pain, we did workup for a connective tissue disease. The RA factor was positive, 56. The NTCCP was positive. ANA and ANCA were negative to the other CTDs. Then pleural fluid, also we did a C3 and C4 level, complement level in the pleural fluid. So, taking into the consideration of this recent investigation report of positive RA factor, NTCCP with a high SR CRP level blood, with a pleural fluid report showing a low PS, low glucose and high LDH, and low complement level in the pleural fluid, a provisional diagnosis of recurrent effusion due to underlying rheumatoid etiology was made. Patient antitubercular drug was stopped. We put the patient on prednisone and other DMRTs. HUQS was added, and patient was gradually follow up. And after 2 month follow up, patient symptomically improved with steroid and DMRTs, and repeat X-ray shown reduction in effusion, clinically better. So basic purpose or point of this thing is that pleural effusion or recurrent effusion maybe come from a different etiologies, and particularly we got a lots of CTD patient, and rheumatoid arthritis is one of the very peculiar characteristics. It's sometimes because of the low sugar we may think that this kind of effusion may be paranormal effusion or an empyema also. This confusion with the empyema is very common in this kind of effusion because sugar is all below 40, always indicating an empyema. Sometimes we made without proper evaluation we may drain the fluid, or sometimes this kind of patient may be advised for doing this decortication also because of the empyema. So that's why the important point is that we should look into the complete clinical picture as a whole, so that we should not miss out. This is an uncommon presentation, but a very classical presentation. So the classical picture of a pleural fluid in rheumatoid will be a yellow green thick cloudy appearance of fluid. Sugar is usually less than 60, pH will be low, which is matching with the empyema. Protein will be high. This is again favoring empyema, but LDH will be high also in case of empyema will get in. But cell type here will be high WBC with predominantly lymphocyte, not neutrophil, which is we get in empyema. Microorganisms are usually negative, but we may get sometime if there is a associated secondary infection. Biopsy finding is classical, where we can show a rheumatoid nodule, which is very characteristic of this, and that give a very clear diagnosis, and that where we can give a very specific therapy and better outcome. So now my question to the panelists is what are the common causes of recurrent pleural effusion, and how we should approach this step-by-step approach so that we can diagnose the common and uncommon presentation of pleural effusion.
But I want to just clarify one thing. In a tertiary care hospital, it is all right. But in periphery, when you get this type of case with joint pain, at least do the RH factor, which is positive, anti-CCP done, because after doing all these things, the everything is solved with a prednisolone. So before going to this, we should treat it at periphery. If it is with steroid, because there is the joint pain is there. If it is not respond, antitubercular is must in this case. If it is not response with steroid also, then you send this case to tertiary care hospital where thoracoscopy is done. This is one message actually.
Actually, sir,
This is a message from a senior pulmonologist. I agree with you, but I have a point to Kripesh. Will you let me know, did you solicit the opinion of rheumatologist?
Yes, definitely, sir. We took an opinion from rheumatologist.
My point is that since you have diagnosed it as a case of pleural effusion of rheumatoid origin, DMRDs were not opined.
Yeah, it was added, DMRDs.
You mentioned only about oral steroids.
No, DMRDs also added.
The other thing is that pleural effusion is like a magic box. What will be, we don't know. Because in rheumatoid arthritis case also, pleural effusions become sometimes 1,000 to 2,000. And same thing in case of parapneumonic effusion, one criteria is there. If the pleural effusion is 2 to 3 times higher than the normal level, it is a case of parapneumonic effusion.
And
so
also,
these things all come in mind, but if we think more, then it is very difficult to treat any case.
So one thing I want to add in this case, you have done already thoracoscopy and pleural biopsy. Did you go for tissue CB0 or tissue TB culture in this patient? Already you have done the biopsy.
That culture report and CB0 was also negative in this patient. So we run all possible etiologies.
Regarding here also, if you send the tissue for CB0 or all this, not send in the, as usual in the formaldehyde solution, you send it in the normal saline. If you send it formaldehyde solution, the bacteria will die. This is for a
sensitivity and specificity of these particular samples are very low compared to the sputum. Pulmonary sample, it is higher. It is high. Comparatively, it is higher. You want to say something, Nirban? Yes.
Actually, in thoracoscopic, if we get a tissue sample, then the CBNAT sensitivity as well as the specificity increases compared to pleural effusion or sputum.
Your point was about the causes of rheumatic.
Yes. No, my point is how we should approach this kind of patient who present with recurrent pleural effusion, and what are the stepwise approach so we can make a proper diagnosis.
To summarize,
recurrent.
To summarize it, if we have the causes, it will be the common causes will be either TB effusion, parapneumonic effusion, then malignancy, then even transulative effusions like congestive heart failure. This also can present with recurrent effusion, but this is an exudative effusion, so the bottom list is almost crossed out. So the stepwise approach will be to get a thoracosynthesis done and then repeat the procedure thoracosynthesis. And if we still don't have a final diagnosis, then we should go ahead with thoracoscopy if available. That is what I am saying.
Excellent. Any more input from the
Common cause of
audience or this
there
participant?
may be transitive or exudative. These are we know congestive cardiac failure. Renal cause is the nephrotic syndrome. Then we come to this malnutrition. In MAC syndrome, sometimes we may get it, but some say sometimes we get exudative, sometimes it's transitive. So malnutrition we have told, no?
And CLD, recurrent pleural effusion,
cirrhosis of liver. These are the, and on the other hand, any causes tuberculosis, malignancy, connective tissue disorders, then even some drugs, all this produces the bilateral pleural effusion. Even after surgery also, there are so many abdominal cause also. Like in pancreatitis, usually we get unilateral, but we get bilateral also. Like that in liver problem, usually we get unilateral, but sometimes it may be bilateral. So from abdominal cause also, if there is peritonitis, even after peritoneal, there is also. We should keep in mind, and maximum if the patient is having the malignancy, then see whether patient is getting the AC inhibitor drugs or not, tyrosine kinase inhibitor. And destiny is the drug where pleural effusion is common. I have seen so many cases, pleural effusion. Just ask malignancy case, see whether you are taking this. If he is taking destiny, then it is due to the drugs. It may present as usually exudative, sometimes transitive. That is another message.
And sometimes I think sarcoidosis may be a factor.
Yeah,
Yes,
exactly.
sarcoidosis sometimes we get, but previously it was that if we get pleural effusion in sarcoidosis, it is not a case of sarcoidosis.
Though it is
now
uncommon.
its concept is changed.
If less than 2-3% only. So basically, we may have a recurrent effusion because of a transudative or exudative type, infective or non-infective things. And even if we do a stepwise approach or pleural synthesis or a thoracoscopy, after that also 10 to 15% case will remain undiagnosed. These cases basically require a follow-up. And most of these undiagnosed cases on later on may come out to be tubercular or malignancy. So basically in pleural effusion, we need a stepwise approach and we need a very close monitoring. Sometimes diagnoses are very confusing. After initial treatment, we can follow up and review our treatment and diagnosis as well. So now, not wasting time, we're going to the second case. This is a 26-year-old female present with a history of cough and chest pain, a low-grade fever and weight loss. There is no history of diabetes or hypertension. In previous consultation, doctor investigated and found right pleural effusion. Pleural fluid analysis was done, which saw a total count of 1800, which was lymphocytic predominant, protein was 5.6, sugar 88, culture was negative, AFP smear was negative, AD was 79, malignant cell was negative, gene expert was negative. So based on this report, patient was started on anti-tubercular drug. So this was the initial X-ray of this patient. Then after taking 1 month of anti-tubercular drug, patient still symptom are more or less same, and we didn't chest X-ray again. So again, this more or less the same symptom persist. And then we have decided to go to do a CT thorax to find out any other underlying pathology is there or not. So CT thorax also showing this moderate amount of right-sided pleural effusion. So what is the opinion of the panelists that what we should do in this clinical scenario?
Sir,
Because patient, if you see, look in the pleural fluorescence, AD was quite on a higher side. It is a lymphocytic exudative, and clinically it looks like a tuberculosis, but patient is still not responding.
See, the patient is young lady. So we have to rule out connective tissue disorder here. Here we have to think about SLD.
Exactly.
Then, though we are giving the ATT, though all these tuberculosis findings are negative, and we can go for pleural biopsy here. Here, thoracoscopy is important, but before that, you rule out connective tissue disorder as this is a female patient.
Exactly. Any opinion from the other panelists?
This case is very important because just I have told that if the ADL level is more than 70, it is usually tubercular. In that case, ADL level is 79, no?
79.
TCS, lymphocyte predominant 80%, female 23 or 25 years. So in that case, we will give the ATT first. based on this, because we should justify why we are giving the drugs. We will give the HCG and we will do the further follow-up this case. But in further follow-up, after giving up HCG for how many days, it becomes again, it is increased. So in that case, we should keep in mind that whether we will do the thoracoscopy or not, because in that case, we do for the invasive procedure, like pleural biopsy or thoracoscopy. But thoracoscopy is easier.
I have a point here. Initial finding of pleural fluid suggests tuberculosis. Origin AD is high, lymphocytic, exudative. Are we dealing with a drug-resistant tuberculosis?
Exactly. So there is a possibility of drug resistant tuberculosis also there, and it can present with this pleural effusion which is not responding to a standard anti-tubercular drug.
So previously I told that maximum cases is written that cases of pleural effusions of tubercular in origin, mainly drug resistance. Without doing the culture and sensitivity, we cannot label that it is a drug resistance tuberculosis. So how will you do the culture and sensitivity in that case? In pleural fluid, if we get the CBNAT is not negative, CBNAT is already negative. If positive, we can see the at that time, the same time, rifampicin resistance. Now, not only rifampicin resistance in CBNAT, we can see so many the newer advancements machine is coming. We saw so many drugs are there. So there we can be sure. But if it is also negative, then the problem is coming. So we should do the tissue culture. And for that reason also, now thoracoscopy is necessary. If we think, otherwise no. If we get the CBNAT is positive, then our problem is solved.
So this base.
Yes. Coagulam. That's whether it is here or not on physical examination.
That is not there during physical examination.
Actually, when the protein is more, we get the cobweb type of coagulation. This word of in previously when we were the students, it was thought. Even it was thought that you give anti-tubercular drug with steroid. So in that cases, in first cases, no need of doing thoracoscopy, anything. Give anti-tubercular with steroid. Patient will relieve within 2 months, but we don't know whether it is due to the steroid or the anti-tubercular drugs. But after 6 months, we will write the cure. Patient is also happy because it is treated in their local area. No need of coming to Guwahati or to Vellore or Delhi. So sometimes the teaching is very good. And another thing is that 80% is diagnosis still by the history. So we should always give importance in the history, like the first case. In that case, something complicated I have seen.
Yeah, exactly. In this patient, this repeat pleural fluid analysis is done. It was also showing the almost the similar characteristic. And rheumatological or any CTD test was not done because there was no clinical features in this patient.
Sir,
so we
was the patient HIV negative? Because iris also
yes,
can.
so second time since patient was not responding, this immunological test was also done. It was negative.
Sir, in a female patient, prolonged fever, like coming to you with pleural effusion, not evidence for any tuberculosis, you have to think about connective tissue disorder SLE, because SLE is presenting with many ways.
Yeah, exactly.
They may not have any joint pain.
Exactly. So since it was not initially classical presentation was not there, so we have decided to do a repeat thoracoscopy. It was also not conclusive, so we have to decided to go for thoracoscopy. So we went for a thoracoscopy. And
another point I have just told regarding this, to evaluate pleural effusion in connective disorder, especially the rheumatoid arthritis, it takes 6 months to years. But in case of SLE all, it takes a more time, even years. But important thing is that sometimes if it become only pleural effusion, maybe the presentation, but it is a very rare presentation. It's important.
Yeah, exactly, sir. So indeed, in this case, we have decided to go for this thoracoscopy. So this is the left side thoracoscopy picture, and this is the biopsy picture. So any comment from the panelists about the thoracoscopic finding?
So we see a lot of nodules in the when I see to the apex of the lung, I see a lot of nodules, mostly in the parietal pleura as well as in the visceral pleura as well. So a lot of nodules are there. And when I go to the histopathology side, I see a lot of something like glandular picture forming, and as well as a stromal picture. So mostly in a female. So the chances of adeno-CA will be much higher, although immunohistochemistry will be better to say if it is adeno-CA or not.
Exactly. So
Circular pleural effusion, if we do the thoracoscopy, it will be take the Sagudana appearance. La Sagudana, typical picture. If we go get the Sagudana appearance, then it is 100% confirmatory. Biopsies must. Regarding this, there is mucinous infiltration also, no? Some
There is
nodular cells are hyperchromic also, nucleus. So it goes in favor of carcinoma. Usually in adenocarcinoma, we get such type of picture. But this patient is 26 years, female 26, no?
26.
Adenocarcinoma, it is actually unlucky.
So here, this diagnosis on histopathology was given with adenocarcinoma, and we sent for EGFR and ALK mutation. EGFR mutation was positive. Patient was started on a zefitinib, and patient improved over a time. So the malignant effusion is another common way which can present with a recurrent pleural effusion. So the question to the panelists is, what are the options for managing recurrent malignant effusion?
Now, regarding this zeftinib, actually when we will see the EGFR, but we are going something different from here actually. So in that case, what when we will see the in EGFR, we see the axon 18, 19, 20, 21 like that. 19 is very much sensitive for this one, zeftinib. 21 is highly not highly sensitive. Then we can give the another that is alphatinib, no? Or not. But most important is the ostavitinib, which penetrate the CNS. If it is available, we can give. But zeftinib is available in many of the cancer hospitals. So zeftinib is a good drugs. Or others only give the orlitinib. That will be best. But I have not seen much more difference in both orlitinib and zeftinib.
Diagnosis of adenocarcinoma is made, but lung parenchyma showed nothing. What is the primary then?
In early stages, you may get may not be able to find many early changes in the parenchyma. It may present with a primarily pleural adenocarcinoma also.
Maybe it's from breast or stomach.
Other imaging was normal. There's no clinical finding to suggest this. Primarily, it can also happen in pleural also.
Really common thing is the lung, then breast, then we can get from
Even
others.
most of the time, adenocarcinoma
But sometimes we get
simply
directly
present
in
as a
the pleural
consolidation
effusion
also.
without any cause. That thing happening here, no, without any primary site.
Even in 10% of sir, in 10% of it can present directly with diffusion, and then adeno-CA, as sir has said, that it can present with a lung, or sometimes even what we call is a cups carcinoma unknown primary site, where we do all the imaging, nothing is detected. So what sir was saying regarding the mutation, we generally, whenever EGFR comes, we go ahead with the mutation analysis, and then if there is specific mutations are there, only then we start with first line therapy. And if there are specific mutations like exon 19 deletion, in those cases we newer studies like Flora, Adora, in which they had seen that third line EGFR inhibitors, mostly what is called as osimertinib. Osimertinib becomes the drug of choice, as well as in those studies where they had seen that in effusions or mass with brain metastasis, osimertinib has the most progression-free survival, overall survival. So in terms of all those, so osimertinib becomes the drug of choice in exon 19 deletion.
Osimertinib actually penetration of the CSF level is very, very high. But osimertinib is highly costly.
Sir,
highly costly.
Cost of therapy.
Yes, that is important because our
around
person will
6,000 per month.
Yes, yes.
But osimertinib will go more than
around 1 lakh per
1 lakh per month. So the cost of this
is
thing
1 lakh. Yes, osimertinib is guessed. But I request to all of you, because secretary, organizing chairman is not officially declared.
Organizing chairman is Jogesh Sharma sir.
Also, he is declaring, but so I request to all of you to register, and there are so many persons of the ICS member, and that is actually product of both. Our NEPCON is now two, one and second. There is a step brother is also now there. So both brother and step brother, दोनों मिलकर now आ गया हमारा CC1. So member of NEPCON 1, 2 both are there. So that will be held in Guwahati. We are lucky actually. So I invite to all of you, though I am not become a chairperson also, yes, organizing president, no?
Yes.
So I request to
Is
all
there
of
any
you, but it
provision
is not
for
free.
early bird registration?
Yes,
Yes,
this will
certainly.
be announced
There will be.
within month of January.
Acha, acha.
There will be around 800, 900 delegates will be from outside. And I request to all to participate this time.
So with this, I would like to, in the capacity of chairperson, I would like to say thank you, dear panelists, and also to the speaker, Dr. Kripesh Ranjan Sharma, and also to my co-chairpersons. So I conclude the session in the capacity as chairperson. Thank you all. Now we will proceed to the last part of the this particular mega event, that is valedictory function.
Thank you, ladies and gentlemen, for your for your patience and active participation. Before concluding, I would like to invite Dr. Jacqueline Shira, ma'am, to announce the results of poster and paper presentation contest.
Good afternoon, everyone. I hope all of you enjoyed this mega event, Epicon Assam Chapter 2025. We now move on to the most awaited segment of Epicon Assam Chapter 2025 by the PG students, that is, the poster and paper prize announcement. To present the prizes and certificate to our winners, it is my privilege to invite our respected senior faculty and mentor, President of API Assam Chapter, Dr. Anup Kumar Das, onto the stage. I request sir to kindly present the prizes to the student. May I request everyone's attention as I announce the winner of the free paper presentation competition. The third prize for the paper presentation goes to Dr. Shabnam Fardos from Tezpur Medical College and Hospital. Dr. Shabnam Fardos, may I kindly request a representative from Tezpur Medical College to take the prize on behalf of her? The second prize for the paper presentation goes to Dr. Rupankar Nandi from Assam Medical College and Hospital. Dr. Rupankar Nandi, is he there? Okay, someone from AMC can receive his prize on behalf of Rupankar Nandi. And the first prize for paper presentation goes to Dr. Sajid Sikdar from Assam Medical College and Hospital. Dr. Sajid Sikdar, We now move on to the poster presentation award. The third prize for the poster presentation goes to Dr. Twinkle Agarwal from Jorhat Medical College and Hospital. Is Twinkle Agarwal present here? Can anyone from Jorhat Medical College who can receive her award? Nobody. Okay. The second prize for the poster presentation competition goes to Dr. Mugilan Venkat from AIMS Guwahati. Dr. Mugilan Venkat from AIMS Guwahati. Anybody from AIMS Guwahati? The first prize for the poster presentation goes to Dr. Mekibul Islam Farzi from Borpeta Medical College. Dr. Mekibul Islam Farzi. A big round of applause for Mekibul Islam Farzi. Borpeta. Have sir. Yes, sir. Yes, sir. It's done, sir. You can take your seat. Now, with your kind permission, I now hand over the mic to Dr. Vikrant Sharma for the further proceeding. Thank you.
To formally conclude this session, may I kindly invite all the esteemed members of organizing committee to join us on the dais. May I request all the esteemed members of this organization to join us on the dais. Let's welcome them with a big round of applause, please. Now, may I invite our respected chairperson, Dr. Mihir Kumar Goswami, sir, to speak a few lines on behalf of the committee.
No doubt, I would like first to thank all the esteemed delegates who have graced this mega event. 2.5 years ago, it was a dream. It was a dream that API Nagaon branch will host a mega event of this magnitude where more than 500 delegates attended and graced and participated and debated on each moment. And it was a dream which has been turned into reality. Not by me, by all the members. So a big hand of applause for all the esteemed member of this hardworking, dedicated, sincere team. So I would like to thank my team who have worked day and night. দিনক ৰাতি কৰি কপালৰ ঘাম মাটিত পেলাই নিজৰ প্ৰেক্টিছ বাদ দি বহুতখিনি ত্যাগ স্বীকাৰ কৰি যিখিনি কাম কৰিছে যিটো অসম্ভৱক সম্ভৱ কৰি দেখুৱালে তাৰ কাৰণে তেওঁলোক ধন্যবাদৰ পাত্ৰ দ্বিতীয়তে মই যোৱাকালি সন্ধিয়া যিখন সভাত যিটো কথা কৈছিলো পুনৰ আজি সেই কথাটো মানে দোহাৰিব খুজিছো যে মোৰ গীতৰ সভাৰ তুমি এইটো অলংকাৰ যিসকল ডেলিগেট এষ্টিম ডেলিগেট যিসকলে ইয়াত আহি তেওঁলোকৰ বহুমূলীয়া সময় দি আমাক কৃতাৰ্থ কৰিলে তেওঁলোককো মই ধন্যবাদ জ্ঞাপন কৰিছো তৃতীয়তে আমাক যিসকলে সহায় কৰিলে
সেই দায়িত্বটো মই গোটেইখিনি নাম মানে বিতংভাৱে উল্লেখ কৰিবলৈ মোৰ সহযোগী ডক্টৰ শৰৎ কেওট তেওঁ বিশদভাৱে ক'ব কিসকল ব্যক্তি বা অনুষ্ঠানে আমাক সহায় কৰিছে তেওঁলোকক মই ধন্যবাদ জ্ঞাপন কৰিছো চ' it is a day of fulfillment for us আজি আমি এটা সন্তোষৰ বা তৃপ্তিৰ হাঁহি মাৰি উশাহ এটা ল'বলৈ সক্ষম হৈছো যে আমি এফেৰা কাম কৰিলো আৰু আমাৰ এই যাত্ৰা অব্যাহত থাকিব ভৱিষ্যতলৈকো চ' I would like to say the word the victory to API Naga branch Assam. Thank you.
Wait a minute. So, okay. So last part. Thank you everyone for joining Assam APICON 2025. Respected distinguished faculties, all the chief office bearer of API Assam chapter, and all the delegates and dear friends. As we are to the close of the Assam APICON 2025, it gives me great pleasure on behalf of the organizing committee to offer a few words of gratitude and reflections. Over the past 3 days, we have had an excellent academic experience with high quality scientific sessions, insightful deliberations, and active participation from delegates across the state. We are really thankful to all the faculties, delegates, and special invitees. My heartfelt thanks goes to the scientific committee members who have so nicely tailored the scientific agendas in spite of all the hiccups. And also my thanks to all the subcommittee members and all the members of API Assam Chapter Nagaon branch for their active participations. I also thank postgraduate students who have participated so enthusiastically, and I would like to special mention our post PG coordinator Dr. Jacqueline Disida, who has done a great job coordinating the PG program. Next, my heartfelt thanks goes to the academic partners, all the farmer groups who have supported us wholeheartedly throughout the conference, and we are really in-depth to you. We are really thankful to you. With this word, I would like to conclude my short speech. Thank you, everyone. Thank you, API. Long live API. Long live Assam Chapter. Assam Chapter. Thank you. No. Now I would like to now I'd like to request our one or two of our co-organizing committee member to speak few words. Sir, 1 minute. Go ahead. Just say one few words.
উপস্থিত থকা সকলো ৰাইজক নগাঁওবাসীৰ ফালৰ পৰা মই ধন্যবাদ জনালো মই নগাঁৱৰ এজন জ্যেষ্ঠ চিকিৎসক আজি এই কনফাৰেন্সখন মানে ভালদৰে পাতিবৰ কাৰণে মিহিৰ গোস্বামী শৰৎ কেওট নগেন ডেকা কৰণ দলে তেওঁৰ পৰিবাৰকে আদি কৰি সকলোৱে যথেষ্ট সহায় কৰিলে অৰূপ চৌধুৰী দিনে ৰাতিয়ে লাগিছে দুই এটা নাম হয়তো মোৰ বাদ পৰি যাব পাৰে আগলৈও এনেকৈ আমি নগাঁৱত যাতে কনফাৰেন্স পাতিব পাৰোঁ আৰু যিবিলাক স্পীকাৰ আহে তেওঁলোকক মই ক'ব খুজিছোঁ যিকোনো বেমাৰৰ তেওঁলোকে ভাগ কৰিব লাগে ট্ৰিটমেণ্ট এট পেৰিফেৰী ট্ৰিটমেণ্ট এট চিভিল হস্পিটেল ট্ৰিটমেণ্ট এট টাৰ্চাৰী হস্পিটেল এই তিনিটা ভাগত ভাগ নকৰিলে all doctors are not benefited. So I request the speakers to divide the topic how to treat at periphery or primary health center, how to treat at district hospital, how to treat here. Suppose এতিয়া যদি ইয়াত কোনোবা এজনৰ হাৰ্ট ব্লক হয় 20 pulse, what you will do? হয়তো বহুতৰে কনফিউজন হৈ যাব আমিবিলাকে কাৰ্ডিয়াক মেছেজ কৰি অৰ্চিবেজ দি পঠাই দিওঁ কিন্তু লাৰ্ণ যিবিলাক প্ৰফেচাৰ আছে তেওঁলোকে এইবিলাক চিটুৱেশ্যনটো ফেচ নকৰে ইয়াৰ পৰাতো গুৱাহাটী পাবলৈ আপোনাৰ 8 ঘণ্টা লাগিব মই বহুত পেচেণ্ট কাৰ্ডিয়াক মেছেজ দি গুৱাহাটী পাইছোগৈ বহুতৰ হয়তো এইবিলাক এক্সপিৰিয়েঞ্চ নাই আমি 79 পৰা প্ৰেক্টিছ কৰিছোঁ আই এম এ পোষ্ট গ্ৰেজুৱেট অফ আছাম মেডিকেল ফ্ৰম 1978 I like today the speech of Dr. A দাস তেওঁ যিখিনি কথা কৈছে এইখিনি কথা প্ৰফেচৰ মিহিৰ গোস্বামী হেৰি প্ৰফেচৰ ব্ৰজমোহন গোস্বামী আৰু প্ৰফেচৰ মথুৰা মোহন গোস্বামীৰ কথা তেওঁলোকে কৈছিল ইউ ৰিড দি হিষ্ট্ৰী প্ৰপাৰলি ক্লিনিকেলি এক্সামিনেশ্যন এতিয়াৰ ডাক্তৰসকলে উদ্যোগ চিধি ইনভেষ্টিগেশ্যন বহুতে হয়তো পেচেণ্ট টাচ নকৰে ক্লিনিকেলি টাচ কৰি লওকচোন গতিকে এই জ্ঞানটোও আপোনালোকে সকলোকে দিব আৰু পেৰিফেৰিত কেনেকৈ মেনেজ কৰিব আজিকালি গুৱাহাটীলৈ ৰেফাৰ কৰিলে কেছ এটা আপোনালোকৰ মেন এণ্ড মানি লাগে পইচা হ'লে মানুহ নাই মানুহ হ'লে পইচা নাই গতিকে ঘপককৈ পেচেণ্ট এটা যাব নোৱাৰে ফাৰ্ষ্ট এড কেনেকৈ দিব হাউ টু মেনেজ এ কেছ অফ একুইটেমা ইন লংকা ইন যমুনামুখ সেইবিলাকো আমি শিক্ষা স্পীকাৰবিলাকে দিব লাগে প্ৰায়বিলাক চেমিনাৰতে টাৰ্চিয়াৰী হস্পিটেলৰ চিকিৎসাৰ কথা কয় অল ৰাইট উই শুড ন' হোৱাট ইজ গোয়িং অন ইন দি ৱৰ্ল্ড বাট উই শুড ন' হোৱাট উই কুড ডু এট আৱাৰ লেভেল উইথ দিজ ৱৰ্ডছ আপোনালোক সকলোকে মোৰ আন্তৰিক ধন্যবাদ দি নগাঁও এই কাৰোলৈ একো বাকী নাই কিবা যদি আমাৰ দোষ হৈছে আপোনালোকে নিজ গুণে মাৰ্চনা কৰিব প্লিজ এক্সাৰচাইজ ফৰ আৱাৰ এনি অমিশ্যন এণ্ড কমিশ্যন উইথ দিজ ৱৰ্ডছ আই কনক্লুড মাই টপিক
From the audience, sir, Zuga Soma, sir, please come, sir. Thank you.
So it is very difficult to address everybody. So respected Unubda, respected Virinsida, then Nogenda, then our beloved Horat, Urup, and I don't know all the members, but all the members of the organizing committee, and that is a very good trend that everybody is coming here in the space. Our respected Disar, Thirazda, this is not the valedictory function. That is actually a milestone of the knowledge, discipline, and transition. And transition, in that sir has already told so many things, Virinsida, what the problem is faced in the and that is not the ending, that is the beginning again for the this next time is the Tinsukia. So I thanks to all of them, very good academic piece, very good, and better to use the term excellent, and hospitality is very good, and everybody will give it in the now WhatsApp, and you will give that thanks from the organizing committee. But on behalf of the audience or from the delegates and faculty, I thanks to all of you for a very good academic, very good piece, very good hospitality, cultural function, everything. There is no, and another thing is that they are arranging sometimes the midterm also CME. That was also very good and exceptional 2 times. Everything is fine actually. So on behalf of the audience and especially from myself, I thanks to all of you. We cannot forget this. With this memory, we will go to our places. I thanks to young generation also. Yes. That is also for that reason I am telling the word milestone. This is the milestone of discipline, knowledge, and learning. Everything is there. There is transformation to transition, like ebook, etc. Again, thanks to whole team, with from my heart actually and soul, really.
Lastly, I would like to request our API Tinsukia branch member to come to the dais just to will hand over our API flag to them officially for the next conference. Oh, yeah. Aru, lastly, another point, just we will keep ready. 1 or 2 of the pharma group partners, academic partners, please come forward and have a just one word of encouragement for us. We are inviting everyone.
Thank you so much. On behalf of Tinsukia branch, I am Dr. Chandan Sharma. Invite you all for 2026 APICON Assam chapter, that is the 35th APICON, and wholeheartedly invite you all. Thanks so much.
Thank you.
Is there anyone from the